today's session with the thoracic trauma. Professor Shailen Kumar sir will be presenting this lecture. He's
Good morning,
a head
everyone.
and professor in the
We are going
Department
to
of
start our
Cardiothoracic
today's
Surgery at
session
our institute.
with the
He has
thoracic trauma.
extensive experience in performing
Professor
wide
Shailen
range
Kumar
of
sir
cardiac
will be
and thoracic
presenting this
surgeries.
lecture.
He's
Sir,
a
welcome,
head
sir.
and professor in the
Thank you.
Department of Cardiothoracic Surgery at our institute. He has
Thank you.
extensive
So,
experience in performing wide range of
the
cardiac
thoracic
and
surgery.
thoracic surgeries.
So, cardiothoracic surgery
Sir,
now
welcome,
has
sir.
the, I think, three divisions now. Thank you. So, the thoracic surgery. So, cardiothoracic surgery now has the, I think, three divisions now at KGMU. So, thoracic trauma, so important. Thoracic trauma, important because it consists of around 10 to 20% of the all of the trauma, and maybe the death. The important is that if you see, if you examine, if you manage the things in a nice way, you can prevent this death due to this thoracic. One, I think, Kulsesta et al. About 2 years back, in his series of 1359 cases. So, the maximum cases of rib fractures, flail chest, U 2.1%, and external fracture and dislocation about 5.4%, and second largest series will be the pneumo or the hemothorax, that consists of about 20.4%. Major vascular and tracheobronchial injuries are naturally uncommon, and that has not been recorded, may not be included, or may not have that time the cases came when the study was going on. So, why this is important? Thoracic trauma management, because it is a devastating injury with high morbidity and mortality. The important thing is that all the symptoms and signs you see, all are sub its internal organ. So, we have to evaluate very cautiously. So, there must have the overall setting, overall, I think, examination, and especially the critically ill patient needs more attention and diagnostic evaluation. So, naturally it is not different from the any injury, any trauma. So, it must follow the ATLS algorithms, which must be followed, and the role of thoracic surgeon in very specific. Actually, the trauma surgeon, especially you people posted in the trauma in the general surgery, or now the trauma surgery has now at the some centers they have developed trauma surgery different at the as a separate aspect. But you people must know and may be posted there, you have to manage that. So, mechanism of how it happens, like blunt injury or maybe penetrating injury, or sometimes both. So, and what are the organs involved? Like all the organs inside thoracic cavity, like thoracic cage, cardiovascular, the naturally pleural or the pulmonary, mediastinal, sometimes mediastinal, diaphragmatic, sometimes esophageal, and penetrating cardiac. Especially, it is different because of all of the injuries. You know that it is very different. One incident happened here recently. There was a stab wound penetrating the left ventricle, and the patient survived after I think the management. So, why how it affects the patient? Like it has the chest excursion compromises, like pain itself, and the movement, maybe the bleeding inside, ineffective diaphragmatic contraction, all can lead to the, I think, insufficient ventilation. So, and the result is that there may be atelectasis, maybe the pulmonary contusion, or maybe respiratory tract disruption sometimes. So, the important is that you have to first identify the very, I think, life threatening conditions like open pneumothorax, flail chest, tension pneumothorax, massive hemothorax, cardiac tamponade. So, all can lead to the condition like apnea or respiratory thoracotomy. So, this is the situation when you see there are certain conditions when you have to act very, very fastly, even not equipped with all the instruments, all the scenarios. like unresponsive hypotension. The hypotension is not responding. So, even after medication, rapid exertion, rapid blood loss, more than 1500 immediately or 250 ml per hour for the next 4 hours. Traumatic arrest with previously witnessed cardiac activity, means there is cardiac activity, maybe the history or during the treatment course you see there are cardiac activity, but now there is arrest, but you have to act very fastly and cardiac tamponade. So, these are the scenarios where you have to do department thoracotomy. Now, the purpose of the thoracotomy is to evacuate the pericardial tamponade, or you have to evacuate that very fastly, control hemorrhage if there is major bleed is there. Open cardiac massage, sometimes I told you that if there is arrest you have to do the cardiac massage. Cross clamping descending aorta, when suppose there is extreme blood loss, there may be so brain is at risk of the blood loss, I think the supply. So, we have to cross clamp the aorta, descending aorta, limit subdiaphragmatic hemorrhage. Suppose there is hemorrhage is I think below the diaphragm, then you have to again you have to cross clamp to limit the loss and repair the major air leak sometimes, that is also the problem. So, you see the signs of vascular injury. So, you see the widened mediastinum, you see itself mediastinum is widened, loss of cardiac knob shadow, the widening of the paraspinal stripe, the stripe is clearly here, but it is there is loss, downward displacement of the left bronchus, you see this is the bronchus has displaced downward, and obliteration of aortopulmonary window, you see here is the aortopulmonary window that has been lost. So, these are the signs on the chest X-ray, because we do not have time to go for the CT scan to confirm that. So, other features like fracture, first rib, sternum or the scapula, these are the features, these are the signs which show that there is the collision is very significant, we have to act very fastly. Multiple rib fractures leading to flail chest or like that, and massive hemothorax itself I think indicator of fast action. So, when you do not do I think thoracotomy in emergency department, so if the CPR has been done for more than 15 minutes, so even after effort or even a blunt or the penetrating whichever injury, multiple blunt trauma at the multiple site. So, you see the prognosis is grave and there is severe head injury, in those conditions you have to avoid that. So, in I think you see the total of you see the survival rate. So, I think death rate is quite high. So, it is overall is 6.1% only. So, in penetrating trauma it is 5.8 and blunt is 0.44, means blunt injury is more serious than the penetrating injury. So, rib fracture is commonest one, I told you. So, the symptoms like localized pain like or the pneumothorax, that have to be managed accordingly. So, you see the first and second rib fracture is I think have the quite impact. So, it is very taken very seriously, maybe the internal injury, the vascular injury or the parenchymal injury, lung parenchymal injury, that, and you see people will die with this type of injury. So, if the lower like the 10 to 12th rib fracture is there, maybe chance of liver, spleen or the kidney injury. So, you see there is the fracture, I think the rib fracture here. So, most heals in management point of view, mostly heal, you have to take care of the pain. Pain is the main issue which has to be taken care of. So, good analgesia, maybe some people do the epidural anesthesia, I think epidural catheter and putting the anesthesia. So, you have to manage opioids are important. So, flail chest is a condition where there is the two segments more than 3 or more than 2 ribs involved at the two sides, and which do not have attachment to the other cartilaginous or the osseous part of the rib cage. So, in those scenario you see here the fracture here and fracture in the I think at the two sides simultaneously. So, I told you that there is no bony or the cartilaginous connection that moves independently of the chest wall, that is called the paradoxical chest movement. So, the symptom is depending upon how much segment and how much ribs are involved. So, and these are the findings like the bruising or the crepitus, tachycardia, hypotension depending upon the internal injury also. So, you have to take you have examined, and the complications like the hypoventilation or the mediastinal flutter. So, we have to act very fastly, like investigation, like very simply chest X-ray will tell lot of things, and ABG to examine the situation of the ventilation. So, the management is suspect the other injuries in addition to the chest injury. So, the treatment the treatment gold standard of treatment is I think the positive pressure ventilation. So, you have to see the ventilation is there hypoventilation or not. If the patient is not having the proper ventilation, you have to act and you have to do the positive pressure ventilation. And the one issue is that whether the stabilization of the chest wall is needed or not. So, the chest wall stabilization recently has been in practice in the many centers. We also had the one series of the patient who did not respond to this medical treatment or pressure ventilation, like the patient is not responding in 4 or 5 days or 1 week, then we had done that stabilization of the ribs and patient recovered. So, the good series of the patients have the advantage of fixation of the ribs. So, external fracture is naturally uncommon, you see here. So, management is mostly wait and watch mostly. So, if especially when there is suppose there is large movement difficulty, movement on the respiration or the severe pain or large distraction, lot of gap or the multiple fractures, in those cases you have to act, and we did also so many cases of the external fracture, I think stabilization. So, pulmonary contusion is another scenario which is very common. So, with all type of the injury, so with the rib fracture or the any type of blunt or the penetrating injury you see here. So, naturally the pneumonia, the sometimes later on may lead to the lung abscess or pulmonary embolism. Pulmonary embolism is a scenario when there is major bronchus and vascular, especially the venous. Pulmonary veins are maybe communication or maybe injured at the same time. Then air embolism is the issue in cases of the chest injury, especially the lung parenchymal injury. Sometimes it happens, so that have to be taken care of. You have to be vigilant. You see on the CT scan, these are the certain bleeds. So, management is supportive treatment. So, you have to watch whether the patient is ventilated properly or not, and you have to act accordingly. So, you see if this contusion is large, that is called laceration. You see here in the X-ray on the CT scan, you see is the scenario is the condition where the air inside the pleural cavity, and that can be open or open and maybe the may have the open pneumothorax or may have the closed, that may be the simple or the tension pneumothorax. So, you see this open laceration here. So, open is the air enters through the chest wall directly. If there is a gap on the chest wall, that sucks the thoracic, I think pleural cavity sucks the air. So, you have to repair that, you have to close that one, and that leading to the ventilation perfusion mismatch. So, you have to cover the open area, assist positive ventilation, mostly they need, and monitor for progression to the tension pneumothorax or pneumothorax, whatever. So, emergently that notes emergent treatment. So, simple pneumothorax for 10 to 30% the blunt trauma, almost 100% with penetrating trauma. So, that will depend upon what type of injury and how much it is, you have to treat accordingly. So, very common with the rib fracture. So, papered bag effect, like the compression, there is sudden breakage of the parietal layer of the pleura, that leads to that is the most common in the blunt trauma, that leads to the pneumothorax. So, sometimes it is exertion and cuffing in normal conditions. So, management is intercostal drainage and naturally to see for the other injury if there is there. So, another condition is the tension pneumothorax, which occurs when there is valve like activity, air enters and does not exit. So, you see here the condition on the right side, the whole mediastinum has been shifted and whole of the right cavity is filled with the air. The another on the left side, you see it is filled and there is this is collapse of the lung. So, the are the certain features, clinical features. So, the patient will be mostly in the very distress, very discomfort, and if you do not act rapidly, may lead to the very bad consequences. So we have to be very vigilant about that. The treatment is immediate. You have to put the needle. So second or third intercostal area. So and later on, naturally, you have to put the intercostal drainage. So, pericardial tamponade, another situation which is occurs in some cases 1 to 2% of the cases. So, you have to there is backstride in this pericardial tamponade, that is the hypotension, sustained hypotension, increased central venous pressure and the quiet heart sound on auscultation. So, other features like the narrowing of the pulse pressure, pulsus paradoxus, where there is pulse is weaker, disappears when the patient inhales, that is the opposite of the what normally physiologically. So, this is the picture of this pericardial tamponade. So, management is you are very fast. So, you have to needle aspiration very fastly, the oxygen have to institute the oxygen therapy and rapid transport to the treating center if your patient is at the diagnosed at the primary center. So, hemothorax other situation you must be knowing. So, these are the other sources of the bleeding. So, you see the intercostal vessels, the lung parenchymal, the bronchial arteries, these are the sites of the bleeding. You see the massive hemothorax. So, these are the features of shock. Naturally, if there is huge bleed and diminished breath sound on the affected side, tachycardia naturally if the bleeding is there. So, treatment is protocol is the same like ABC, you have to take out the blood from the thoracic cavity, you have to put the ICT very fastly, maybe sometime the aortic rupture. So, again the patient may have the dyspnea or depending upon the what rupture and what content has gone inside the thoracic cavity. So, accordingly the symptoms appear and management naturally they establish the airway and assist ventilation if there is hypoventilation. So, fluids and all the management has to be done. So, it is not very emergency, if suppose very distress is there you have naturally you have to operate the case. So, another esophageal injury very uncommon, but sometimes you find you see there is air in the mediastinum here and the the contrast esophagogram you see here the leakage of the contrast in the mediastinum. So, management is established airway again, consider early intubation if possible and IV fluids and other you have to maintain the blood pressure and emergent maybe need emergent treatment, maybe the thoracotomy to repair because the chance of mediastinitis is quite high and mediastinitis mortality in this scenario. So, another condition is tracheobronchial rupture, sometimes happens very uncommonly. So, I have one experience recently of the patient, there was blunt injury chest and the patient has the bilateral pneumothorax. We put the ICD on the both sides, but still there was collapse, it is not recovering well. So, at some event one or after 2 days there was a complete expansion of the lung after 2 days, but after thorax. Then we decided to do the chances of the major bronchial injury. So, there was one rent just proximal to the carina. So, then again intubated and the patient recovered without it. If a small rent is there less than 1 centimeter or 1.5 centimeter. So, put the balloon of this in the the tube, and you can just close it and you can wait for that. So, management is again they establish the airway. So, you see the major bronchus injury here. So, you see the I think the subcutaneous emphysema, and here you see on the X-ray on the CT scan. So, in summary, the chest injuries are common and often life threatening. That's why it should be taken as a whole to examine the patient and identify is there any subtle injury, so that you can manage properly and you can prevent the death. Thank you. Any question if you like to? कुछ पूछना है तुमको? चल, okay. Thank you.
Thank you so much, sir, for your precious time.
कुछ पूछना है
I
तुमको?
request Professor Suresh Kumar, sir, to
Chal.
kindly felicitate.
Okay. Thank you.
Sir. Thank you so much, sir, for your precious time. I request Professor Suresh Kumar, sir, to kindly felicitate. Sir. Our next lecture will be on role of surgery in pulmonary. Next lecture will be on Professor Surgery Kumar, sir, in pulmonary in the department of general surgery. Kumar, sir, presenting in the department of general surgery will be presenting. Specializes in pulmonary surgery. He specializes in pulmonary surgery, highly respected surgeon, highly respected surgeon with a long and distinguished career. Welcome, sir.
Thank you. Thank you. Point. Light. Thank you. Good morning. Today topic is roll up surgery management of pulmonary tuberculosis. डिपार्टमेंट ओल्ड डिपार्टमेंट रिस्पायरेटरी का क्या नाम था? एनीवन नो? टीबी. तो टीबी चेस्ट डिपार्टमेंट सिर्फ पल्मोनरी टीबी देखता था, लेकिन सर्जन कहाँ का टीबी देखता है? आप ऊपर से चलो, हेड नेक की टीबी, चेस्ट की टीबी, एब्डामिन की टीबी, जेनाइटोयूरिनरी टीबी, हाँ, यूरोलॉजी, लोअर लिम्ब. तो ट्यूबरक्लोसिस पल्मोनरी से ज़्यादा कौन डील करता है? सर्जन. तो आप लोग इमरजेंसी में देखते होंगे हर दूसरे तीसरे दिन कॉक्स एब्डामिन के पेशेंट आपको मिलते होंगे. तो वी इन दिस short period we take some your time to teach management of pulmonary tuberculosis by a surgeon. First surgical procedure is performed in tuberculosis is in pleural empyema is open drainage. Thoracotomy nowadays in literature known as window thoracotomy. Nowadays thoracic surgical incidence is increased due to the diagnosis, due to the coming CT scan which diagnosed the post tubercular sequelae. And before the cystoscopy and laparoscopy, thoracoscopy came in 1912 for the diagnosis of the pleural diseases and adenolysis for empyema. These are the some historical background of surgical technique which came first 1895 first pneumectomy was done, and after that in 1950 double lumen endotracheal tube. Most of the surgery is done in the single lumen endotracheal tube, but lung surgery is done in the double lumen endotracheal tube. And medistinoscopy came in 1954 for the diagnosis of the mediastinal disease like maybe lymphoma, and interior mass, maybe sometimes undiagnosed tuberculosis. You know the history of the tuberculosis. First tubercular bacteria is discovered by Robert Koch 1882, and diagnostic modality that time is tuberculin test, and after that before some anti-tubercular drug is came late 1944 and other anti-tubercular drug 1960. Before that tuberculosis was treated by the surgical intervention. These are the way of the transmission. This is the airborne disease tuberculosis. You know the some diagnostic material, sputum, exudate, maybe third space fluid like a pleural fluid and peritoneal fluid for sent for the diagnosis. Nowadays, CVNAT is the most sensitive investigation. Other investigation is the screening, X-ray, chest scan, and bronchoscopy. These are the diagnostic modality for the tuberculosis. These are the symptom, basic symptom. You know, अगर बुखार 15 दिन से ज़्यादा है, dry cough, cough with sputum, and maybe hemoptysis, young male presented in OPD. First thing about the tuberculosis, and these are the some indication of surgery in the tuberculosis. In profuse bleeding, sometimes patient presented with the massive hemoptysis. What are the means of massive hemoptysis? Massive hemoptysis is the more than 500 ml blood came in 24 hours. This need hospitalization, first manage conservatively. If the not stop, then go for the surgical intervention. Other is the maybe sometimes cavitary lesion is the ruptured in the pleural cavity. Patient presented with the tension pneumothorax. This is a dire emergency. Patient needed nowadays when the patient have TDR, totally drug resistant, or MDR, multi drug resistant, when the localized cavitary lesion is involved, patient needed surgical intervention to remove the particular lobe or particular segment to the download the bacterial load. After the these slide, then the come on the complication and sequelae of the tuberculosis, post-tubercular sequelae. The complication of tuberculosis is the pneumothorax, which is the common, maybe pyothorax, and other is the pleural empyema. With or without bronchopleural fistula, maybe sometimes patient presented with bronchiectasis due to the bronchial stenosis vertebra. These are some contraindication when you choose the surgery. These are some contraindication for the pulmonary surgery like impaired pulmonary function test and heart failure, maybe BMI, may other comorbid condition and active tuberculosis. These are the surgery is opted in the surgical in the lung surgery. Wedge resection. What is the wedge resection? This is a type of non-anatomical resection of the lung. When the disease in the periphery may less than 3 centimeter or 2 centimeter needed the wedge resection, non-anatomical resection, and segmentectomy when the segment is involved, maybe sometimes bronchiectasis, maybe sometime patient have some other diseases needed segmentectomy. Lobectomy is the lobe is involved, pneumonectomy may be combined. Window thoracotomy is the oldest procedure of the thoracic surgery. We are doing the modified, we modified some window thoracotomy done in the literature is the dependent site, but we are not doing a dependent site. Thoracomyoplasty is another procedure. We do the two-stage surgery in the tuberculosis. First go for the window thoracotomy, then after that 6 to 1 year, then go for the thoracomyoplasty. What is the most important is the decortication. In our center, most common procedure is done in our department is more than 3,000 cases done in the last 20 years is decortication, only decortication. These are we cover these are diseases which is common managed by the general surgeon, not needed a specialist. And chest wall abscess, this is the bony involvement or the soft tissue involvement. Empyema assistance is the other entity who is the and rib caries, tubercular empyema. These are post tubercular sequelae fibrocavitary lesion, bronchiectasis. These are the lesion cover one by one. What are the chest wall abscess? Collection of pus in the chest wall. What are the risk factor? Is the immunocompromised patient. In the types of the infection are the maybe bone involvement or the soft tissue involvement or the bone or joint involvement. Most common, most of the patient is the coming with the anterior chest wall swelling. In the interior side is the possibly the sternoclavicular area, possibility of the cold abscess tuberculosis, and other is a soft tissue infection in the cold abscess present in the chest wall. See, in the left side there is some elevation and there is the lung is collapsed, partially collapsed, castophrenic angle is obliterated. This is the, and this needed some aspiration for the confirmation of the Mycobacterium tuberculosis. Then go for the further investigation of the CT. This is the same patient. This is the in the right. See, there is the collection is the present in the, sorry, बाइक किधर से हो गई? See, this is the collection is the present in the right side, and this is the air is the present. Somebody is the aspirated. Source of air is the from the outside. This needed, and there is some extension of the pus in the thoracic cavity. Another example. This is the cold abscess present in the anterior chest, and the same patient CT scan is the, so this is the collection, this is the collection, this needed incision and drainage and antitubercular drug. Another soft tissue infection, see, this is the elevation of the soft tissue in the X-ray, see, this is the elevation and this is normal soft tissue shadow, this is abnormal elevation, and same patient the CT scan shows collection of the pus in the soft tissue chest wall as well as in the pre-pleural area, This needs incision and drainage. This is the same patient, and other is the entity is the empyema assistance. Sometimes came in the short note in the exam. What is the long-term complication of poorly and uncontrolled empyema? This is the they erode the chest wall and coming up to the soft tissue. Patient clinically present with chest wall swelling. On examination, this is cystic swelling and compressible, and cup impulse is the positive. Maybe sometime swelling here when patient is the lying down. And cause of the empyema assistance is the most common cause is the tuberculosis, and other is the actinomyces and the fungal infection. And this is the how to diagnose is the X-ray chest and is the and CT scan, and for confirmation send for fluid for the CV naught. This is the collection in the pleural cavity which is communicated. This is the communication which erode the chest wall and going to the parietal area. This is the how to manage. Management is don't give the incision at the bulging side, because this heal and left out the pleurocutaneous fistula. How to manage? Put the intercostal drainage is the remote from the bulging side. This is the, and maybe sometime patient needed a decortication, because in this case this is the pleural, visceral pleura is thickened. This patient not manage only the intercostal drainage, this managed by the carriage rib means is the progressive destruction of the bony structure, and these are the route to occur of the osteomyelitis. See, this is the destructed bone is the present in this. This is the same X-ray, CT scan shows. See, this is the destructed rib. This is the carriage rib. This needed incision and drainage along with excision of the is the both rib. नहीं जा रहा है. Another sequelae of tuberculosis is the common is the our center the Aspergilloma. This is the opportunistic infection. This is the three types of Aspergilloma. One is the invasive type and other is the allergic bronchopulmonary, but aspergillosis is the common is the our center. And patient is the clinically present with the pain and cough, maybe sometime cough with sputum or without dry cough. Both symptom is avoidable, but patient is coming with hemoptysis, this alarming symptom. When patient is come with hemoptysis, previously treated for the tuberculosis, first thing patient have a recurrence of the tuberculosis. Then after, if the AFB is the negative, then patient consider for the superimposed infection, bacterial infection, give the antibiotic. If the patient is not relief symptom, recurrent hemoptysis is the present, then think the patient is the suffering from fungal infection. Which fungal infection is the common is the Aspergilloma. What are this is the invasion and destruction of the parenchymal blood vessels within the cavity leading to risk of the hemorrhage. There is the cavitary lesion present in the post tuberculosis which is infected with fungal, and in the wall there is the microaneurysm is formed. In the due to the irritation, some allergen is released through the fungus, they causes the irritation of the wall and patient is the coughing and rupture of the microaneurysm. Patient presented with the recurrent hemoptysis. And how to treat? These are the some investigatory tools is the X-ray, some marker is the serum galactomannan and CT scan thorax. Maybe sometime patient needed a biopsy. When suspicion is the old age patient, history of smoker, no history of the tuberculosis or sarcoidosis, think about the some malignancy is the lung squamous cell carcinoma in the mass. The needed some biopsy, CT guided FNC or the biopsy. And what are the options of the treatment is the first in the Aspergilloma is the go for the medical treatment. Initially give the low dose steroid with anti-allergics and along with the antifungal and antibacterial for the 2 weeks. Then plan for the surgical resection. What are the options of the surgical resection? Wedge resection, lobectomy and pneumonectomy. Wedge resection is indicated when the lesion size is the less than 3 centimeter and peripheral lesion. If the central lesion is the present and go for the, if the lobe is involved, go for lobectomy. Maybe pneumonectomy is needed less than 5 to 4% in cases of the patient needed pneumonectomy. But most of the patient needed a wedge resection and lobectomy. Options of treatment in the Aspergilloma. This is the one this is the video of the White's guided wedge resection in case of Aspergilloma. This is the small size, less than 2 centimeter size of the disease. We do for the White's resection. Another problem in the post tuberculosis case is fibrocavitary lesion. Fibrocavitary lesion is present in the periphery in the lower lobe, and this is the some differential when the fibrocavitary lesion is present in the post tuberculosis patient. Think about the bronchogenic or this is the differential diagnosis of the fibrocavitary lesion. This is the picture, see, this is the right lobe lesion is present, more than 2/3 part is the involved. The normal lung, sorry. See, this is the normal lung, this is the normal lung, and this is the abnormal pathology. And patient more than 2/3 of the lobe is involved, then patient is the plan for the lobectomy, lower lobe lobectomy. This is the bronchial artery, and this is the resected part of lung. Another problem in the post tuberculosis is the bronchiectasis. Bronchiectasis is occurred due to the 2 reasons. One is the healed lymph nodes which compress the bronchus, another is the healed bronchus due to the stenosis. And patient is presented with a copious amount of the sputum with hemoptysis. Maybe sometime patient presented with the dyspnea, and these are investigatory tools are X-ray. In the X-ray, honeycomb appearance is the present. CT scan is the good investigation, and pulmonary function test is the give the some functional deformity of the lung. This is the post tubercular destructed lung. The left side lung is the destroyed. Patient presented with the recurrent hemoptysis and with fever, and patient needed some surgical intervention. And right side there is the compensatory hypertrophy is the occur, and heart is the shifted. If the when you see the X-ray, there is some like a opacity is the present, sub collection. Don't put the intercostal drainage, otherwise you enter in the heart, directly heart. See, this is the heart is the close to the left chest wall. This is the another picture. This is not associated with tuberculosis. This is the honeycomb appearance. This is a different type of the bronchiectasis. How to treat? Treatment is the initially the medical treatment, bronchodilator and pulmonary. Then if the patient is the fit for surgery, then go for the surgical resection, pneumonectomy, segmentectomy, or maybe lobectomy is the needed. Most of the patient needed lobectomy. And when the patient is sometimes coming with the massive hemoptysis and patient needed some urgent treatment, and nowadays go for the bronchial artery embolization, and then later on the plan for the resection. Another important in the post tubercular sequelae are the Pott's spine. Basically the thoracic is the common, and patient presented with the back pain and maybe sometimes functional disorder like a paraplegia or paraparesis, and anatomical disorder is the kyphotic or scoliotic deformity. This type of the patient needed surgical intervention, and mode of the investigation is the X-ray is the dorsal spine, and what are the treatment? Incision and drainage. Maybe sometimes if the vertebra is involved, needed stabilization of the vertebral column. This patient is the coming to our side with the severe pain in the back, and with some he is suffering from fever. He took more than 1.5 year antitubercular drug, but pain is the pain is not relieved. Then CT scan shows this is the collection in the paraspinal area. See, this is the collection, and this is the causes irritation of the nerve. Patient complaining severe sharp shooting pain. This needed a incision and drainage and excision of the bone. Another is important is the pleural empyema. What is the pleural? We have a large series of the empyema, different type of the pleural empyema, and this is the different causes of the primary cause are the this is the pneumonia, but be concerned about the tuberculosis, and there is a huge list of the secondary causes: non-traumatic, traumatic, thoracic, extrathoracic, systemic, and iatrogenic, non-iatrogenic, and osteomyelitis in the thoracic, maybe Pott's spine, and subphrenic hepatic abscess may be rupture, and these are the some other causes in the iatrogenic, in the esophageal tear, and post surgery in thoracotomy, maybe cardiac surgery, in the trauma and refracture. These are the secondary causes of the pleural empyema. This is the classical picture of the patient is coming from the different state, maybe coming from Bihar, Jharkhand, Chhattisgarh, Madhya Pradesh, Uttarakhand, different state from the Nepal. These are the coming in the chronic stages. This is the in the X-ray see, this is the collapsed lung along with the visceral and parietal pleural is the thickened. CT scan shows this is the posterior lateral side is the collection is the present, and collection sorry. And this is the posterior lateral side collection. This is the parietal pleural is thickened, and as well as visceral pleural is also thickened. This needed a surgical intervention, both removal of the visceral and parietal pleura. And nowadays ultrasound is the new diagnostic modality for the thoracic diseases. In this case is the hyperechoic fluid collection along with the pleural thickening. This is the another picture. This is the rare picture, this is the dystrophic calcification. See, this is the pleural patient is coming with the chest pain. He is took anti-tubercular drug for 5 years back, but patient is came with symptom of the severe chest pain. Pain is due to the overcrowding of the intercostal space. This is a rib with overcrowding, and there is the visceral pleura and parietal pleura both are calcified. Patient is needed due to the pain, patient needed a surgical intervention in the decortication. How to manage? Management is the 90% is the pleural empyema managed by the simply the chest drain and antitubercular drug, but 10% patient needed sometimes decortication, only 10%. Most of the 90% patient managed by the simply intercostal drainage, chest physiotherapy and the antitubercular drug along with the some antibiotic, and but 1 to 2% cases needed window thoracotomy. In 20 years back, every patient have a taken treatment window thoracotomy, modified open drainage, but nowadays the department is doing a decortication. Is the large series of the our institute. What is the decortication? Surgical removal of thick and inelastic and restrictive pleural peel. This is the done by open approach or the VATS. We are opting both open and VATS according to the availability of the instrument and availability of the patient and fitness of the patient. And this is the contraindicated in the active tuberculosis. This is the some drawback and benefits of the VATS. This is the young male presented with the history of the chest pain, and he took anti-tubercular drug for more than 3 months, and CT scan shows this is the classical loculated collection in the posterior lateral side, classically in the lateral side, and we plan for the VATS. This is the classical case of the VATS. Lung parenchyma is the good. When the lung parenchyma is the good, when initially when the of the VATS guided decortication, see the lung parenchyma is the good, and this is the loculated collection and significant visceral parietal pleura is the thickened. The position of the patient in the praying position, this lateral praying position, and first port is made in the 7th intercostal space in the mid axillary line, and two port is the one is the anterior axillary line in the intercostal space, and other is port is the posterior axillary line in the intercostal space. First in the tuberculosis, you know, in the abdomen, a lot of adhesion. This is the area, this is the cavity. See, this is the cavity, this is the cavity, this is the adhesion, this is the lung parenchyma. See, this is the lung parenchyma. Patient on the double movement endotracheal tube, one lung ventricle. Patient is the single lung. This is the lung is fallen out when adhesion is the release. Lung is the away from the cavity. This is the cavity filled with the pus. And after the first is the remove the cavity, then the put the suction drain to suck out all the pus and debris which is filled in the cavity, and then we suck all the and irrigate with the, and after that irrigation and suctioning the cavity, and this cavity is the removed. आगे forward करो. ये करो, ये इस पर आ जाओ. हाँ, this is the post. Sorry, ये वहाँ नहीं आ रहा है. This is the post operative X-ray. of the same patient. And this is the another video, and this is the our journey initiated from the here. When we join the department, every patient get a treatment of the open drainage. तो रेजिडेंट एक हम लोगों का वार्ड हुआ करता था, बहुत पुअर पेशेंट रहते थे, तो उसको एम्पाइमा गांव बोलते थे कि कहाँ जा रहे हो, आज एम्पाइमा गांव में आज जा रहे हैं ड्रेसिंग करने. तो मोर देन 20 or 30 पेशेंट इन द लाइंग डाउन इन द डाउन स्टेयर. अब शिफ्ट हो गए यूरोलॉजी में. What are the open drainage? We do the rib resection, 1 to 2 rib is resected out and make a hole in the thoracic cavity, and lung is not expanded due to visceral pleural thickened. After that lung dressing, then patient is coming this position, and then the second stage surgery is done is the thoracomyoplasty. What is the thoracomyoplasty? We clean the cavity and mobilize the pectoralis major and latissimus muscle and put in the cavity and close the skin. This is the post-operative X-ray. In the empyema, 2-stage surgery is performed in our institute. This is the original article and original work is done in our institute. Thank you. Any question?
Thank you so much, sir, for this wonderful talk. I request Professor Shailendra Kumar, sir, I request Professor Jitendra Kushwaha, sir, to kindly felicitate, sir. Professor Jitendra Kushwaha, sir, will be delivering a lecture on updated management of varicose veins. Welcome, sir.
लगाओ भाई. ठीक है. So good morning to everyone. Topic is updated management of varicose veins. Before going to the treatment of the varicose vein, you must know the anatomy. Varicose vein is a disease of the superficial venous system of the leg. So venous systems are divided into the superficial venous system, deep venous system, and perforating veins. Superficial veins are superficial to the deep fascia, and deep veins are deep to the deep fascia. Superficial veins are great saphenous vein, small saphenous vein, and their tributaries. And deep veins are like common femoral vein, popliteal vein, peroneal vein. These are deep veins. Perforating veins communicate superficial venous system to the deep venous system and allow venous blood flow from the superficial to the deep only. So GSV incompetency is responsible for the 45 to 75%, and SSV is the responsible for the incompetency of 15 to 25%. Anterior accessory saphenous veins, that is the tributary of the great saphenous vein, that also may become incompetent in the 10%, anterior accessory saphenous vein, and posterior accessory saphenous vein may cause in the 5% incompetency. So it should be kept in the mind that these veins may be also incompetent for the varicose veins, not only GSV or SSV. Perforators in the legs are ankle perforators, lower meia-costal, lower leg perforators. So these are carpet perforators, 1, 2, 3, below knee wire perforators, above knee dot perforators, and mid thigh hunterian or sartorial perforators. And this is the saphenofemoral junction. So this here saphenofemoral junction, there is always a valve. If this valve become incompetent, so blood will come from the common femoral vein into the great saphenous vein, and it will cause varicose vein. So symptoms of chronic venous disease. Chronic venous disease: heaviness, tired legs, fatigue, feeling of swelling, itching, cramps, throbbing pain. These are symptoms. Etiopathogenesis of chronic venous systems: any cause in which venous stasis occurs, like prolonged standing, prolonged sitting, or pelvic tumor, or a deep venous thrombosis. This causes increased venous hypertension, which will lead to the venous wall tension. This will cause matrix metalloproteinase overexpression, and after that, this will result in the remodeling of the vascular wall and degenerative loss of elastin and collagen, which will cause venous wall smooth muscle relaxations. So wall will be dilated, incompetent, wall will become incompetent, and this will cause chronic venous disease. Similarly, it may also cause endothelial cell injury due to the chronic stasis venous blood in the leg. It will cause endothelial cell injury, leukocyte infiltration followed by inflammatory changes. Again, this will cause the loss of the elastin and collagen fiber in the wall. So venous wall and wall become incompetent. Investigation is the gold standard is the duplex ultrasound, duplex color Doppler ultrasound, in which B mode, color mode. On the B mode, what is the site of SFJ, where is the site of SPJ, where is the site of perforators, and what are their diameters. Deep venous thrombosis, superficial venous thrombosis on the B mode. On the color mode, it denotes reflux. Reflux on the color mode. Red color denotes reflux. If it is persisting for more than 500 milliseconds, it means that valve is incompetent. SIP classification that is developed by the American Venous Forum, clinical, etiological, anatomical, and pathophysiological 2020, that is latest classification for the uniform comparison, for the uniform treatment, and for the to check the follow-up results for that treatment. So this is the for the research purpose. C0, no visible sign, no visible signs of prominent veins. C1 is the telangiectasia, less than 1 mm interdermal venules. Venules also contains valve, microvenous valve. If that got incompetent, so it will cause telangiectasia or reticular vein. Reticular vein is 1 to 3 mm interdermal venules, and reticular veins are due to the subdermal venules, dilatation of the subdermal venules. So telangiectasia or reticular vein. C2, that what we call varicose vein. Actually, that is the varicose vein is the one stage of the chronic venous disease. This C classification is for the CVD, chronic venous disease, not for the varicose vein. Varicose vein is the C2 stage of the C. Dilated, elongated, tortuous, superficial veins of the leg having reflux. C3, venous edema due to the increased capillary permeability. C4, A, B, C. C4A, eczema. C, sclerosis, hardening of the skin and subcutaneous fat. Or atrophy blanche, skin becomes atrophied, white color. C4C, corona pelvitica, crowning of the varicosities around the ankle, that is called malleolar flare or corona pelvitica, that is due to local incompetence of the perforators, ankle perforators. C5, heel ulcer. Ulcer was present, but that is healed on the conservative treatment. C4, 6, non-healing ulcer, active ulcer, not responding to the conservative treatment. Ulcer is not decreasing in the size, not coming in the healing phase. Size is even increasing after the treatment. So this is the active ulcer, C6, and C6R is called recurrent ulcer. Conservative management indication: if patient is in the pregnancy, only conservative treatment, only the stocking. Other indication for the conservative treatment is the for the surgery, but he is waiting for the surgery. He is in the waiting list. Our patient is not willing for the surgery, there is indication for the surgery, but patient is not willing for the surgery. So these are the indication for the conservative treatment. In the conservative treatment, weight loss, physical activity, calm muscle exercise, compressive pressures, and some veno-active drugs is advised. So elastic compression stockings, that is the main initial treatment of the first treatment of the varicose vein. Advise the stockings. Below knee length stocking, mid thigh stocking, full thigh length stocking is present. So usually below knee is preferred for the more compliance of the patients. And there are graded compression stocking, grade 1, grade 2, grade 3, grade 4 on the basis of the disease. For the prophylactic treatment, grade 1 stocking 10 to 20 milli, 14 to 20 millimeter mercury of pressure. For the varicose vein, grade 2 stocking, venous edema, grade 3, and for the filarial, grade 4 stockings. So depend on the ankle pressure. And this is called graduated compression stocking. Graduated compression stocking means whatever pressure is present at the ankle joint, of that 70% pressure should be at the calf, and of this ankle pressure, 50% pressure should be at the thigh. So this is graduated compression, means as we will go upwards, compression should be loose for the venous drainage. Other compression stockings are wrapping. Patient can wrap, adjust grade 1, grade 2, grade 3, that are adjustables. If the patient is bedridden, then pneumatic compression stocking. Veno-active drugs, there is definitely role of the veno-active drugs. So now latest is the updated is the microionized MPFF, microionized purified fluoride fractions, that is named marketed as a Dizoflab, Daflan, Aldosmin. So fluorides, that are drugs that increases the tone of smooth muscle, tone of the wall and tone of the valve. So this is preferred in the conservative treatment along the with stockings. But in the pregnancy, only stocking. Fluorides are also not indicated. Intervention for the superficial vein incompetency, intervention, treatment of the varicose vein. If there is superficial vein is incompetence, great saphenous vein is incompetence, small saphenous vein is incompetence. So what are various options? This is European Society of Vascular Surgeon ES 2022 guidelines, and this is the latest guidelines. ES 2022 guidelines for the treatment of the varicose veins. Endovenous thermal ablation is preferred. Class 1 level A indication. Laser ablation or radio frequency. Thermal ablation by laser or radio frequency. Second option is high ligation and stripping, that is old treatment. High ligation and stripping. Ligation of the SFJ, of the SPJ, and stripping of the small saphenous vein up to the upper calf, because below that nerve comes, sural nerve and saphenous nerve. Endovenous non-thermal ablation, glue, MOCA, mechanical ablation and chemical ablation, foam sclerotherapy, these are non-thermal. So treatment of the reticular vein, if you have vein viewer, so it can be used to magnify the view. So in the reticular vein, pass the 0.5% sclerosing agent, 0.5% sclerosing agents. If veins are permanent, so when vein are needed, you can directly pass foam sclerotherapy into the vein. Endovenous laser ablation, that laser ablation, radio frequency ablation, that is the standard of care for the varicose veins. And ultrasound guided, this procedure is performed. First localize where the great saphenous vein. Puncture the great saphenous vein, ultrasound guided. This is great saphenous vein. This is guide selling needle. Blood is coming from the great saphenous vein. Pass the guide wire in the great saphenous vein, ultrasound guided. This is J wire, J shaped, to prevent extravasation of the wire. And this guide wire will guide the introducer sheath. So through this guide wire, introducer sheath is passed, fascia dilator, sheath. Black color was fascia dilator and white color is introducer sheath. So now this guide wire along with fascia dilator is taken out. Guide wire and fascia dilator is taken out. Only introducer sheath is inside the great saphenous vein. Laser machine, 7 watt power. Laser fiber passing inside the great saphenous vein. Ultrasound guided. And it should be away 2 centimeter from the SFJ to prevent the burning of the common femoral vein. So this laser fiber is going inside the great saphenous vein up to the SFJ, then 2 centimeter is withdrawn. This is saphenofemoral junction below common femoral vein, and this is great saphenous vein. This is saphenofemoral junction. This is valve of the saphenofemoral junction. 2 centimeter out from the SFJ, laser fiber. Thermal ablation is, it works at 800 degrees centigrade. Laser works at 800 degrees centigrade. This is tip of the laser fiber. So to prevent the burning of the surrounding structure, normal saline, perivenous normal saline is passed around the great saphenous vein. Normal saline or ringal lactate. If you are using the tumescent anesthesia, so tumescent fluid is administered that contains xylocaine, normal saline, soda bicarb. So this is normal saline bulging down the great saphenous vein. It will absorb the heat. So to prevent the burning of the surrounding structure, this is laser fiber, working laser fiber, bubbling. Bubbles are coming when it is on. So there is bubbling due to it dehydrates the endothelial cells. Bubbles arises. So endothelial cell will damage, followed by the fibrosis, and great saphenous vein will be obliterated. Performed only up to the knee joint, because below knee joint there is the saphenous nerve. So burning of the saphenous nerve will cause. Second option is radio frequency ablation. It works at 120 degrees centigrade, 85 to 120 degrees centigrade. Laser works at 800 degrees centigrade. There are different type of machine, closure fast, 7 centimeter length in the 20 centimeter. That laser was working 1 centimeter in 10 seconds. 1 centimeter in 10 seconds laser. Closure fast 7 centimeter in the 20 seconds. So there is less time. Veno close, other device, other is FKR. So there are other types of, many types of. Second option is the foam sclerotherapy. This is non-thermal. Previously were used in the great saphenous vein, short saphenous vein, but now that sclerosing agents are converted into the foam by the Tessari technique. In the one syringe, sclerosing agent is taken, sodium tetradecyl sulfate or polidocanal. These two are widely used. Sodium tetradecyl sulfate or polidocanal sclerosing agents that damage the endothelial cell surface lipids. So in one syringe, sclerosing agent taken. In another syringe, room air is taken. Room air, 4 times room air, and this is mixing and remixing through the tri-way stopcock, mixing and remixing 20 to 20 times. That in the perforator, in the tributaries, ultrasound guided to prevent the extravasation. Otherwise, skin will be injured. Stable for 2 minutes. 1 to 2 ml of foam injected at one time for 10 to 15 centimeter. So how polidocanal and sodium tetradecyl sulfate, that is safe, and in comparison, polidocanal is more safe. Polidocanal is more safe. Less hyperpigmentation, less tissue necrosis. So room air in another syringe. In this sclerosing agent, 4 times room air, tri-way stopcock. So this is lever lock syringe. Lever lock syringe that can be locked on the screw. So mixing and remixing will cause foam formation, and this is very well visualized on the ultrasound. High ligation, esophageal ligation, foam catheter, foam can be passed through the in the great saphenous vein or small saphenous vein, that is called catheter directed foam sclerotherapy, or through Vigo or butterfly cannula. Stripping and ligation is other, that is old technique. Ligation of the SFJ, and passing the stripping from the above to downwards or from down to upwards, and stripping of the great saphenous vein up to knee joint, because below the knee joint there will be injury to the saphenous nerve. Perforating veins, If perforators are incompetent, that can be treated by in the C4, C5, C6. C4 means skin changes, C5 heel ulcer, C6 active ulcer. It is in the C4, C5, C6. So this is perforator. Reflex in the perforator. Red color denotes reflex in the perforator on the color mode. I am puncturing the perforator. IV cannula, 16 number cannula. So this cannula is going inside the, this is perforator. This is perforator. Superficial muscle sinus. So this is perforator. Blood is coming from the perforator. Laser fiber is being passed in the perforator, just below the deep fascia. So this is fiber tip in the perforator. Again, tumescent fluid injected, and Bigo is removed out, taken out. Laser fiber is inside the perforator. Peri to absorb the surrounding heat. And this is ablated, again bubble will appear. So this is ablation of the perforator. This is perforator ablated, bubbling inside the perforator. Foam sclerotherapy can be passed, again butterfly cannula. Reflex in the perforator. This is superficial vein, this is deep vein, and this is perforator. Communicate superficial to the deep vein, posterior tibial vein. So this is reflex inside the perforator. Now scalp vein of butterfly cannula, that is punctured ultrasound guided in the perforating veins. Tip is inside the perforator. And small amount of foam, 1 to 3% is passed in the perforator. This is foam inside the perforating veins. Subseps, now this is being obsolete. Subfacial endoscopic perforator surgery. Incompetent perforator is treated by 2 ports, same instrument as in the laparoscopic, same ports. Carbon dioxide is passed inside the subfacial space. Subfacial space between the deep fascia and underlying muscle sinus. So now skin, subfacial, cutting the deep fascia, below the deep fascia, subfacial. That's why it is called SEPS, subfacial endoscopic perforator surgery. To create the space, this is passed to create the path. Normal saline will pass through this cannula, through this suction, and subfacial space. First port. So in this perforator is utilized very in the magnified view. Second port, through guided by first port, on the medial aspect of the leg, below the knee, both ports. Most of the perforators are found below the legs and on the medial side. So this is perforator. Endoscopic dissection of the perforator. Above is deep fascia and below is muscle, calm muscle, and this is subfacial space, perforator coming from above to downwards. So this is B perforator. It can be clipped, it can be cauterized by the harmonic, ligase or whatever. So this is cauterized. Foam sclerotherapy in the varices. Varices means incompetent tributaries. Bunches of tributaries are found on the leg, below the neck. In this, foam sclerotherapy can be passed through the butterfly cannula. A small amount of the foam. Ultrasound guided. Other techniques, updated techniques, but these are evaluating techniques, not level 1 evidence. Endovenous ablation by steam, it will be cheap. Superheated steam is passed into great supination, short supination. Other is MOCA, mechanical ablation and chemical ablation, glue, microwave therapy and HIPU, high intensity foam sclerotherapy, that is coming in the treatment of the varicose vein. MOCA means mechanical ablation by wire, prongs of wire. This will cause venospasm. At the same time, foam is passed. So mechanical ablation by the prongs of that is opened inside the vein, that will cause venous spasm, and foam at the foam is passed into the gate supination, but that is not showing very good result. That's why I have stopped. Glue, that is going good result, 98 to 100% closure rate. Glue, non-thermal. Endovenous glue is passed into the great supination or small supination, ultrasound guided. Cyanoacrylate glue, that will close the lumen, adhere the lumen. Microtherapy in the varicose vein, that is latest coming in the varicose vein. Now HIFU, high intensity focused ultrasound is for the treatment of varicose vein, a new non-invasive procedure that is also evolving. Focused ultrasound generates heat at a precise point deep to the skin, guided by real-time ultrasound guide image. A little amount of local anesthesia is around the vein. This combined with the skin cooling delay, which is computed with that machine. The HIFU. Non-healing ulcer, active ulcer, there is some specific treatment. 4-layer bandage. Sir, first layer contains cotton wool, second layer contains inelastic bandage, and third layer elastic bandage, and fourth is cohesive. So 4-layer this 4-layer bandage remains for the 1 week. After 1 week, that is changed. For the venous also higher pressure is required, venous hypertension. So compression around the ankle should be around 40 millimeter mercury or more than 40 millimeter mercury. That's why 4-layer bandage is preferred. First layer, second layer, only 1 layer, 2-layer bandage is not effective. And from the toe to the knee, below knee. First layer is cotton, second layer is cotton crepe bandage, and third layer contains synthetic crepe bandage, that is lycra, and fourth layer cohesive. So it remains for the 1 week. Patient is asked to the doxycycline, and early intervention enhances the healing of the venous ulcer. So whatever cause incompetency should be treated by the laser or foam, whatever you preferred. Early intervention enhances the healing rate of the ulcer. So this ulcer is treated by the interventional therapy and multi-layer drainage, multi-layer 4-layer bandage. This is bilateral varicose vein, venous ulcer with varicose veins, ulcer healed completely. Ankle perforators, skin bandage fails. So in that there is indication of the skin grafting or pedicle graft. Meath-Turner syndrome, that you must know, especially on the left side. In the left side, left common iliac vein is compressed by the right common iliac artery here. Left common iliac vein is compressed internally with the right common iliac artery. So compression of the left common iliac vein will cause the left side venous stasis, followed by DVT, followed by the varicose ulcer, left sided. So in this common iliac vein that is compressed by the iliac artery, that should be treated by the common iliac vein stenting. Hyperbaric oxygen therapy in the there is role of in the venous ulcer. So take home is the proper history and examination, rule out DVT and what is the incompetency of the which vein. Anterior excessive supination, posterior excessive supination should not be missed. Perforators are incompetent, that should be also treated, especially in the skin changes, healed ulcer or active ulcers. And the third, 98% closure rate is by the laser or radiofrequency. And for the venous ulcer, along with adjunctive treatment like pentoxifylline, multivitamins, and venoactive drugs, flavonoids, 4-layer bandage is preferred, and the early intervention enhances the venous healing. So, thank you.
Thank you so much, sir. I request Dr. Manish Agarwal, sir, to kindly felicitate Jiten, sir.
ठीक है
Thank you so much. Sir. I welcome Professor Sandeep Tiwari, sir, Professor and Head Department of Trauma Surgery, KGMU, to kindly deliver the lecture on abdominal and pelvic trauma. Welcome, sir.
So good morning everybody. There is no energy. Good morning everybody. Still I can't hear you. Good morning everybody. Yeah. So how many of you have dealt with trauma? How many of you have dealt with abdominal trauma? So why abdominal trauma is important? What is so specific about abdominal trauma? Yes, please. Anybody? Speak out. It is not a lecture, it is interactive discussion. Okay? Speak loudly. Very good. There are a number of important organs in the abdomen. So what can happen? Can cause hemorrhage. Yes, very good. And in trauma, most common cause of death is hemorrhagic shock. Hemorrhagic shock. So it's very important to recognize the shock and to recognize the source of bleeding. Okay. The normal dictum is hemorrhage can happen where? कहाँ कहाँ हो सकती है hemorrhage? Speak out, speak out. गलत बोलोगे कोई बात नहीं यार, कोई यहाँ गोली थोड़े मारने जा रहा है, बोलो hemorrhage कहाँ कहाँ हो सकती है? There is a major vessel. Very good, very good. So normal dictum is blood on the floor and क्या मतलब? Blood on the floor क्या मतलब हुआ? External bleeding, which you can see, and there are 4 more which you cannot see. That is pleural cavity, peritoneal cavity, pelvis, and long bones. Okay, and peritoneal cavity is a huge cavity, even a large amount of hemorrhage, and which can cause delayed death of the patient. So abdomen and pelvis cavity, it can accommodate around 2 liters of blood. ठीक है, 2 to 2.5 liters means class 3 hemorrhage. Do you know na classes of grade of hemorrhage? Class 1, class 2, class 3, class 4, है ना? So it can cause pelvic cavity damage, can cause class 3 hemorrhage, and peritoneal cavity can accommodate even a large amount of blood, 3 liters, 4 liters. ठीक? How much is the total amount in the blood? It is, why it is important? It is important because, why it is important? It is important because if you recognize early, you can prevent the death of the patient because of hemorrhagic shock. So abdominal and pelvic trauma is most common cause of preventable death because of trauma. There are so many reasons of hemorrhage in the abdominal cavity, in the peritoneal cavity, and many times we are not able to recognize it. Okay? So unrecognized abdominal pericarditis continue to be cause of preventable death, which we have already talked about. So, the objective, identify the anatomic regions of the abdomen that are critical in assessing and managing trauma patients. So, if you look as a general surgeon, then anatomic regions are different. But if you look like a trauma surgeon, for a trauma patient, the anatomic regions of the abdomen are different. Okay? In that we do not classify it as a quadrant which you read in general surgery. Right hypochondrium, left hypochondrium, hypogastrium, suprapubic region, right iliac fossa, left iliac fossa. How we classify, we will see in our few minutes. Discuss the risk of abdominal pneumonia based on the mechanism of injury. अब see, to understand what is the mechanism of injury is very important. If you know what is the mechanism of injury, you can identify that which region may be injured, which part of the abdominal cavity is injured. Okay? Giving you one example, we were, before when I was in general surgery, we were not able to identify the pancreatic injuries very frequently. But now we have got more than 200 case series of pancreatic injuries. I will show you in next slides also. So, if there is a history that is a motorcycle rider or a two is riding and there is a direct impact in the epigastrium, there is a handlebar injury, then there are high chances of pancreatic injury. Because pancreatic injury is very dangerous, if you recognize early and you treat it early, then patient may survive. Otherwise, what will happen? You will recognize once there will be pancreatitis, and then it will be difficult to manage. So, mechanism of injury is very important. Then identify the patients who require surgical consultation. ठीक है कि किन पेशेंट्स में हमें इमीडिएट सर्जरी करनी है. तो ए पेशेंट ऑफ एब्डोमिनल इंजरी, in hemorrhagic shock, you have given 1 liter of fluid, you have PC, but patient is a non-responder. Non-responder means his shock is not improving. What does it mean? It means that you are filling the balti, but you have closed the tap. ठीक है, तो टैप क्लोज करने के लिए क्या करना पड़ेगा? You have to shift the patient immediately to OR. Okay, so that is why it is very important to recognize surgical consultation and catheter based intervention. If patient is a responder, then you will shift the patient to CT. You will go for CT or CT angiography, and if there is a blush or extravasation of dye from somewhere, there is a solid organ injury, then you will go for radiological intervention. Okay, interventional radiology, but the patient should be stable, not in an unstable patient. If patient is unstable, then we will shift the patient to OR directly. Then determine appropriate diagnostic procedures. क्या क्या डायग्नोस्टिक प्रोसीजर्स हो सकते हैं? भाई चेस्ट एक्सरे, पेल्विस एक्सरे तो हम प्राइमरी सर्वे में करा लेते हैं, ठीक है. उसके बाद जब पेशेंट स्टेबलाइज हो जाता है, क्या करते हैं? व्हाट इज एटीएलएस प्रोटोकॉल? प्राइमरी सर्वे एंड सेकेंडरी सर्वे. प्राइमरी सर्वे में क्या करते हैं? वी गो फॉर ABCDE. ठीक. अब एब्डोमिनल ट्रॉमा इज बेसिकली ए C.
क्योंकि मोस्ट ऑफ द टाइम सर्कुलेशन इज अफेक्टेड. बिकॉज ऑफ सर्कुलेशन A may also be affected, because in shock what happens, mentation may go down. ठीक है ना. तो ये जरूरी जानना है कि हमको क्या करना है. इन्वेस्टिगेशंस प्राइमरी सर्वे में अनस्टेबल पेशेंट में वी विल नॉट गो फॉर एनी अदर इन्वेस्टिगेशंस एक्सेप्ट ब्लड इन्वेस्टिगेशंस एंड चेस्ट एक्सरे एंड पेल्विस एक्सरे. इफ वी हैव टू गो for CT abdomen, then we will go in secondary survey once the patient is stable. Don't sleep यार. इतनी जोर से मैं बोल रहा हूं तब भी तुम सो रहे हो हैं. सोना मना है. सोने की ज्यादा कीमत होती है कि प्लेटिनम की? बोलो. सोना ज्यादा महंगा होता है कि प्लेटिनम? अरे बोलो तो. प्लैटिनम ना. ठीक है. और ट्रॉमा में क्या कहते हैं? गोल्डन आर दैट इज. तो हम तो 20 मिनट पढ़ा रहे हैं यार, 1 घंटे भी नहीं पढ़ाने जा रहे हैं. ठीक है. और अब तो नया कॉन्सेप्ट आ गया प्री हॉस्पिटल केयर के लिए. प्लैटिनम 10 मिनट्स. ठीक है. तो 10 से 20 मिनट थोड़ा सा जाग के बैठो. Then formulate the acute management plan for abdominal and pelvic injuries utilizing a case scenario. We will discuss a case scenario. Okay. Discuss the importance of early identification and emergent management of pelvic hemorrhage. So what is the emergent management of pelvic hemorrhage? Yes, very good. Just apply a pelvic binder. If you don't have a pelvic binder, then sheet. Where? At the level of greater trochanter. Okay, that's good. What priorities abdominal and in the management of multiply injured patient? So priorities will never change any patient of trauma. You will check for airway, because what he is saying that there is multiple injured patient, so he may have polytrauma. ठीक. तो priorities will never change, it will remain same A, B, C, D, E. This we have already talked about. One thing is important. Read out this, please, madam. What is written here?
Patient assessment is often compromised by alcohol intoxication, drugs, brain or spinal injury and associated chest pain.
Exactly. So that is why sometimes will not give you any signs despite he is having bowel perforation, the patient is having, or there is a lot of hemorrhage. So signs of peritonitis may be obscured because of this reason, and that is why it is said that abdominal trauma, to recognize abdominal trauma early is important, because patient is having head injury or he is in alcohol intoxication. So signs of peritonitis will not be there. So what I was talking about, the anatomical regions in trauma scenario, not as a general surgeon, is this. Anterior abdomen is from transnepal line to anterior axillary line to inguinal ligaments and pubic symphysis. It is not like quadrants. Why? Because lower thoracic injuries can cause liver injury. On left side it can cause spleen injury. In epigastrium it can cause gastric injury, pancreaticoduodenal injury, retroperitoneal injuries, ठीक. तो that is why it is classified as anterior abdomen, it is classified as flank, the flank is anterior, between anterior and posterior axillary lines, ठीक, up to the iliac crest, then back posterior axillary line, tip of axilla to the iliac crest, because this is the reason. Okay. So on these basis only, and at the basis of mechanism of injury, we can identify where is the injury. क्या भैया 20 मिनट होगा क्या? And these are the spaces: peritoneal cavity, retroperitoneal space, pelvic cavity. जहां पे इंजरी है वहां पे कौन कौन से आर्गन है, इसलिए इसको ऐसे डिस्क्राइब किया जाता है. अभी रेट्रोपेरिटोनियल इंजरीज की बात हम लोग कर रहे थे. इट इज डिफिकल्ट टू रिकॉग्नाइज. ओके, फास्ट में दिखेगा नहीं, डीपीएल में आएगा नहीं. So a 20-year-old male helmeted motorcyclist, high speed collision, head on into the side of a vehicle that pulled out in front of him. ये मिस्ट समझते हैं ना, मैकेनिज्म ऑफ इंजरी, साइंस एंड सिम्टम्स एंड ट्रीटमेंट गिवन. ओके, पेशेंट रिपोर्ट्स ब्रीफ लॉस ऑफ कॉन्शियसनेस, कंप्लेन्स ऑफ पेन इन चेस्ट एंड एब्डोमेन एंड पेल्विस. तो तीनों जगह पे दर्द हो रहा है उसके. बीपी 100/75 है. हार्ट रेट जो है वो हार्ट रेट इज 115, जीसीएस इज 15. तो अभी कॉन्शियस है पेशेंट, लेकिन क्लास 1 शॉक में है. What are your priorities for management of this patient? So priorities never change in a trauma patient. Priorities will remain same. इंटरप्रिटेशन क्या है वाइटल साइंस का, कि पेशेंट है जीसीएस 15 में लेकिन माइल्ड शॉक में है. ठीक है. इनिशियल थेरेपी, क्या देंगे भाई? जीसीएस 15 में है, इसका मतलब एयरवे पेटेंट है. रेस्पिरेटरी रेट नॉर्मल है, ठीक है, इसका मतलब ब्रीदिंग प्रॉब्लम नहीं है. प्रॉब्लम कहां पे है? सी में है थोड़ी सी. ठीक है, तो वी विल गिव इनिशियल बोलस ऑफ 500 ml ऑफ क्रिस्टलोइड. ठीक है. ईएमएस की रिपोर्ट क्या है? पेशेंट वाज फाउंड 10 feet फ्रॉम हिज मोटरसाइकिल, लाइंग ऑन राइट साइड, ट्रेवलिंग ऑन हाई स्पीड. ठीक, हार्ड राइट साइडेड लैंडिंग, ब्रीफ लॉस ऑफ कॉन्शियसनेस, लेकिन अभी कॉन्शियस है. तो और क्या हो सकता है उसको? कॉन्शियसनेस हुआ था, अभी नहीं है. ठीक है. एंड एम्पल हिस्ट्री में देयर इज नथिंग पॉजिटिव. अब based on the reports and mechanism of injury, what injuries he may have? He may have head injury, chest pain है, chest injury हो सकती है, abdominal injury हो सकती है, pelvis injury हो सकती है, extremity injury हो सकती है. क्यों? क्योंकि ये एक dangerous mechanism of injury है, because it is a dangerous mechanism of injury. हिस्ट्री में हम लोग को देखना है, पूछना होता है, जो कि हम लोग को यूजुअली मिलती नहीं है यूपी में, क्योंकि एम्बुलेंस वाला 1 घंटे बाद पहुंच रहा है, आधे घंटे बाद पहुंच रहा है, पेशेंट अनकॉन्शियस है. बट वी हैव टू टेक ऑल दीज हिस्ट्री ऑलरेडी डिस्कस्ड. Restraint devices. सीट बेल्ट लगाए हुए है और सीट बेल्ट इंजरी का साइन है, दैट मीन्स ही मे हैव bucket handle tear of the mesentery, which will not be detectable on fast. Fast will only say there is minimal amount of blood or fluid. Okay, so that will be detected only after 3 to 4 days. Once the gangrene has started, then the signs of peritonitis will come. So it is difficult to diagnose. What to do? What to do? Look CT properly. There is mesenteric stranding in CT scan if there is mesenteric injury. We have to read CT very meticulously to recognize mesenteric injury. Otherwise, if you have got the facility, go for diagnostic laparoscopy. This we have discussed कि mechanism of injury is important. Penetrating में stab हो सकती है, गन शॉट हो सकती है, एक्सप्लोसिव ब्लास्ट इंजरी हो सकती है. ये परसेंटेज है. ब्लंट में स्प्लीन सबसे ज़्यादा होता है, स्टैब में लीवर सबसे ज़्यादा होता है, गन शॉट में स्मॉल बावल सबसे ज़्यादा इंजर्ड होती हैं. ये हैंडल वार इंजरी हम लोग डिस्कस कर चुके हैं. पेनिट्रेटिंग इंजरी है तो फिर क्या करेंगे, कैसे हमारी वो चेंज होगी. पेनिट्रेटिंग इंजरी में सबसे इंपॉर्टेंट होता है ट्रेजेक्टरी देखना. ठीक है, राइफल्ड है, अनराइफल्ड है. राइफल्ड है, राइफल्ड क्या फर्क होता है? व्हाट इज द डिफरेंस बिटवीन राइफल्ड इंजरी एंड अनराइफल्ड इंजरी? राइफल्ड जो है घूमते हुए जाती है, तो एंट्री वुंड यहां हो सकता है, एग्जिट वुंड बहुत दूर हो सकता है, बट देयर कैन बी मल्टीपल इंजरीज. पैलेट इंजरीज में क्या होगा? पैलेट इंजरीज में देयर कुड बी multiple pellets in the abdomen, so there could be multiple injuries. So that is how the mechanism of injury is important in abdominal trauma. This I was talking, if you recognize pancreatic injury properly, because if you will recognize it late, it will cause pancreatitis, and then the patient you may lose the patient. So this is the paper which was published. There is more than 200 cases series at our trauma center in our department. Then I was talking about lucid interval. We have given the term lucid interval to mesenteric injury also, because it is diagnosed delayed. So that is why there is importance of diagnostic laparoscopy and to identify mesenteric injury in CT properly. Examination remains same as in all abdominal examination: inspection, auscultation, percussion and palpation. Then, but urethral, perineal and rectal examination is must in abdominal trauma. Vaginal examination is must in females. Gluteal examination is must. Examination of back during log rolling, because there may be injury to the back, patient is lying, so you can miss the back, which may have caused retroperitoneal injury. Okay, so that is why log rolling. What is log rolling? It is done by 4 persons suspecting that patient is having spinal injury. So one patient stabilizes the spine, cervical spine, and rest of 2 they turn over the patient, and one person examines the back for any injury. So Foley catheter should be avoided in patient with perineal hematoma or blood at meatus. Okay. This we have discussed already. So there was a right-sided lower chest tenderness in the patient, contusions right chest, abdomen and flank, tender right upper quadrant, right flank and suprapubic region, pain on palpation of the anterior pelvis, no blood at the urethral meatus, rectal examination is normal, vital signs following epidemiology, which I have said, have become normal now. How will you assess now? पेल्विक एक्सरे तो हो गया, उससे पता चल जाएगा है। पेशेंट स्टेबल हो गया, हमने क्या कहा था कि पेशेंट स्टेबल हो जाए अगर तो क्या करेंगे, गुड। दिस वी हैव ऑलरेडी डिस्कस्ड। इस फास्ट इज इंडिकेटेड एट दिस स्टेज। Speak loudly. Yes, we have already done. Fast is not an investigation. Mind it. Fast is a part of clinical examination in trauma patient. An unstable patient should not be sent to radiology for fast. Fast has been done by trauma physician or a trauma surgeon or a general surgeon who is dealing with trauma. So fast is not an investigation, it is a stethoscope in a trauma bay. It is a stethoscope in a trauma bay. Then these are the adjuncts. We have to put 2 tubes. We have to perform 2 exams and we have to do 2 x-rays. Fast disadvantage is कि जब तक 70 ml से ज्यादा फ्लूइड नहीं होगा दिखेगा नहीं, नंबर 1 रेट्रोपेरिटोनियम। फास्ट में क्या देते हैं, 4 जगह देखते हैं, मॉरिसन्स पाउज, डगलस पाउज एंड स्प्लिनिक व्यू एंड एपिगैस्ट्रिक व्यू टू लुक फॉर पेरिकार्डियल फ्लूइड। फीमेल है तो करोगे, यूपीटी करोगे और वेजाइनल एग्जामिनेशन करोगे। ये वी हैव डिस्कस्ड, वी विल गो फॉर सीटी। These are the sensitivity and specificity of the CT abdomen. Okay. आपके पास पूरी सर्जिकल और रेडियोलॉजिकल फैसिलिटी है। एब्डोमिनल सीटी में ग्रेड 3 लीवर इंजरी है, राइट री फ्रैक्चर्स हैं, बायलैटरल रेमाई पेल्विक रेमाई फ्रैक्चर्स हैं, सर्जिकल कंसल्टेशन ऑब्टेन हो गया है और 1 लीटर फ्लूइड अब तक दिया जा चुका है। इज इमरजेंट लेप्रोटमी इज वारंटेड? नो। So in many trauma patients, in abdominal injuries, especially in blunt abdominal trauma patients, now we do not go for emergent laparotomy if patient is a responder. If he, then it is different, then we will immediately shift the patient to OR. क्या क्लिनिकल चेंजेस इसमें ऐसे आए हों? अब एक होता है रिस्पॉन्डर, एक होता है नॉन रिस्पॉन्डर। इन दोनों के बीच में क्या हो सकता है? व्हाट कैन बी? ट्रांजिएंट रिस्पॉन्डर। तो हो सकता है कि दिस पेशेंट वुड हैव बीन ट्रांजिएंट रिस्पॉन्डर। ठीक, तो व्हाट क्लिनिकल चेंजेस विल सजेस्ट दैट ही इज ए ट्रांजिएंट रिस्पॉन्डर? Exactly. BP has started falling down, patient has started tachycardia, patient has developed peritonitis, patient has developed low GCS. Okay. These are the indications for laparotomy in blunt trauma. Number 1 we have already discussed. If there is free air in the X-ray chest, then obviously you have to go. If there is a signs of diaphragmatic rupture, if there is signs of clear-cut peritonitis, and if CT is showing positive signs. This is very important. What happens? Many times you have asked the resident, your junior, to shift the patient to OT. So what is black hole time? Anybody? Ji Dr. Sam. What is black hole time? See, why I have put this slide, this is very important. What happens when we shift the patient to OT? So there is no resuscitation while he is being shifted from the ward to OT. And he is a transient responder or a non-responder. Okay. Then what happens? The anesthesia resident comes and he starts preparing the trolley. He is also not looking at the patient's vitals and all that. And the surgery resident or a trauma surgery resident is busy in painting and draping the patient and all that. So that time, that half an hour time, the patient is not being resuscitated and he becomes low. Anesthesia is given, then shortly NORAD will be started. Then anesthetist will say, no, I cannot extubate the patient. So management of this black hole time is very important, that one person, when patient is en route to OR, should always keep an eye and continue the resuscitation while he is being given anesthesia or surgery is being started. Damage control laparotomy. It is very important in trauma patients. What is damage control? Give the best in minimum time. Suppose patient is very low, he is NORAD और आपने देखा bowel perforation है, don't go for anastomosis. If you have a time, go for ileostomy, jejunostomy, or just tie the loop and put inside the abdomen. Okay? Just give me 5 minutes, please. So the intention is like this. So patient is bleeding. He is having liver tear, deep liver laceration. Don't try to go for segmentectomy or don't try to go for stitch the liver. Just you can put the Foley catheter or you can go for perihepatic packing. But damage control surgery का नियम ये है कि you have done the damage control surgery, shift the patient to ICU, okay, reshift the patient within 48 hours and do the definitive. These are the pictures of packing. This is pancreatic injury which I was talking about, that this is very important to recognize. This is a transaction. So here the damage control surgery is important. These all are pancreatic injury patients. This we have already discussed. Penetrating trauma, indication of laparotomy. न्यूरोट्रांसमिटर अनस्टेबल है, प्रोटोनाइटिस है, एविसेशन है, फास्ट पॉजिटिव है, सिटी पॉजिटिव है. अनस्टेबल फ्रैक्चर्स लीड्स टू अनस्टेबल पेशेंट्स. पेल्विक मंत्रा यह, ठीक है. तो अगर फ्रैक्चर पेल्विस है, खास कर से अगर ओपन बुक फ्रैक्चर है, I will just close it because there is less time. किताब खुली है तो किताब को बंद कैसे करोगे? तो जो ओपन बुक फ्रैक्चर होता है उसमें क्या होता है कि जब आप देखोगे तो एक तो पीसीटी पॉजिटिव होगा, पेल्विक कंप्रेशन टेस्ट. इट शुड बी डन ओनली वंस, शुड नॉट बी रिपीटेड. ओके, बिकॉज इट कैन इंक्रीज द ब्लीडिंग, इट कैन डिस्क्लोज द हेमेटोमा. ठीक है. तो पहला काम तो क्या है कि जब ओपन बुक फ्रैक्चर होगा तो क्या होगा कि दोनों लिम्ब एबडक्टेड होंगे, उनको एडक्ट कर देना है, मिला देना है, ठीक है, और पेल्विक बाइंडर बांध देना है। ईडी में इतना ही काम करना है बस आपके लेवल पे, इससे ज्यादा कुछ नहीं करना है। 90% केसेस में ब्लीडिंग बंद हो जाएगी। अगर नहीं बंद रही है, पेशेंट नॉन रिस्पॉन्डर है, देन ओआर, ठीक, एंड प्री पेरिटोनियल पैकिंग विल बी डन। ये 3 टाइप के फ्रैक्चर्स होते हैं। डीपीएल अब आजकल होती नहीं है क्योंकि ज्यादातर जगह फास्ट अवेलेबल है, जहां पे नहीं अवेलेबल है वहां डीपीएल करना है हमको, ठीक है। लेप्रोस्कोपी का हमने बता दिया कि क्या क्या एडवांटेजेस हैं आपको, दैट वी हैव ऑलरेडी डिस्कस्ड। बच्चों में बस हमको ये देखना होता है कि उनकी फिजियोलॉजी डिफरेंट होती है, तो वी हैव टू मैनेज देम डिफरेंटली। उनकी डोजिंग अलग होती है, उनका फ्लूइड अलग, उनकी डोजिंग होती है अलग होती है, ठीक है। बाकी प्रायोरिटीज विल रिमेन सेम। एब्डोमिनल कंपार्टमेंट सिंड्रोम, ये बहुत ध्यान रखना, जब हम डैमेज कंट्रोल सर्जरी करते हैं तो एब्डोमिनल कंपार्टमेंट सिंड्रोम होने की संभावना होती है, ठीक है। उसकी अर्ली डायग्नोसिस इज वेरी इंपॉर्टेंट। What is our experience in last 5 years? We have admitted 165 patients, out of which 2,600 were blunt, rest of penetrating. So this is only what we have done, and 83% of the blunt trauma patients were managed conservatively, and only 1.1% of penetrating trauma were managed conservatively. So penetrating trauma, unstable patient, shift the patient to OR. Don't think anything. So case scenario conclusion is emergent laparotomy was not required, non-operative management was done, patient admitted to ICU for monitoring, pain control and respiratory care, hemodynamics were normal, physical therapy was given for pelvic fracture, and patient was discharged on day 6. So these are the key learning points. Then mechanism of injury is critical. Thorough examination of the chest, abdomen and pelvis are required to avoid missing significant injuries. Appropriate diagnostics is required. Surgical intervention is assessed via clinical findings in the patient response to management. Early identification and emergent management of pelvic hemorrhage is very important, can be life saving. Non-operative management, I will say one line on this in the last, that non-operative management should be done by the senior most person and by the same person, number 1 every day, number 2 there should be facility of emergency laparotomy, number 3 there should be facility of ICU care, then only put the patient on non-operative management, otherwise go for laparotomy. Thank you. Any questions? Yes, yes.
If facility is not available, then should we straight away go for
If you have got expert urologist, then call him, call a senior person, or otherwise go for suprapubic catheterization. Okay? Anyone? So no questions. Thank you very much.
Thank you for your enlightening talk, sir. May I now request Professor Parker, sir, to kindly come and felicitate the speaker.
Thank you.
Our next lecture is on locally advanced carcinoma of the gallbladder by respected head of the department, sir. He has a keen interest in hepatobiliary oncology and is an expert in his own right in the field with a huge repository of knowledge. We welcome you, sir.
रुक जा, ये पकड़। Manaji, this talk was not meant for this forum, and because of my being a lazy bone and short of time, I couldn't, tailor made the talk for you guys. But I would just tell you from my recall memory what I want to tell and what I and we need to communicate to you people. And had it been made for you, what is the epidemiology, okay, pathogenesis, TNM, then what is early gallbladder cancer, if at all, what constitutes locally advanced cancer gallbladder, and what is the standard of care for early gallbladder cancer, what is the standard of care for locally advanced cancer gallbladder, and then 1 or 2 line for cancer gallbladder, recurrent cancer gallbladder, and post metastasis. इतनी चीजें आनी चाहिए. So it is no rocket science. If I miss something, you just let me know क्या क्या चीजें उसने पढ़ानी थी. So please just forget this. This has to be talk. What is gallbladder cancer? What is the clinical presentation? Needless to say, it is a disease of the northern India. We say it is the cancer gallbladder happens mostly in the Gangetic plain. गंगा के किनारे रहने cancer gallbladder ज़्यादा होता है. But what about those who don't stay in and around Ganga ji? Like it is more common in Chile also. Highest incidence in Chile, highest followed by Peru, followed by Japan and some part in Pakistan and other countries. All right. तो इन जगह पे भी ज़्यादा होता है. बट इंडिया में जोग्राफिक डिस्ट्रीब्यूशन देखें तो नॉर्दर्न इंडिया में कैंसर गॉलब्लैडर ज़्यादा होता है एंड सदर्न इंडिया में कैंसर गॉलब्लैडर इवन गॉल स्टोन्स भी कम ऑपरेट. What is the clinical presentation? Obviously a female preponderance followed by association with the stone. Any stone more than 2.9 centimeters or 3 centimeters, higher incidence of prevalence of gallbladder in that particular cohort. Then patients having chronic typhoid carriers. Go have some coffee and splash some water on your face. जो chronic typhoid carriers हैं और इस तरह की condition है तो what is it actually they do? Cancer gallbladder, stone disease, chronic typhoid carrier, they all continue to prepare or present a milieu of increased inflammatory markers. एक stress का माहौल रहता है. And therefore, in these patients, you will see that the gallbladder cancer, the gallstones are not present or there some kind of history is not present. हालांकि history of chronic typhoid carrier is difficult to elicit या prove करना मुश्किल है, but majority of the gallbladder cancer are associated with a stone, चाहे वो 2.9 centimeters का हो या उससे छोटा हो. Number 1, female sex. It can present at any age. But normally cancer is an accrual of all genetic events, inflammatory events, stress and blah blah blah, and therefore it has to happen at the age of 49 and 50 years. But still you would see that in OPDs they happen at an early age also. Number 1. Number 3. Number 4. What is the common clinical presentation? The presentation of gallbladder cancer is mostly जोर से बोलो, be a little louder. Jaundice. And at one point of time, people start thinking that is cancer gallbladder the most common cause of jaundice compared to periimpelvic cancer. अभी आज की तारीख में periimpelvic cancer is the most common cause of surgical obstructive jaundice. ठीक है, ये 3-4 चीजें होती हैं. Important चीज ये है that whenever there is jaundice, either because of involvement of the liver, which is rarer, it will cause less jaundice compared to involvement of CBD. वहाँ पे jaundice का मतलब है larger size, यानी locally advanced status, यानी poor prognosis, more spread to local organs, more spread to lymph nodes, and hence a poorer prognosis. The magnitude of surgery also increases.
आपको एक चीज करने, गाड़ी खरीदने गए, अगर अर्ली गॉलब्लैडर कैंसर था, गॉलब्लैडर के अंदर लोकलाइज है, आपने रेडियोलॉजिकल डायग्नोसिस बनाई और आपने जाकर के उसको ऑपरेट कर दिया। यहाँ सिचुएशन ये नहीं है। यहाँ पे क्या हुआ कि पेशेंट को लोकल एडवांस कैंसर गॉलब्लैडर बिहेव लाइक आपको कार तो खरीदनी है, लेकिन उसके पहले आपको लोन लेना है, उसके पहले आपको घर में जगह बनानी है, और एक्सक्यूज तो उसमें क्या हो जाता है कि आपको पहले से और भी बहुत सी चीजें करनी पड़ती हैं। जॉन्डिस लिवर इज अ सिक लिवर, ठीक है, जिसको जॉन्डिस है वो सिक है, कोलेंजाइटिस है वो सिक है, जॉन्डिस लिवर है सिक लिवर। तो इसके अंदर विज उस कंडीशन में जिसमें केवल लिवर सीधे निकालना था, रिकवरी भी उतनी ही प्रोपेंशरेट कमेंशरेट द अमाउंट ऑफ जॉन्डिस एंड साइज ऑफ द लिवर एंड सर्जरी एंड ड्यूरेशन is also commensurate with the amount of time and all these confounders. इतनी सी बात है. And that is why majority of the gallbladder cancers are inoperable by the time they present to you, and safe statistical data says that only 10% of the gallbladder cancers are operable by the time they come to you. 90% are inoperable. इसलिए ये जो टॉपिक है लोकली एडवांस कैंसर गॉलब्लैडर, बल्कि इसको होना चाहिए था लोकली एडवांस कैंसर गॉलब्लैडर एंड इनऑपरेबल कैंसर गॉलब्लैडर, ठीक है, क्योंकि मेजॉरिटी है, हमको मेजॉरिटी में ये ट्रीट करना है. You know it has a bad prognosis. This is no rocket science, right? And uh, 0.6 to nearly 1.9 of cancer-related deaths का कारण होता है. And this point number 3, ये अगर आपको सत्यनारायण भगवान की कथा सुनते हैं तो उसमें बोलते हैं ना पंडित जी सत्यवचन महाराज इसमें ये है that the only chance of survival is radical surgery. Radical surgery ही इसे मुक्ति दिलाता है. इसके अलावा modality has been adopted to be, now they are a standard of care, but they have not proven their strength vis-a-vis surgery in patients of cancer gallbladder. इंसिडेंस लो है वेस्टर्न कंट्री में, होता कम है, तो फंडिंग कम है, रिसर्च कम है. इंडिया जैसे डेवलपिंग कंट्री पेरू, चिली, जापान और चाइना को छोड़ दें तो अभी भी स्ट्रगल कर रहे हैं कि बिलो पॉवर्टी लाइन से उठाना है और ये करना है, तो ऑब्वियसली रिसर्च का फोकस पोटेंशियल कम है. ये मैं बता चुका, और ये भी बता चुका कि अगर किसी पेशेंट को जॉन्डिस है तो वो एडवांस गॉलब्लैडर कैंसर की श्रेणी में आ सकता है. इट कैन बी. Second important point is that whenever you are able to feel a lump in right hypochondrium which is continuous with the liver, and the findings are that it looks like an oval liver, or if you are saying it is cancer gallbladder, it should be rounded, it should not be spherical. Spherical means chikna and smooth because of any other reason, but a cancer gallbladder liver would be variegated, nodally and knobly. Knobs होंगे, गांठ होगी, इस तरह का होगा. इसके लिए once again you need little imagination. If you remember T3 and T4, it simply means that gallbladder malignancy has gone beyond cirrhosis of the gallbladder. Liver माफ कीजिए अचानक से शुरू हो गई. केजरीवाल जी उधर हार के खांसी मुझे दे गए. तो जब T3 होता है तो गॉलब्लैडर के पास T3 होते ही वहां पहुंचने की कोशिश करता है मोमेंटम, और उसे रोकने की कोशिश करता है. तीसरी चीज क्या होती है वहां पे? स्टमक. तीसरी चीज ड्यूडनम, चौथी चीज कोलन. और ये कैंसर गॉलब्लैडर एलिसिट स्ट्रॉन्ग डेस्मोप्लास्टिक रिएक्शन. स्ट्रॉन्ग डेस्मोप्लास्टिक रिएक्शन का मतलब हुआ कि ओरल कैंसर की तरह जो नोडुलर लीजन है बहुत हार्ड होता है, बहुत ज्यादा डेस्मोप्लेजिया होता है. इन 3-4 चीजों से लंप बनता है. तो जब भी कभी इसका लंप बनेगा, एक चीज बहुत कॉमन होगी, इट विल बी कंटिन्यूअस विद लिवर. ठीक है, तो करेगा, रिवर के साथ कंटिन्यूअस होगा परकशन में. तीसरी चीज ये होगी कि ये स्मूथ ग्लोबुलर नहीं होगा. कभी मत बोलना स्मूथ लॉबुलर। जब भी पेरियम्पेलरी कैंसर की आप डिफरेंशियल डायग्नोसिस बना रहे हैं, प्लीज डोंट पुट कैंसर गॉल ब्लैडर अनटिल अनलेस वो रेडियोलॉजिकल डायग्नोसिस जब वो स्पाइरल वाल पर फीस्टर के पास नेक के पास प्रेजेंट है, कैंसर प्रेजेंट है, गॉल ब्लैडर स्मूथ लम्प मिल सकता है उसमें, लम्प समथिंग विच वुड लुक लाइक पेरियम्पेलरी कैंसर। ठीक है, तो ये सब तो बता ही दिया। ये बेसिकली ये फ्लो चार्ट ये बता रहा है कि हम चलते कैसे हैं, what constitutes early gallbladder cancer. Up to T2 you can safely say it is early gallbladder cancer, but T3 में एक डिबेट है, कल से हमारे और अक्षय जी के बीच में युद्ध चल रहा है टाटा में, और वो कहते हैं कि द लिवर इन्वॉल्वमेंट शुड बी मोर देन 2 centimeter. What my understanding is, my understanding of other my colleagues is that anything above T3 plus T4 involvement of pancreas, duodenum, colon, other organs and vascular organs is a locally advanced cancer gallbladder. लोकली अर्ली गॉलब्लैडर कैंसर गए, कार खरीदी, ले आए, यानी देखा, इमेजिंग से डायग्नोसिस बनाई. वी डू नॉट अटेम्प्ट टू मेक साइटोपैथोलॉजिकल डायग्नोसिस इन पेरियम्पेलरी कैंसर, हेड ऑफ पेनक्रियाज एंड कैंसर गॉलब्लैडर बिकॉज इमेज बेस्ड डायग्नोसिस इज सफिशिएंट. याद रखना, द मोमेंट यू आर in a needle in the patient's abdominal cavity, it simply tells the examiner, it simply tells the patient that disease is inoperable. You are trying to offer patient something else which upfront surgery cannot be done. ये ध्यान रखना है. तो इसमें क्या हुआ कि अर्ली सर्जरी में रेडिकल कोलिसिस्टेक्टमी करते हैं. T1A केवल मीसम म्यूकोजा में है तो भैया T1A में लैब कोली सफिशिएंट. T1B onwards up to T2 radical chole is sufficient. Radical chole entails 2 centimeter of the non-anatomical, non-neoplastic liver and up to segment posterior superior pancreaticoduodenal lymph node, clearance of the lymph node. ठीक है, इतनी सी बात याद रखना है. अब जब एडवांस ट्रीटमेंट करना है, इसमें सिस्टमिक कीमोथेरेपी आ गई, नियर जोन कीमोथेरेपी आ गई, पेरी ऑपरेटिव आ गई, एडजॉइंट आ गई, पैलिएटिव आ गई. विल टॉक अबाउट देम. ये थोड़ा सा आपके लेवल का बियॉन्ड है. ये वी हैव टॉक्ड अबाउट इट. तो इसमें क्रॉनिक ये हमारे लिए बहुत इंपॉर्टेंट थी. ये भी कॉमनली हो रही है, हेपेटाइटिस बी एंड सी. वायरल इन्फेक्शंस केवल हेपेटाइटिस बी और सी के और भी होते हैं. प्राइमरी स्क्लेरोटिक कोलिंजाइटिस एंड एब्नॉर्मल पैंक्रियाटिक बिलियरी डक्ट जंक्शन. ये भी इसके अंदर क्या होता है, एब्नॉर्मल पैंक्रियाटिक बिलियरी डक्ट जंक्शन में क्या होता है कि जो स्मूथ मसल का वॉल्व होती है, वैल्व की जो वॉल होती है वो अच्छे से बनी नहीं होती है, अपना काम ढंग से नहीं करता, थोड़ा रिफ्लेक्स होता रहता है. और जब पैंक्रियाटिक बिलियरी जूस मिलते हैं तो एक्टिवेट होते हैं, इन्फ्लेमेटरी कैस्केड बनता है और वंस अगेन वहाँ पे इन्फ्लेमेशन का माहौल बना रहता है. फिर दूसरा ये आया जियोग्राफिकल फैक्टर. ये मैंने आपको बता दिया और ये याद रह जाए. केरास आपको थोड़ी बहुत आपने पढ़ी होगी, BRCA2 पढ़ी, BRCA1 पढ़ी होगी, एपिडेमिनल ग्रोथ फैक्टर पढ़ा होगा एंड TP53 पढ़ी होगी. इसलिए आपको बस याद आ जाए तो अच्छी बात है, बिकॉज दीज आर दी कॉमन रिस्क. नहीं चल रहा है ये. वी हैव कम टू ये स्टेजिंग है जस्ट टॉक. तो स्टेजिंग में ड्वेल करने की ज़्यादा जरूरत नहीं है. स्टेजिंग में समझने की चीज़ ये ज़रूरत है कि व्हाट डज स्टेजिंग टॉक अबाउट. स्टेजिंग में दो चीज़ें हुई कि अर्ली गॉलब्लैडर कैंसर क्या है, लोकली एडवांस कैंसर गॉलब्लैडर क्या है, ये समझ में आना चाहिए. आई होप यू हैव अंडरस्टूड व्हाट इज लोकली एडवांस कैंसर गॉलब्लैडर एंड अर्ली गॉलब्लैडर कैंसर और गॉलब्लैडर कैंसर और लोकली एडवांस गॉलब्लैडर कैंसर. मेटास्टैटिक आपको पता ही चल जाएगा, उसको तो बताने की जरूरत नहीं है. इसमें बस एक चेंज जो AJCC 7 से आया है, वहाँ पे N1 और N2 लोकेशन बेस्ड थे. N1 was pericoiloidal and N2 was anything above that is or celiac trunk was inoperable and it was N2. आज के डेट में कहते हैं less than 4 positive and less than 3 positive with N1 and more than 3 positive is or more 4 and more is N2. इतनी सी बात होगी. गॉलब्लैडर कैंसर में कितने लिम्फ नोड पॉजिटिव हैं. इसकी एक सिमिलर एनालॉजी है ओरल कैंसर से. द ग्रेटर नंबर ऑफ द लिम्फ नोड्स आर पॉजिटिव, ग्रेट पुअर इज द प्रोग्नोसिस. दूसरी चीज ये है. इतनी सी बात है, इसलिए समझ आना चाहिए ये. अब इससे मैं बता रहा था कि व्हाट इज व्हाट कॉन्स्टिट्यूट लोकली एडवांस कैंसर गॉलब्लैडर, तो ये बात होगी T3 एंड T4। इसमें ये बात इन्होंने भी कहीं ना कहीं से लाए होंगे, मोर देन 2 cm द लिवर। द रीजन इज व्हेनेवर मोर देन, वो व्हाई लिवर इज इन्वॉल्व इंपॉर्टेंट, इन्वॉल्वमेंट ऑफ लिवर इज इन्वॉल्व क्यों इंपॉर्टेंट है, इनको जगाओ। लिवर इन्वॉल्वमेंट का इंपॉर्टेंस ये है, जैसे ही लिवर इन्वॉल्व हुआ वैसे लिम्फ मेटास्टेसिस बहुत ज़्यादा बढ़ जाती है और डिस्टेंट मेटास्टेसिस चांसेस बढ़ जाती है। तारीख में ये लोग ये कहते हैं कि गॉलब्लैडर कैंसर में वी हैव टू बी एग्रेसिव टुवर्ड्स लिम्फ नोड डिसेक्शन, जो हम लोग इधर आजकल परसीव कर रहे हैं, रादर देन लोकल डिसेक्शन, ठीक है। और इसमें आप देख ही रहे हैं कि ये टाइप 1 एंड 2 ब्लॉक है, नोडल स्टेटस अगर पॉजिटिव है, प्रेडिक्टिव पैनक्रियाटिक 13 है, पोस्टी है, सुपीरियर पैनक्रियाटिक और ड्यूडनल इंपॉर्टेंट है, और हाइलम चला गया है। तो ये सारे इन्वॉल्वमेंट ऑफ स्टमक, ड्यूडनम, कोलन, ये सारी चीज़ें बता रही हैं कि ये डिजीज बहुत बढ़ गई है, एंड दीज ऑल कंस्टिट्यूट लोकली एडवांस कैंसर गॉलब्लैडर। लेकिन हम इनको इसलिए क्लासिफाई करते हैं दैट स्टिल एट दिस पॉइंट ऑफ टाइम दे आर ऑपरेबल फॉर सम पेशेंट, स्टिल ऑपरेबल, but not every center can do it. In those patients where the pancreas is involved, people go for hepatopancreatic duodenectomy. But the selection of these patients is different. It should be done in those who have very good performance status. It should be done by a surgeon who has done a lot of these kind of patients, and there are very good facilities to cater to these in ICU conditions, because these patients are likely to land up in ICU and for ठीक है, इसलिए इस ग्रुप को हम जानते हैं। तो इस ग्रुप में क्या कर सकते हैं? अभी तक क्या था, अभी तक का मतलब है 8-10 साल पहले तक वी हैड नो कीमोथेरेपी एक्सेप्ट सिस्प्लैटिन एंड दिस। फिर लोगों ने देखा कि अगर हम जेमसिटाबीन या कैप्सिटाबीन एडजुवेंट ट्रीटमेंट में देते हैं, दीज पीपल इंप्रूव, देयर सर्वाइवल इंप्रूव रिसेक्टेबल गॉलब्लैडर कैंसर में। नाउ अनदर थिंग हैज कम that in these group of patients where the cancer gallbladder is locally advanced cancer gallbladder, वहाँ पे a definite role of neoadjuvant chemotherapy has come, ठीक है। definite role of neoadjuvant chemotherapy has come। अब जब आ गया है तो आपको पता चलेगा कौन से पेशेंट में की neoadjuvant chemotherapy देनी, इनमें देनी those who are locally advanced cancer gallbladder। अब nearly at you need to have a cytological diagnosis in your hand. Then for this you will need ultrasound guided FNAC और true cut biopsy। ये आपको बिल्कुल MS में आना चाहिए, ये नहीं बोला आपने कि साहब हम लोग ऐसा नहीं करना है। ट्रू कट अल्ट्रासाउंड गाइडेड इंडेड बायोप्सी करनी है इन खास कर पेशेंट में, क्योंकि इस कोहर्ट में थर्ड और T1 T2 में थोड़ा गर्म पानी दे दीजिएगा। T1 T2 में सवाल में जमीन आसमान का अंतर।
Then should we straight away go for
If you have got expert
में और T2 में with adjuvant chemotherapy you can think of 5-year survival of 70-80%। कुछ T1 मिक्स ग्रुप है इसलिए आपको ज़्यादा लग रहा है, बट इसमें बहुत कम है, इसमें मंथ्स में। लेकिन वहीं अगर आपने नियोजन कीमोथेरेपी ऐड कर दी तो सर्वाइवल बहुत अच्छा हो रहा है। देन ये जो 8 महीने था, 15 महीने था, इट बिकम 24 मंथ, इट बिकम 3 years, एंड विच इज अ वेरी गुड सर्वाइवल फॉर अ पेशेंट एंड अ डिजीज एज बैड एज कैंसर गॉलब्लैडर। तो आपको ये करना है, जहाँ पे लोकल एडवांस कैंसर गॉलब्लैडर है वहाँ आपको प्लेनली के आधार पर आप कीमोथेरेपी नहीं दे सकते, क्योंकि जब आप प्रोसीजर करते हो आप बोलेंगे हम सर्जरी तो कर देते हैं, सर्जरी में करते हैं, इट सर्व्स एज अ थेरेपेटिक प्रोसीजर, इट सर्व्स एज इन्वेस्टिगेटिव प्रोसीजर। आपने बायोप्सी करी उसमें आ जाता है मोस्टली। तो कीमोथेरेपी देनी, अब कीमोथेरेपी क्या देनी है, तो नियोजन कीमोथेरेपी देने से पहले पेशेंट के अंदर रहेगा कंसेप्ट बिल्कुल ब्रेस्ट की तरह है, डाउन स्टेज एंड ऑपरेट। ब्रेस्ट में भी जैसा कंसेप्ट है वो इसमें भी वही कंसेप्ट है, डाउन स्टेज एंड ऑपरेट। आप नियोजन कीमोथेरेपी देते हैं, क्या देते हैं दूसरा प्रश्न ये। नियोजन कीमोथेरेपी में आप जेमसिटाबीन सिस्प्लैटिन कॉम्बिनेशन दे सकते हैं, एबीसी ट्रायल है, पोल्का जीबी ट्रायल है, टोपाज ट्रायल है। मैं छोटा छोटा बस आपको नाम बता रहा हूँ। इसमें देखा गया कि इसमें जेमसिटाबीन सिस्प्लैटिन कॉम्बिनेशन से सर्वाइवल बढ़ जाता है। डायग्नोसिस करी, कीमोथेरेपी दी और आपने डाउन स्टेज किया, not only patient becomes operable, the chances of getting a negative resection margin also increases। दोनों चीजें, जिस व्यक्ति में बगैर सर्जरी, बगैर नियोजन कीमोथेरेपी की और कीमोथेरेपी के बाद अगर मार्जिन नेगेटिविटी स्टेटस अचीव हो जाता है, उनका सर्वाइवल नीडलेस से बढ़िया होता है उसको हर्ट में, ठीक है। तो दूसरी चीज ये है, यदि इससे लाभ नहीं मिला तो उसमें आप कैप्सिटाबीन के बजाय, आप सिस्प्लैटिन के बजाय कैप्सिटाबीन ऐड कर दीजिए। कुछ लोग कैप्सिटाबीन भी दिया है, बट वो अलोन, जेमसिटाबीन अलोन इज बैड, combination of gemcitabine cisplatin is good, combination of gemcitabine capecitabine is good, combination of gemcitabine and oxaliplatin is good. उसके बाद सेकेंड लाइन ड्रग्स आ जाती है, फोल्फॉक्स आ जाती है, फोल्फिरी आ जाती है. उसके बाद कॉम्बिनेशन आ जाता है पीडीएल इनहिबिटर जो ब्रेस्ट में पढ़ा रहे थे वो, है ना, चेक पॉइंट इनहिबिटर वाले में आप पढ़ा रहे थे, ये देने से भी कॉम्बिनेशन में देखा गया कि सर्वाइवल बहुत अच्छा हो गया. ठीक है, तो हम लोगों ने कहानी शुरू करी गरम, कहानी शुरू करी हम लोगों ने कैंसर में. T1A sufficient for laparoscopic cholecystectomy is good. T1B onwards radical chole which entails non-neoplastic 2 cm liver, उसके बाद and lymph node dissection. और lymph node dissection पे आपको जोर इसलिए भी दिया जा रहा है क्योंकि aggressive disease, ये lymph node positivity is a single most important prognostic factor. Lymph node positivity is single most important prognostic factor. दूसरी चीज ये देखी गई है. ठीक है, तो ये आ गया एग्जैक्टली वही बातें हम लोग कर रहे हैं. ठीक, ये बस इसमें ये चीज इंपॉर्टेंट है कि जिसमें पर प्राइमम सर्जरी कर पाए उसमें नियोजन कीमोथेरेपी देने का कोई फायदा नहीं है. उसमें हम लोग को फिर भी करना, उसमें अर्ली सर्जरी करनी है. और बाकी सब में ये है डाउन स्टेज एंड सर्जरी, ये डेटा है, ये बताता सर्वाइवल बढ़ गया है. ये सीयर डेटा है, आपके लिए पर्याप्त है. इतने ऑनगोइंग है, ये भी आपके लिए पर्याप्त है. इसमें ये समझ लें कि कुछ स्पेसिफिक कंडीशन में पेशेंट को रेडिएशन भी दिया गया है. रेडिएशन भी हेल्प करता है. रेडिएशन देने के पीछे प्रॉब्लम ये थी कि हम लोग वो नहीं कर पा रहे हैं, फोकस नहीं कर पाते हैं, लेकिन IGRT आगे सब दे सकते हैं रेडिएशन भी. तो अपफ्रंट सर्जरी करना ज़्यादा फायदेमंद है इस कंडीशन में. अपफ्रंट सर्जरी में इस कंडीशन में, जिस कंडीशन में ये है, मतलब अपफ्रंट सर्जरी जिसमें कर सकते हैं उसमें नॉन न्यूप्लास्टिक लिवर का उतना रोल, उतना ही फायदा है जितना सेगमेंट 4B और 5 क्लासिकल निकालना है. लेकिन जिसमें सेगमेंट 2 इन्वॉल्व लिवर इन्वॉल्वमेंट ज़्यादा है उसमें प्रोबेबली यू माइट हैव टू थिंक मोर इन दी फेवर ऑफ अ क्लासिकल 4B और 5 रादर देन लिवर रिसेक्शन ओनली. ठीक है, एग्जैक्टली द सेम चीज़ हम लोग बात कर चुके हैं, इसमें बहुत ज़्यादा टाइम नहीं लगाना है. एक आप लोग वो करते हैं पोर्टेबल नेबुलाइजेशन की हम लोग बात करते हैं. अरे भाई तू जाके जस्ट इसको जगह दे, पानी पी ले, गिव हिम सम वाटर. तो पोर्टेबल नेबुलाइजेशन की बात जब करते हैं उसमें क्या करते हैं हम लोग की, तो आर्दो रिसेक्शन का मतलब हो गया कि जब हमने डिजीज निकाली तो पेशेंट को कम से कम बढ़िया सर्जरी का फायदा देते हैं. अब उसमें क्या है कि जो बड़े एक्सटेंडेड रिसेक्शंस हैं, वैस्कुलर रिसेक्शंस हैं, इनको कोई फायदा नहीं. बट पोर्टेबल नेबुलाइजेशन एक स्पेसिफिक ग्रुप में देखा गया करने से क्या होता है कि आप पेशेंट को आर्दो रिसेक्शन दे. लोकली एडवांस कैंसर गॉलब्लैडर का ग्रुप ये भी है कि डिजीज बड़ी है तो आप उसको ऑपरेट करके निकाल सकते हैं, फैली नहीं है, मेटास्टैटिक नहीं है, इट इज स्टिल लोकली एडवांस. लोकली का मतलब है लोकल एंड लोकली एडवांस है, वहाँ निकालना है. पोर्टेबल नेबुलाइजेशन हम स्टील की कॉइल से कर सकते हैं और बाकी चीज़ों से कर सकते हैं. दैट इज नॉट द क्वेश्चन. क्वेश्चन इज कि इसको करने पे पहले क्या ध्यान रखना है. इमेजिंग का रोल है इसमें, फंक्शनल लिवर वॉल्यूम यानी कितना लिवर बचेगा उसका रोल है. और ये एक कॉम्प्लेक्स बताया जाता है एटॉफी हेपेटॉफी कॉम्प्लेक्स. वो ये बताता है कि भाई साहब आपने दिया तो लिवर रीजनरेट कर जाएगा ना. लिवर रीजनरेट करेगा तो कितना करेगा. नॉर्मल लिवर 20% रीजनरेट करेगा, जिसको कीमोथेरेपी दे चुके हैं या जिसमें कोई प्रॉब्लम है वो 20-30% करेगा. और अगर इसको सिरोसिस है तो ओनली लेस देन 40% लिवर रिकवर करेगा. दिया हुआ है. कहने का मतलब ये है कि जो हेल्दी लिवर है वो ज़्यादा ग्रो करेगा, क्योंकि जब आप एक्सटेंडेड राइट हेपेटेक्टमी करेंगे तो उसमें आप सेगमेंट 2 और 3, सेगमेंट 1, 2 और 3 छोड़ेंगे. 1 तो बहुत छोटा था, वही छूटेगा. तो सर्वाइवल के लिए पर्याप्त नहीं है. आपको सर्वाइवल के लिए कम से कम 3 एक्टिव सेगमेंट या 40% ऑफ द लिवर वॉल्यूम चाहिए. बस इतनी सी बात ध्यान रखिए कि ये करना होता है, इससे ज़्यादा आपको कुछ नहीं करना है. उसके बाद आ गया लिम्फ नोड. मैंने बताया है कि आजकल फोकस और प्रेशर बहुत है लिम्फ नोड डिसेक्शन में, क्योंकि डिजीज़ की सिंगल मोस्ट इंपॉर्टेंट फैक्टर होता है. और इसको निकालने के नहीं तो रिलैप्स बहुत ज़्यादा इनमें होता है. लिम्फ नोड में रिलैप्स होगा और दूसरा वहाँ पे होगा. एनीथिंग बियॉन्ड पोस्टीरियर सुपर पैंक्रियाटिक 16B और जो लेफ्ट इनर वेन के बाद लिम्फ नोड है वो मेटास्टैटिक डिजीज में आता है. सीलेक्ट टंग के लेफ्ट साइड में डिजीज में वो इनऑपरेबल लिम्फ नोड में आता है. तो आपको इतना ध्यान रखना चाहिए. इफेक्ट लिम्फेडेक्टमी करते हैं. तो जब तक ये चला तब तक एक चीज बताते हैं, इसमें एक चीज इंसिडेंटल गॉलब्लैडर. आप करने गए अल्ट्रासाउंड किसी चीज के लिए, आपको गॉलब्लैडर कैंसर मिल गया, उसको वैसे ही प्रिपेयर करके आपको ऑपरेट करना है। दूसरा आपने लैब कोली करी, उसमें गॉलब्लैडर में इंसिडेंटल निकल के आया, उसमें भी कंप्लीशन कोलेस्टेक्टमी करनी है। प्रश्न सिर्फ इस बात का कि कब करनी है। मेजॉरिटी ऑफ द पेपर ये कहते हैं कि कम से कम 4 हफ्ते के बाद और 12 हफ्ते से पहले इस ग्रुप में सर्वाइवल सबसे अच्छा देखा गया। ठीक है। तीसरी चीज आती है कि पोर्ट साइड मेटास्टेसिस को रिसेक्ट करना कि नहीं करना, ये सब बेयर कर दिया। राइट हेपेटिक आर्टरी, ये लेफ्ट गैस्ट्रिक आर्टरी होनी चाहिए, कॉमन हेपेटिक आर्टरी के पास आता है। देखिए, लेट मी सी, हेपेटिक आर्टरी है। ठीक है। तो तीसरी चीज पोर्ट साइड डिसेक्शन का बहुत ज्यादा फायदा नहीं था, बट रिकरेंस विद पोर्ट साइड रिकरेंस हुई तो कीमोथेरेपी एंड सर्जरी करनी है, और उसको रेडिएशन देना है तो पोर्ट साइड को उसमें इन्वॉल्व करना है। चौथी चीज बहुत ज़्यादा आती है कि पेट सीटी कराना नहीं कराना। पेट सीटी का इन कंडीशन में रोल इसलिए कम है कि पेट सीटी डिपेंड करता है वॉल्यूम ऑफ द ट्यूमर के ऊपर, पेट सीटी डिपेंड करता है एग्रेशन ऑफ द डिजीज पे, पेट सीटी डिपेंड करता है ऑन द अमाउंट ऑफ यूग्लाइसीमिया पेशेंट हैज़। तो पेट सीटी का बहुत ज़्यादा रोल नहीं है। जैसे आजकल ब्रेस्ट में लोग कहते हैं कि पूरा ऊपर से सीटी कराना, पेट सीटी करा लो। कुछ लोग एडवोकेट क्या करते हैं कि पेट सीटी कराया जा सकता है कैंसर गॉलब्लैडर के पेशेंट में, खासकर जब वो बड़ा हो, क्योंकि माइक्रोमेटास्टेसिस मिल सकती है। प्रॉब्लम सिर्फ थी कि माइक्रोमेटास्टेसिस होगी, वॉल्यूम कम होगा तो उसमें दिखेगा नहीं, तो अभी भी स्टैंडर्ड केयर नहीं आता है। इट इज मोर ऑफ योर ओन इंटरेस्ट एंड सर्जिकल वर्क। रोल नहीं, इसलिए आपको पता होना चाहिए। थैंक यू। अभी घंटी नहीं बजी, पूछ सकते हैं, कोई क्वेश्चन पूछ सकते हैं। नियरली सम तक पूछ लीजिए कुछ। अब लीजिए, आप पूछ लीजिए। बहुत बढ़िया, अब लीजिए, आप पूछ लीजिए। एनीवे, थैंक यू, देयर इज नो क्वेश्चन। थैंक यू। बहुत बढ़िया, खांसते हैं। एनीवे, थैंक यू, देयर इज नो क्वेश्चन। थैंक यू।
Thank you, sir. May I invite Professor Pava, sir, to kindly. Thank you, sir. May I invite Professor Pava, sir, to kindly. May I now invite Dr. Mani Agarwal, sir, to deliver his lecture on opening inguinal hernia repair. Sir is a minimally invasive surgeon and abdominal wall reconstruction surgeon, and he's also deep involved in the academics of the department. We welcome you, sir.
First of all, I would like to thank the organizing committee for giving me the opportunity to present on the open inguinal hernia, lichen steni, etc. The standard disclosure that most of my cases are laparoendoscopic rebook and the articles, and the copyright holds with the originators. So hernia. So the first question that as a resident you will be asked in the examiner, what is the definition of hernia? So hernia is abnormal protrusions. The abnormal word is very important. Abnormal protrusion of an organ or the tissue through the defect in the surrounding wall, because the examiner will ask you that if you protrude the tongue, is this a hernia? This is not hernia, because this is not the abnormal protrusions. So coming to the directly to the groin hernia, the incidence of lifetime groin hernia in men is 27 to 43%, and in women it is 3 to 6%. Most of the cases of the groin hernia are symptomatic, and only cure for the groin hernia is surgery. However, in a small selected patients, we can treat by the wait and watch, but this small subset should be defined, and patient must be informed when we are going for the wait and watch that there is an incidence of 70% in these patients for taking up for the surgery in the next 5 years. Worldwide, hernia is the most common surgery. This is bread and butter for the general surgeon. So every PG must be knowing that what are the treatment options and will be well versed with all the techniques, because this is one of the most commonly done surgery, more than 20 millions done annually globally. And the incidence of recurrence, if we will combine all the type of the open surgery, non-mace repair, globally the reported incidence is still 10 to 15%, incidence of the chronic pain is 10 to 12%, and the severe chronic pain is 1 to 3%. The most challenging thing is that which surgery, when we see that what are the options to repair the groin hernia. So we will be confused, like the topic also, open inguinal hernia, Lichtenstein, etc. There are plenty of the technique that is declared in the literature. So which technique in which pain, it is very difficult. So why this confusion is there? What we want? We want a technique which has a low complication rate, low complication in the form of low recurrence after the surgery, having the less incidence of the chronic pain because it is going to alter the quality of life of the patient, having fast recovery so that hospital stay will be less and patient can resume his daily activity as soon as possible, because this is one of the most common surgery done globally, easy to learn, it can be reproducible, that other newer generation can learn so that it can be reproduced, it can be done at the all the center, and having the reproducible, just only that it can be taught to other doesn't mean, but the results should be at par with the best center, and the most important that it should be cost effective. If a surgery is there which have all the characteristic but it is not cost effective, then it will be not accepted in the all the countries. So going for the options, what are the options that we have? So this is a just diagrammatic that which option. So one is the herniorrhaphy, that means we are going to repair the genes with the local tissue or the thread only, and another is the hernioplasty where we are going to put a patch of other tissue or the mesh to repair the things. When we are talking about the open inguinal hernia, we should remember these 4 persons because there are the more than 100 methods to repair, but at present the 4 methods are still practiced worldwide: Basni's, Soldi's, Lichtenstein and the Dasarda. So at present other options are, for the non-mesh we have the 3 options: Soldi's, Dasarda and Basni's. For the open mesh we have the Lichtenstein tips, plug and patch, reeve stoppage and endoscopic. My colleague will be talking, but at present also the open inguinal hernia is globally practiced most common surgery for the groin hernia. However, in Australia and Switzerland, laparoendoscopic has overtaken number, because these are the data from the registry that the total number of the cases done in that country, how many percentage is laparoendoscopic. So they are the 2 countries, Australia and Switzerland, where the most of the cases are done by the laparoendoscopic way. So there are the various classification for the hernia. There is the country from which the surgeon describe, they give their name. So there is a very much confusion about the name, diagnosis, treatment protocol, because there is no uniformity. So all the hernia surgeon across the globe, like the American Hernia Society, European Hernia Society, Asia Pacific, all combined, major hernia society combined and form the hernia surge, and they are coming with the regular update regarding the classification, management, and this is the their latest updated version where you can see now in this is the October 2023 version where they say that mesh repair is the best repair. The first thing is that we use the mesh repair. If we are not using the mesh, the last statement is there, if mesh is not being used, then the Soldi's repair at per their recommendation is the best repair. The second point here, it is very important that if we are going for the stoppage repair like or the pre-peritoneal, we can do the lap also, but the open also, but when we are doing the open, we are breaching both the anterior and posterior plane. That's why it is not practiced commonly. This is the major update in this guideline. Previously they says that for the unilateral hernia in the both the in the male, Lichtenstein is the treatment, the first given the priority, but now they have updated that laparoendoscopic method, it depends on the surgeon expertise, whether he is expertise in the TEP or the TAPP. We have to go for that if the patient characteristic is fulfilling, local logistic is there and surgeon is experienced. The last recommendation for all the patient, all the sexes, primary rectal hernia, laparoendoscopic technique is preferred. So, talking about that open hernia, so this is the recent publication. Our institute also participated in this collaborative study and we are also the part of this study, which is done over the 83 countries involving 18,000 patients. And just see that there are the 4 classes of the patients are there. So, high income, upper middle income, lower middle income, lower income, and out of all the patient in the higher income, just you will see 70% are by the open and 26. Even in the high income, 70% of the cases are done by the open method. This is the truth. This is the article in 2024 and the data has been taken 2023 to 24. So, this is the latest picture. In the upper middle income countries, it is the 72%. However, India belongs to lower middle income countries. Here the data is 87% and lower income countries it is the 98%. So, this is the chart. We are seeing that what is the truth, which is the surgery which is practiced globally most commonly. Now, coming to the risk factor for the recurrence. So, there are the few modifiable risk factor, few non-modifiable. So, we always have to see that what are the risk factors for the patient, and if it is any modifiable risk factor, then we have to replace that or try to treat that modifiable risk factor. Among the recurrence, female, direct inguinal hernia, if the surgeon's experience is limited, sliding hernia, diminished collagen 1/3 ratio, increased matrix maternal protease, obesity or incorrect surgical technique. These are the factors which can lead to the increased risk of recurrence after the inguinal hernia surgery. So, we have to identify which surgery or the which patients. So, at present there is no classification which is accepted globally. So, you have read about multiple classification given in your textbook and you which is Gilbert, Stopa, Nahes and examiner will ask you. So, there is a very much variations. If there is a variation in the classification, how you will calculate the outcome globally, because another person is using another classification and giving the outcome according to that. So, hernia surge has decided that there should be one uniform classification globally which can be practiced. So, now this is very important for the resident. European Hernia Society has given and hernia surge has also recommended that every surgeon should be using this classification, so that we can compare the results of hernia open laparoendoscopy globally. If we do not have the classification, why the TNM classification is there? So, that we can stage the disease and then we can predict the prognosis. So, for like the hernia also, first is the staging. So, staging you have to have the classification. So, this is the classification. I am not going into the detail of the classification. Now, coming to the open inguinal hernia repair, the first important is the anatomy. So, this is tubercle, this is the anterior superior spine, this is the inguinal ligament, this is the ligament of the Cooper's. So, and this is the lacunar ligament. This is very important. Now, the principles of groin hernia repair, that we have to cover the myopectineal orifice adequately. So, this is very important. So, the boundary of myopectineal orifice is superiorly by the conjoint tendon, inferiorly by the Cooper's ligament, medially by the rectus abdominis, laterally by the iliopsoas muscles, and it is divided by the inguinal ligament. This is very important, and this is the laparoendoscopic view. The next speaker will cover, so I am not going into the details of this. And this is the Hasselbeck triangle, again important for your boundary. Here is the laterally is the inferior epigastric vessel, medially is the rectus muscle. This is the rectus muscle, inferiorly is the inguinal ligament. This is the inguinal ligament. Now, coming to the anatomy of the nerve, because one of the more common complication of the open inguinal hernia is the various nerves are passing through that area. So, that is very important. So, this is the iliohypogastric nerve coming here, and supplying to this. This is the ilioinguinal nerve coming here, going into the scrotum, and this is the genitofemoral nerve divided into the two parts, genital branch and the femoral branch, and this is the genital branch that is going. So this is very important that we should be knowing that how these nerves passes through the plane. I am not going into these. Now pre-operative planning, I told you that modifiable risk factors. So these modifiable risk factors are the chronic constipation, chronic cough, prostatism, nicotine use and the antiplatelet. Before taking up the surgery, for any of the surgery, we have to the patient for these, because these are the modifiable risk factor. Now coming to that, there are the so many methods. Why lichen? So the answer is, it is the most commonly used globally and the best evaluated. So it has tested the time. It is started in 1984 and is still being done most commonly. Short learning curve. So it is easy to teach the resident and having the reproducible results. So when the lichen we have compared from the lower income company or the periphery, the results are comparable to the other centers. Less complicated anatomy, so it is easy to teach. Can be done under the local anesthesia, where the general anesthesia or the regional anesthesia is not available. In that case also you can do by the local anesthesia, no major complication, cost effective and having the lower recurrence rate. So these are the points that favors why lichen repair. For the anesthesia, that which anesthesia you have to do the lichen, it can be done under anesthesia, but surgeon should be expertise. If the surgeon is not expertise, the general anesthesia is preferred over the regional anesthesia. Now this is the landmark paper by the lichen. It was published in 1989. The topic was the tension-free hernioplasty. So what was the concept in the tension-free hernioplasty that has changed the landscape of all the open inguinal hernia? Previously before this, soldis was done most commonly globally. So what was the problem in the soldis repair? This was the internal oblique, this was the transversus. What the surgeons want to create, they want to stretch this and want to fix this to the pubic tubercle. So this is not the anatomical where there is a defect. So tissue are not ready to be stretched from here to here. So they are in the tension, that was leading to the rupture of the mesh or the rupture of the tissue or the recurrence rate. So what was this lichen or the tension free? The topic was the tension free hernioplasty. So they told that here, in place of stretching the from here to here, we place a prosthetic mesh in this plane. So that's why it is called tension free hernioplasty. Have you understood? So this image is also from this original journal 1989. So this was the first article. Now coming to the second article. Now why lichen become famous? So they have scrutinized their 4,000 patients, and after their 4,000 patients, they found 4 recurrence, and these recurrence are at 3 of them are at the level of pubic tubercle. So initial lichen repair, if you will go into the literature, they fix the mesh at the pubic tubercle, and then they change the concept that mesh should go 2 centimeter beyond the pubic tubercle behind the spermatic cord. So just you have to think that the inguinal ligament. So they told that there should be the enough relaxation of the mesh so that it can be fixed. So this is the, in 1995 they came up with the data that since 1984 they have done the 4,000 cases. 4,000 cases, they have the record of all the cases, and they followed the patient for 11 years and they come up with a 4 recurrence, and the detail that in those 4 cases what went wrong, that made this hernioplasty gold standard in that time. So after that lichen in 1985, one of the member after the lichen clinic was handed over to the Professor Ahmed. So he has modified what we is the amide modification of lichen-stein. Many of us still practice the lichen-stein, but Amide had modified, and the later on David Chen, he is currently the director of lichen-stein clinic. So they have modified. What they say, they have changed the infiltration technique from the field block. Cord elevation has to be done 2 centimeter above the pubic symphysis. We have to preserve the cremasteric. Sac inversion should be done compared to sac ligation. The size of the mesh initially described was the 5 to 10, they changed to the 7 into 15 centimeter. There should be mesh overlap. So mesh should be relaxed because mesh contraction is there, and when we are fixing the two tail, we have to fix the two tail behind the deep ring, beyond the deep ring, and above should be fixed by the interrupted absorbal suture over the conjoint tendon, because there is the iliohypogastric nerve, and lower is with the permanent on the lower side. So these are the, so first we will palpate the pubic tubercle. I think everyone should be knowing how to do lichen-stein. So this is very important. Second, we have to palpate the anteesophageal spine. This is the midline. After that, we will mark the incision line. Usually the incision line extends from 5 to 6 centimeter. And then divide the skin and subcutaneous tissue. After dividing the skin and subcutaneous tissue, we will get the superficial fascia. So it will be superficial fascia, campus fascia, fatty layer. You are seeing the fatty layer. So we are dividing. So if you will go over there, you will identify all the layers. These are the venous escarpage fascia. So after that, you are be able to see the external oblique, beautiful external oblique. This is very important that you should identify the superficial ring also. And then you will give a small nick over the external oblique. Why? Just below the external oblique is the ilioinguinal nerve. So you have to give, and this is the way that first you have to spread the seizure so that if any nerve is below the external oblique, it should fall below. So this is very important, that you will just first insert the seizures, spread it so that if any inguinal nerve is adhered to the below surface of external oblique, we can divide it. So this is very important, and we have to open the ring. So this is the most important. After doing this, most of us do the finger dissection. As per the Amide modification or the David Chen modification, we avoid. Why? There is 10 to 18% risk of the chronic groin pain because of the finger dissection. So pubic tubercle, so these are the nerves. When you divide the external oblique, these are the iliohypogastric. Now, how you have to mobilize the spermatic cord, this is important. The avascular plane is over the pubic tubercle. So we have to mobilize the spermatic cord over the pubic tubercle, and medially it is attached with the conjoint tendon. Here you can do the sharp dissection also. There will be no bleeding because this is also avascular. So these are the avascular plane, and this is the area where we should be separating the conjoint, this cremasteric from the spermatic cord from the floor of the inguinal canal. And if you will do this, you do not have to do any finger dissection. Easily you can hook the spermatic cord. After doing this, you have to from the posterior layer or the floor of the inguinal canal. After doing this, the most important that at the deep ring, you have to identify the inferior epigastric artery and the vein, because this is the limit of the floor dissection. Because if you will not dissected this area, there are the chances of increased chances of hernia. This is the genital branch of the genitofemoral nerve. So nerve anatomy is very important. If you will not focus on the nerve anatomy, you will be not if you will be mindful, you can reduce the incidence of pain to the less than 1%. After that, you have to divide the layer of the spermatic cord, external spermatic fascia, cremasteric fascia, and internal spermatic. This you all can do the with with the sharp dissection, no finger dissection to dissect this. If you will do, and then you can identify the sac, you have identified the sac, no ligation, just inversion of the sac, that is enough in simple cases. Now we have measured the distance from the pubic tubercle to deep ring, so that many people what they do, they place the mesh and then do the cutting. So if you can measure, then you can shape the mesh before placing into the inguinal canal. This is very important. The first thing that you have to fix is at the pubic tubercle, not over the with the bone, but with the ligament, and then you have to fix with the lower part of the inguinal ligament or incurved part of the inguinal ligament. And then you have to take the most important is the lower border of upper flap and lower border of lower flap, you have to fix with the incurved part of the inguinal ligament, because this will create the neck at the inguinal deep ring. And then you have to take the two sutures at the conjoint tendon, making sure that you are not taking the bite from the ilioepigastric. And then you have to close the external oblique, fascia and the others. So this is again the Dasarda repair, which is commonly in the emergency, that is, so it is like the same, initial dissection is the same. Here at the lower border of the this spermatic part, we divide the external oblique from deep ring to the superficial ring, and after that upper flap has to be fixed with the incurved part of the inguinal ligament. This is the upper oblique and fixed with the interrupted suture with the incurved part of the inguinal ligament. So what is happening, upper lip is fixed with the incurved part of the external oblique, below is the conjoint tendon. Then you have to feel the upper border of the conjoint tendon, and this part you have to make the incision. So what will happen, this flap will act as a mesh, this flap, because lower border is fixed with the inguinal ligament, and this upper border you have to fix with the conjoint tendon. So upper border you have to fix with the conjoint tendon. This is very important, Dasarda technique. And then you have to upper and lower border of external oblique you can close. So this is the way that we have to do the Dasarda technique. And he is a surgeon from the Pune, Indian surgeon who is doing that. So what are the precautions for that? The main precaution, lichen is the elevation of the cord at the pubic tubercle, preservation of the cremastic muscles, avoid manipulating the nerves, inversion of the sac, mesh overlap, and permanent sutures on the lower, absorber at the upper. This as per the Lichtenstein clinic. However, hernia surge has told that delayed absorbable sutures should be used at all over the places. So this is the change. There is a difference between the Lichtenstein and the European Hernia Society or the hernia surge guideline. Overall complication rate, recurrence rate is 5 to 15%, chronic postoperative. This is the global picture. So that's why hernia Lichtenstein recurrence is 0. At the other center it is the 2%. So there is a depending on the center. Chronic postoperative pain is 10 to 12, wound infection 2 to 10%, urinary retention 1 to 20, sexual seroma 0.5 to 12, bowel bladder vascular injury are the rare injury. So the last and the most important, that symptomatic inguinal hernia should be treated surgically. Surgical treatment should not be like if you have a hammer you will try to fix every nail. The surgical treatment that is given to the patient should depend on the surgical expertise, means the surgeon who is doing, how much he is confident, knowledgeable, patient and the hernia characteristic, that is very important, and what are the resources available to you. That should decide that what surgery you are offering to the patient, and mesh repair overall is the first choice. Thank you, and he is Dr. David Chen, Director of Lichtenstein Clinic, America.
Thank you. I request Professor Avnish Kumar sir to kindly felicitate sir. Thank you. I request Professor Avnish Kumar sir to kindly felicitate sir. Our next lecture is on transabdominal pre-peritoneal repair for inguinal hernias. Sir will be delivering it, and sir specializes in minimal access approach for GI and hernia surgery. Our next lecture is on transabdominal has developed hand at minimal invasive surgery and is an authority delivering it. And sir specializes in minimal access approach for GI and hernia surgeries and bariatric surgery. Sir has developed deft hand at minimal invasive surgery and is an authority in this field. Welcome.
नहीं इसमें डाल इसमें लो कहाँ है पॉइंटर कोई बात नहीं हम ऐसे कर लेंगे यहाँ डाल नहीं इसमें डाल इसमें लो A very good morning to कोई बात नहीं all. See, after a very wonderful lecture, now we'll be going for the laparoscopic version, endoscopic repair of inguinal hernia. A very good morning to see whatever you have been taught. See, after a very wonderful lecture, forget. Now we'll be going for the laparoscopic version. You don't try to correlate the endoscopic and inguinal hernia with the open. See, whatever you have been taught. Okay. You have to just forget the job of for few moments. Endoscopic because you don't try to correlate the endoscopic anatomy, especially TPP, transabdominal pre-peritoneal. Okay. So I am assigned with the job of see as far as inguinal hernia repair, Dr. Manish with relevance has given me, especially TPP, transabdominal. Lichen or overall. In open inguinal hernia repair is most commonly performed procedure. Like Dr. Manish has given just the best one. And you have to learn overall before going for open inguinal hernia repair is most commonly performed procedure. Lichen you have to read and you have to learn everything that this is next step actually. Understand, it's not like कि आप बहुत ज़्यादा उसके लिए बहुत हो जाओ कि इंडोस्कोपिक हमको नहीं आता, बहुत दिक्कत है. लैप्रोस्कोपिक थोड़ा बाद में आता है, ठीक है. Of course, there are various methods to do inguinal hernia repair by the endoscopic route. These are TAPP, transabdominal periperitoneal, totally extraperitoneal. Nowadays people are doing enhanced totally extraperitoneal or extended totally extraperitoneal. And of course, if you see, all of them is learning curve. Someone is bit easier as compared to other. That's it. Otherwise, all of them have got similar outcome in the form of recurrence. Operative time is of course bit different, but of course once you learn any procedure, it almost is similar. Then I am not going into detail. See what you have just read now. Previously we are taught about inguinal hernia canal boundaries. It is anteriorly external oblique, posteriorly by transversely spacia. Floor is formed by the curving edge of the inguinal ligament, and roof is formed by the arching fibers of the internal oblique and the transversus abdominis. That you have to forget here. We don't have to imagine like that. And what you have to do is, and then again myopectoneal orifice. Pectineal orifice. See, what is the basic principle of hernia repair is, what you have to understand, whatever defect you identify, that has to be covered. That may be direct hernia, indirect hernia, femoral hernia. If somebody asks, what is the point, what you are going to get there, this is actually myopectineal orifice. This is the orifice which is covered by below pectineal ligament and above by all muscles. What are those muscles? I am not going into detail, but myo means muscle, pectineal is pectineal ligament, and this is traversed by inguinal ligament, superior compartment, inferior compartment. Superior compartment is the site for the inguinal hernia, inferior compartment is the site for the femoral hernia. Okay, and that orifice is actually visualized from the inside also. That is known as endoscopic inguinal hernia anatomy. You have to understand it. See, if you just remember rule of 3, says 3 zones, 3 triangles, this is all about inguinal hernia endoscopic anatomy. since my talk is, once you enter into the abdominal cavity, first try to see, visualize these three ligaments. What are those three ligaments here? These three ligaments are the most prominent one which you see. Actually, this is a medial umbilical ligament. This is obliterated umbilical artery. The faint one in midline, it is a median umbilical ligament. This is a remnant urachus. And the lateral one, which is here, it is a fold or elevation given by the inferior epigastric vessels. This is known as lateral umbilical fold. And that is the most important one. Once you enter into it, just try to visualize where is the inferior epigastric vessel. After that, we will plan accordingly. And then, of course, this is the picture which is the most important. Once you enter into the abdominal cavity and then strip up the peritoneum and then try to visualize this one. This is an inferior gastric vessel. Lateral to it, it is known as lateral space. Medial to it, it is known as medial space. Lateral space is known as space of Varicose. Medial is known as space of Rectal. And then there are zones also. And then again this is divided into superior compartment and inferior compartment by the iliopubic tract, which is actually an impression given by the inguinal ligament. If you see here, what I told you, myopectineal orifice here, see this is inferiorly it is by the Cooper's ligament, laterally it is by the ilias and psoas, superiorly it is by the transverse abdominis, medially it is by the lateral border of the rectus muscle. So that is how it comes from the inside also. And whatever we have to do, we have to decide where is the defect, whether the defect is lateral to inferior epigastric vessel. All we want to visualize actually. Once we visualize, job is done. Then we don't worry, mesh size is same, everything is same, but what we have to do is that. And of course, when we go laterally here, these are the nerves which are there, which runs over the psoas, lateral cutaneous nerve of thigh, femoral nerve and femoral branch of genitofemoral nerve. Genital branch of femoral nerve runs along with the spermatic cord. Understand? These are the nerves. What is the relevance of this? Once we try to fix the mesh, we don't try to fix the mesh over these nerves. There is a trick how you fix the mesh. You have to fix the mesh above this iliopubic tract. Understand? Because nerves are supposed to go underneath the iliopubic tract, that is inguinal ligament के नीचे से जाती हैं. अगर if you know the anatomy, the iliopubic tract or inguinal ligament about this. And what I told you, space of medial space, that is the space of Rectal, lateral space of Varicose, and preperitoneal space in front or anterior to the bladder is known as prevesical space. And then this is another zone wise classification, zone 1, zone 2, zone 3. Again this is not a different one. Medial space is zone 2, lateral space is zone 1, zone 3 is vascular space. How it is classified zone 1, zone 2, zone 3? It is the severity of dissection where you can land up into the complications. See, zone 1 has nothing, no vessels. Zone 2 has bones and some of the vessels like corona mortis or abnormal variations, that is zone 2. And zone 3 has external iliac vessels. That is why this, as the severity increases, actually if you go into this for dissection, what will happen? You have more likely chance of go to zone 2 and later on they come to zone 3. See, this is another thing. Some people describe triangles. What are those triangles? Triangle of doom. Triangle of doom is basically it is medially bounded by the vast difference. If it is, this is right sided and laterally cord structures, inferiorly by the peritoneal flail. Triangle of pain is iliopubic tract above, medially by this cord structures, inferiorly again by the these are actually imaginary triangles. These are not exactly the triangles which we imagine actually. So the inferior border of this triangle is altogether is bounded by the pelvic triangle is the site for the femoral hernia. If you see femoral triangle is femoral vessels laterally, lacunar ligament medially, Cooper's ligament below. Understand? This is femoral triangle. If you divide the superior space into two lateral and medial halves, lateral is the site for the indirect hernia, medial is the site for the direct hernia. See, now I come to my topic, that was basically TAPP. TAPP was basically done by Dr. RG in 1991. It is easier to learn as compared to TEP, Dr. Ajay will tell you. And these are the indications basically. What I am concerned here is for the resident, see you don't know कि कौन से वाले केस में क्या केस होना है. आज इंडोस्कोपिक हर्निया लगा हुआ है, पता ही नहीं चल रहा है कि TAPP करेंगे कि TEP करेंगे. ठीक, तो basically it can, anything can be done by any surgeon but expert. But of course there are fewer indications जहाँ पे TAPP करना बहुत अच्छा माना जाता है, जहाँ करना चाहिए. Sure कि this is inguinal hernia, reducible one, non-complicated, TEP is good. Not best, TEP is good. But if you don't know, suppose कि patient is having hernia or not, occult hernia, but somebody has said it is hernia, somebody is saying it is not hernia, then of course you have to go for TAPP, first indication. Then of course if it is a recurrent hernia, because if someone has done by an anterior approach, he must or she must have done with the repair like proline or whatever, sutures might have gone to the deep, and if you do TEP, the space is less already and then your sac or peritoneum may get torn. Understand? So that TEP is not preferred for recurrence. TAPP is preferred. You go inside and see what is there and then you do. First one is occult hernia. Second one is recurrent hernia. Bilateral hernia, of course, most of the time if it is clear, no problem, it can be done by TEP or TAPP, but people prefer it because you get lot of space to TAPP. All other things, like if it is also incisional hernia or it is also uncirculated testis, or in females if it is a femoral hernia, because femoral hernia clinically most of the time it is not visible. So TEP instead of TAPP is preferred instead of TEP. So these are few of the, and then of course undescended testes. Some people are having undescended testes, they are associated with the hernia. So if you want to use mesh or if you want to repair hernia, better you use TAPP instead of. Got it? तो आज मुझे अब ये नहीं बताना पड़ेगा ओटी में कि आज क्या करेंगे. ठीक, मोस्ट ऑफ द डे आज सर क्या करेंगे. देखो सर वही करेंगे जो इंडिकेटेड होगा, पहली बात तो समझ लो. और जो इंडिकेटेड होगा इसका मतलब ये नॉलेज आपको पता होनी चाहिए. 99% ऑफ द टाइम यही करेंगे जो इसमें इंडिकेटेड होगा. अपार्ट फ्रॉम इफ इट इज यूनिलेटरल, डॉक्टर अजय विल टेल कि क्या करना है क्या नहीं करना है. ठीक, समझ गए ये बात क्यों नहीं. लेकिन एक समय ऐसा आता है, यू कैन डू एनीथिंग बाय एनी वे. ठीक, लेकिन बात वो नहीं है विद एनेक्डोटल रिपोर्ट्स कि आज मैंने ये कर दिया, मैंने वो कर दिया. ठीक, see there are fewer steps. Some people say it is a 7 steps procedure, some people say it is 9 steps, some people say it is 10 steps, 11 steps. You break these steps, your procedure into different steps. The one is 10 commandments. This is the best one, accepted one nowadays. What are those 10 commands? Don't go with the 10 commands 1, 2, 3, 4, 5, 6. But of course you have to go like this. What you have to do first? What you have to do first is you have to go inside peritoneal cavity and then try to decide see diagnostic laparoscopy is being performed. We are deciding the landmarks. Then of course this is indirect hernia. Then second one, if you can see, then umbilical ligament. We don't go beyond medial umbilical ligament because there is a risk of injury to the bladder. Then you raise the flap, inferior flap is raised first, you give incision and try to be at the level of peritoneum. What is the principle? Then you have to again then what is the second commandment? The principle is once you have given incision and really trying to raise the flail, that fat should belong to the anterior abdominal wall. See, peritoneum is single cell layer, nothing should be there except the peritoneum. That means, and then you try to go into the medial space first, because medial space is the constant space, because there is a pubic tubercle to be distracted, and you try to see that space, that retropubic space or preperitoneal space first. That is the basic aim. See, this is a White House. This is the second commandment. Once you visualize the White House, sorry, then it is that commandment 3 and 4. See what happens, still you dissect 2 to 3 centimeter below to the pubic tubercle or Cooper's ligament, whatever you want to say, and at this moment only you try to visualize the femoral vein. This is right sided hernia being dissected. This was the case of direct hernia and femoral hernia or not. Then if somebody is having indirect inguinal hernia, you have to dissect in a different way. After visualizing the White House, you have to separate the sac from the cord structures. This is commandment 5, inguinal. Most of the time these indirect hernias are complete hernia. What you can do, either if it can be reduced properly, or you can just ligate the sac and dissect it. I have ligated the sac here and transected it. No need for dissection of whole of the sac from the cord structures. Once you have done this one, then you peritalize the peritoneum from the cord structures, then whatever remained is lateral, peritalize the whole of the peritoneum cord structures at least 5 centimeter below the deep ring, and you have to delineate vas and cord structure separately, so that no part of the sac or peritoneum goes into it. Understand? This is the most important. And then after peritalization, what you want to see, if there is a lipoma of the cord also, you can dissect it, because it may have the chances of giving a feeling pseudo hernia afterwards. That is why if lipoma of the cord is there, you try to dissect it and take it out. After doing this, you try to visualize limit of dissection, whether I have completed my dissection or not. So laterally it is here, laterally it is anterior, superior laterally it is medial to ASIS 2 centimeter above, inferior it is a psoas, medially it is or median pubic preference. That is how you decide this, and 5 centimeter below to the deep ring. So by this you try to ascertain that this much of space has been created where a proper size of mesh can be spread, and then try to see what is triangle of Doom, what is triangle of triangle of Doom, triangle of Pain, prevesical space, you try to decide. After that, this is a triangle of Doom, triangle of Pain. After that, you try to, after spread the mesh, you try to introduce the mesh. A proper 15 into 12 centimeter of mesh is the proper size of the mesh which has to be used. Minimally it is a 15 into 12. If you are using lesser size of mesh, the chances of hernia recurrence is slightly more, because see the principle is, see if it is deep ring is 2. The principle of overlapping the mesh is at least 5 centimeter overlap should be there. So 2 plus 5 plus 5. So 2 plus 7, 2 plus 5 7, 7 plus 5 is 12. So actually it is 12 in vertical dimension. It is 15 or more in the horizontal direction. I use half rolled mesh technique to introduce the mesh. After you have put the mesh, what you have to do is you have to spread it. You have to fix it or not fix it, it is choice of surgeon. If it is a direct hernia, more than 3 centimeter defect size, you have to fix the mesh. If it is indirect hernia, you may not fix the mesh. Understand? But in TAPP usually what happens, most of the time we fix the mesh. We fix the mesh. 2 on the Cooper's ligament, 1 on the lateral side above to the iliopubic tract, so that nerves may not be entrapped. After fixing the mesh, then we come out and close the defect, peritoneal fold which we, and then insufflate it and desufflate it. See, once we desufflate it from the inside, see how nicely the mesh is stuck to the peritoneum. Okay. This is how it comes. These are the 10 commandments. Time हो गया? ठीक. So time is finished. If time permits, I can show you the video. Because what I want here, you should learn what are the indications. I don't want anything. I want you should learn what are the indications for the TAPP. ठीक है? For that, I have few 1-minute videos for each and every indications. If you say, I can show you, otherwise I will finish. I will quickly. ठीक है? हो गया? So this is a video for direct bilateral direct inguinal hernia. Here I am putting. यार इसमें फास्ट फॉरवर्ड कैसे? इसको बाहर लगा दो. नहीं है? चलो ठीक. After doing diagnostic laparoscopy, see this is a bilateral direct inguinal hernia. इसको मुझे ना फिनिश करना है यार. नहीं वो तो ठीक है, लेकिन तुम इसको फास्ट फॉरवर्ड कैसे करें? अच्छा यहाँ से आएगा. ठीक 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 है, ऐसे चला दो. मैं बोल तो रहता बेटा कि तुमको उसको लगा दो. चल रहा है उस पर? ठीक है, ओके. इस पर कहाँ बाहर का इसका? ये तो फुल वीडियो चला दे रहा है. इस पर फास्ट फॉरवर्ड करना मुझे ना. नहीं उसमें तो हो जाएगा, इसमें फास्ट फॉरवर्ड करना ना मुझे. इसके करें यहाँ पे. नहीं हो रहा है यार. नहीं दिखाना मुझे ना, मुझे तो वीडियो फास्ट फॉरवर्ड करना ना. चलो इसी से चला दो, इससे चला दो, लेकिन उधर पे नहीं जा रहा ना फिर. ठीक है, ओके, ऐसे दिखा दो. ठीक, ओके. See, this was a case of direct inguinal hernia bilateral. We introduced the port, then we try to visualize the defect. After giving incision, we are raising the flap. Now see, we are reducing the sac. This was direct. It is very easy to reduce the sac, and then we are further peritalizing. And this was direct hernia of both sides. What we did, we have entered from the same defect to the other side as well. We had to give 2 incisions, and then we prepared a mesh like this. After preparing the mesh, we introduce the mesh, and then fix with the tacker. and this is another mesh for the right side, left side was put earlier. Help of V-lock suture, which is a self knotted suture having self knotting property, and this is very easy to do it with it, but it needs practice of course, and then we close it, and then what we do, we put port here and then desufflate it. See, at the time of desufflation, how nicely it is stuck to the peritoneum, abdominal wall. And second one. This was a case of indirect inguinal hernia having irreducible, reduced from the cord structures. This was not a direct hernia. Then again we ligated it and then we completed the procedure. This was for the indirect hernia and irreducible one. This is again, this was a recurrent one. This was a recurrent one. See, this is the recurrent side. After recurrent hernias, most of the time it is a medial hernias. Medial hernia means direct hernias. And the procedure remains the same here. And we do dissection and we peritalize it and then come out and put the mesh of proper size. And sometimes we close, see, this is the procedure which I was doing. Yeah, na? This is another case. Hernia momentum was stuck. It was not being reduced, but from the abdominal side we manipulated a lot. And after that also we did the same procedure here and came out. This was a case of canal of neck hernia for the female. Understand? And the canal of neck hernia is bit sometimes associated with fluid collection in it also. So there was hydrocele associated with it, and this is the type of finding we get here. After that, I do not prefer to cut round inguinal ligament, otherwise round ligament is cut. Now round ligament is cut, it becomes very easy, everything comes down. Now in females it is very easy. फिर नीचे कर दो बेटा. हाँ, ये वाला. This is recently I have done it. This is a case of recurrent femoral hernia. Patient was operated thrice somewhere else. Presented with us with the case of obstructed femoral hernia, and the content was urinary bladder in it. See, whenever there is a femoral hernia, what has to be done? It has to be taken. There might be chance there might be content as a bladder. See, this is the bladder which was going into the femoral sac, and it was also associated with the direct hernia as well. This is the bladder. This was the bladder here. This looks like a bowel, but it was bladder here. I am just so, but she was, when she was admitted, she couldn't complain anything regarding the bladder features suggestive of being trapped. Okay. Next. And we put the mesh and then came out again. Or this was a case of undescended testes, irreducible hernia, and see, this is the defect size. This is the defect size. This was the defect actually. This is a big defect here. This is a big defect here. So what we planned after dealing with the undescended testis, we tried to deploy the mesh. There we felt a difficulty, how mesh should be actually deployed. What I did, I will tell you. Pava sir is very fond of doing, and I have learned this undescended testis from him. Actually, so I did the undescended testis part and deployed the mesh. I had not seen how to deploy the mesh in the undescended testis. Just show me. See, once, because the undescended testis pass is brought to the scrotum through this another route, new route. So once we place the mesh is being obstructed being placed. So we have to split the mesh in this particular region to cross the midline, so that recurrence chance is reduced. This is what we did for these different kinds of presentation. That means what I want to tell you, you should learn what are the indications for TAPP. Understand, and what are those indications for TEP. These procedures may be difficult to be tackled by the TEP. Understand? Inside. You have to visualize something from the inside. So these are some of the indications where TAPP is preferred over TEP. Okay. Thank you.
Thank you so much, sir, for this informative lecture. I request Professor Jitendra Kushwaha, sir, to kindly facilitate. Our next topic is extraperitoneal repair for inguinal hernia. Dr. Ajay Pal, sir, Professor Junior Grade in Department of Surgery. He specializes in minimal access surgery and hernia surgery. He has a keen interest in teaching and published numerous articles in national and international journals. Welcome, sir.
Thank you. Thanks for the organizing team, Dr. Akshay, Dr. Pajja sir. Thanks to Avnish sir and Professor Pava sir, who are my mentors, and Dr. Manish Agarwal. So the presentation is totally extra hernia. So it's a type of laparoendoscopic technique in which you create a plane in the extraperitoneal space to actually achieve the critical view of hernia. So the critical view of hernia is critical view of myopectineal orifice. So that Professor Avni sir has already described in detail how to visualize the various anatomical structures of the myopectineal orifice, and that is the purpose. So hernia surgery being the commonest surgery performed worldwide, and open hernia surgery, lacunar repair, as already described, is still the most commonly practiced. But endoscopic hernia surgery in various countries and various other places have taken preference among the because of lesser pain, early postoperative recovery, early return to work, and less surgical site infections. Initially described, the laparoscopic extraperitoneal repair was initially described by Dr. Douglas Fuzley and McCarran. They are both from New York, Mount Sinai University, which are uncomplicated. But as the surgical advances came and techniques become easier, now it has been even for the recurrent cases and the large scrotal hernias, people are doing an extraperitoneal repair, and also in the form of enhanced view extraperitoneal repair, which is ETEP. The anatomy already described, but it remains the same, that the rule of 3, which is the 3 ligaments, 3 folds, 3 spaces, Bogros, Retzius, and 3 vessels, which are inferior epigastric, external iliac, and corona motoris. The triangle remains the same. The triangle of pain, triangle of doom, and femoral triangle. The 3 zones are 1, 2, 3. The These zonal anatomy has come into place in the last 5 years. After 2018, the landmark article by Ferdinando and adopted by George Dais and others, the zonal anatomy became important because the risk of complication in dissection in various zones is different. So if you are dissecting in the zone, usually the last zone to be dissected is having a higher rate of complication if injury occurs in that zone. So that's how the escalating zones are there. Myopectineal orifice is basically the area which is comprising the orifices, which are hernial orifices, and covered by the muscles which are overlying the rectus abdominis and the transverse abdominis, inferiorly bounded by the peritoneal fold. So this anatomy is unique to the extraperitoneal space. Though we approach in TAPP by intraperitoneal, but again we go back in that space. So that is a difference between performing surgery by a TAPP route, because you go into an intraperitoneal cavity first and then create an extraperitoneal space. While in TAP, you straight away enter into the extraperitoneal space and then perform dissection. So that's why this anatomy is unique. The zones and triangles, they remain same, and already described by Professor Avnish beautifully, that the concept of inverted Y and the areas of MPO. Why they are important? Because unless until you achieve the full dissection, the paratalization of the cord, the visualization of the underlying vessels, the testicular vessels, the vas deferens and iliopubic tract, though iliopubic tract may not be visible in all cases, but in thinly built and especially Indian patients, it can be visualized. If all these triangles and iliopubic tract is visualized, you are able to see both superiorly and inferiorly, and it means that you have achieved the critical view of myopectineal orifice. So coming on to the indications. Indications remains the same, which is for a laparoendoscopic repair, which are the recurrent hernias. The recurrent hernias, though usually being operated by TAPP, but now have also being done by TAP approach, especially the hernia which have been operated by an anterior approach. These are posterior approaches. Again, the anterior approach is the open approach, which may include the mesh repair or the tissue repair already described. These are the posterior approaches in which you want the defect. You can simply see that the principle of physics come into place here. When the mesh is entrapped between the muscles and the peritoneum, it is going to have a physiological, whenever because there is a positive intra-abdominal pressure, the mesh is going to be compressed and taken its place, and there is theoretically chances of hernia is less. But though in various histories it has not been proven that it is definitely improving the results of recurrence, but the results are comparable. And again, in the groin hernias in females, especially to visualize the femoral hernias at the same time, because in anterior approach it might not be so easily visualization of the femoral hernias. So that's why the extraperitoneal approaches came into place. Contraindications. So contraindications are mainly relative in nature. Relative in nature in the sense that if somebody has undergone the surgery in the space in which you, suppose the patient has undergone a previous hernia surgery which was an stopaz repair or an anterior transinguinal preperitoneal repair, in that case does your space of radius and the space of Burgos is already vitiated and you are may not be able to dissect properly, but that's a relative indication. Another being if there is patient has undergone a surgery of the prostate. Another being the prior laparotomy. So prior laparotomy or prior intra-abdominal surgery is basically relative contraindications, because if you compare it with TAPP, definitely the difficulty in performing TAPP in the previous abdominal surgery will be more difficult, because you will not be going to gain a space inside the peritoneum, but you can gain a space in extraperitoneal repair, totally extraperitoneal repair. Giant scrotal hernias अभी recent में ही कहने लगे हैं कि giant scrotal hernias के भी हम लोग we can tackle it by TEP or by ETEP more so, because the extent of dissection in ETEP is totally ETP is more, and you are going to have a larger space. The loss of Nemo, which is extraperitoneal space, is less as compared to TEP, traditional TEP. So E क्यों लगाया उसके पहले? Enhanced view. अभी हम आगे बताएंगे कि कैसे होता है. बाकी जो पेशेंट जिनमें the general anesthesia is contraindicated, those who have uncorrected coagulopathy. The question is uncorrected coagulopathy. They are an absolute contraindications. Otherwise, if the patient is having corrected coagulopathy, then those patients are being only a relative contraindications are being operated. The learning regarding few points about the learning curve. So definitely performing the laparoendoscopic repair of hernia, especially by a TEP route, has been traditionally to be said to be by having a higher learning curve as compared to going an intra-abdominal route and then performing a TAPP. So traditionally it was there, but just as the advent of ETP came, now the peritoneal repair has got the comparable learning curve. The people who wants to go undertake this and make this comparable outcomes can straight away go for an ETEP. Because why? Because ETP में जो space हम create करते हैं, that is only a limited space, और limited space हमें create करने में it takes time. Initially, because you want to insert a port in the limited space, the distance between the two ports is very less, है ना? So the triangulation is not there. इसी की वजह से initially it was in midline ETP, फिर उसके बाद advent हुआ दूसरी techniques का triangulation का. Antibiotic prophylaxis, yes, based on any environment, the elective surgery, it is an average risk patient, you have to give an antibiotic prophylaxis. With regards to use of urinary catheter routinely, the various studies are there. They want the bladder to be evacuated before surgery. If you expect the patient has evacuated the bladder, then it is okay, but in our cases we perform a routine catheterization, and that is also being advocated with some other contemporary studies. And then anterior repair is recommended after if what happens in a TEP, if there is a recurrence, then it will have to be repaired by an anterior approach. The mesh is recommended in all TEP cases or TAPP cases, you already know that, because without mesh the repair cannot be done. What happens, why the TEP came? Because sometimes there was a risk for during port insertion, port site, in fact port site hernias or port site visceral injuries, maybe underlying visceral injuries, they found to be more incidence in TAPP as compared the TEP had a higher incidence of, though not statistically significant, higher incidence of vascular injuries. In the recent Cochrane evidence also showed that the conversion rate to other techniques was higher in TEP in the latest evidence, but it was also not statistically significant. So both of the techniques are comparable and now purely depend surgeon's preference as well as a few patient characteristics, such in which patients you suspect the patient to be having occult hernia. You suspect the patient might be having an occult hernia, then you go for a TAPP straight away. And the patient who have gotten prior abdominal surgery and suspect that intra-abdominal, you cannot go straight away into an intra-abdominal cavity without risk of complications. You want to go first into the extraperitoneal space, whether you are able to dissect there or not. And then complication rates, they are comparable. The post-operative pain, recurrence rate, primary, secondary outcomes, quality of life, everything is comparable in TAPP and TEP. This is the Cochrane review recently published in July 2024, and basically improved upon in July, it was there in 2022 as well, and there is no clear superiority of one over the other. But there is higher risk of conversion to another repair method in TEP. Why so? Because one of the complication being in loss of pneumo, because they could be injury to the peritoneum or there could be a defect in the peritoneum, the loss will be there and there will be intraperitoneal. So that's one of the indication for risk of conversion. So this already been discussed, the EHS classification, why it is required, because globally accepted, you want to compare your recurrence rate, your complication with the global standards in place, and that's why a uniform standard classification has to be utilized, and in that way EHS classification is there for utilizing all hernia cases, whether it is primary or recurrent you are operating. Coming on to the port placement, if it is in you want to perform an TEP, their technique will be in midline 3 ports or a triangular 3 port, and this point is in triangular technique it is better for bilateral hernias. If it is a unilateral hernia, for unilateral hernia it can be comparatively done both by midline and triangular techniques. This is how it is there, the port placement. One of the port placement technique on the right side is of an extended view or enhanced view. Enhanced view TEP, total extraperitoneal repair, means that you want to enhance your view. How you are going to enhance? Going proximally or proximal to the umbilicus or level of the umbilicus. So more proximal you will go, more chances of dissecting in the extraperitoneal space and finding the larger space for putting in a mesh placement. So initial coming on to starting after the port placement, how you are going to do a dissection? Either you can take the help of a balloon for performing the initial dissection, you can take the help of optical trocar, it could be telescope guided. We in our setting perform a take the help of 0-degree telescope and guided dissection is there. This is one of the videos. Video is of TEP, but principle remains the same in ETP and TEP. Placement of the first port, incising the anterior sheath, going into the extraperitoneal plane will require the placement of a 10 mm port and fixing it so that it remains in it does not come out or it does not go deeper into inside the abdominal cavity. So we fix that, and after that with the help of a suture we fix that, and after that you insert a telescope and just rotate your telescope by an angle of 90 degrees to find that there is a junction of the posterior PRS and the space. That space is basically the extraperitoneal space. This extraperitoneal space contains 3 fascias. Essentially 3 fascias are there. One of the fascia is the fascia is the most common fascia which we found is fascia transversalis. Another fascias which are modification of the fascia transversalis, but they are the preperitoneal in nature. They are the superficial preperitoneal, deep periperitoneal fascia. So the dissection in between the superficial preperitoneal and deep peritoneal fascia is described, though we all of us may not be achieving it, but these are the 3 layers that are seen. So this is plane called is basically the extraperitoneal space. So what happens after seeing that extraperitoneal space? First sign was there. Which sign was that? You want to see? Which sign? Lighthouse or White House sign. So that's the visualization of the pubic tubercle, and after that Cooper's ligament. So we will be teaching you later on, but the dissection can be there. So on the right side it is there. In between these 2 yellow layers you have to do the dissection. So that's basically the zonal dissection already described by sir. Zonal dissection is zone 1 is a lateral zone, zone 2 is the medial zone, and central zone is the zone 3. Concept of critical view of myopericardial orifice, again it came from the critical view of safety which was described by Strasberg in 1995, and it zone dies in the setting of hernia. It is basically the appropriate exposure, it means the adequate exposure for placement of mesh so that all the hernial orifices are visualized and they can be corrected upon, they can be covered by an area of mesh at least to an extent of 3 cm beyond it. So this is required, the critical view of myopericardial orifice, and it might if it is not visualized it may lead to an increased incidence of recurrence. So the 10 commandment here also remains the same. The commandment after visualizing the Cooper's ligament, the fat and inferior epigastric artery belong to the anterior abdominal wall. In TEP repair, the zone 2 dissection. Zone 2 dissection is usually done initially by the direct telescope. So here there zone 1 dissection, here zone 2 dissection is usually means not always it is done, but in TEP it is because it is the first area to be visualized, be done first. So after this zonal anatomy, you want to visualize the inferior epigastric artery, you want to find out whether the defect is medial to lateral to it, you want to see and free of the external iliac vein is free from any lipomas. The femoral hernia is not there, and after that you identified that there is no direct or femoral hernia, and you can create an area of at least 3 to 4 centimeter beyond it, so that the mesh can be placed. Commandment 4 was external iliac vein should be visible. Commandment 5 is if it is a large hernia, inguinal in nature, it can also be tackled by TEP, but though difficult, technically demanding, but it can be dealt, but the division of the sac has to be done. So you can transect the sac provided that you have safely all the contents of the cord, and the cord should be separated at the apex of the triangle of indirect hernia. The 5 triangles, one of the triangle was indirect hernia. Na? So and another step is paratalization. It means that all the elements of the cord are separately sufficiently dissected from the peritoneum, and at least the vas difference is seen to be crossing the external iliac vein in the zone 3, and in the zone 1 iliopsoas muscle is visualized, though there is no need to visualize the nerves again and again. Why? Because if you are want to visualize a nerve, you will be delineating the psoas fascia or the overlying fascia or the fascia covering the nerves, and that may lead to post-operative pain as well. So visualization of nerves is not necessary, but dissecting in the layer is more important. Lipoma of the cord regarding comment on, because it has to be removed. Why? Because it may lead to recurrence, it may lead to seroma formation as well. Boundaries are already described, it remains the same in extra-abdominal space, whether you are 4 cm above the deep inguinal ring, whether medially pubic symphysis, remember not the Cooper's ligament, pubic symphysis, because why? Because the area that needs to be covered in case of a direct hernia has to be 4 cm away, so that's why you have to go almost medial to the pubic symphysis. So the commandment again remains the same. The 10 after that the study came out that said not only the 10 commandment, but it can be comprised in 7 steps, which is basically in summary the 7 steps are pubic symphysis first, then bluntly dissecting the Cooper's ligament bilaterally. Bilaterally means you can go to the opposite side as well if needed. This will open the space of radius more so as to place a large size mesh. And Hasselbalch triangles is identified and 3 potential hernias associated with it. You can see on the right side the dissection is started in the extraperitoneal space, 1 step, second step it turn toward medially, then turn toward superiorly to identify the medial fossa, which is the site of direct hernias and femoral hernias, here femoral fossa, and then turn along the iliopubic tract to the cover the on the lateral aspect to cover the indirect hernias here. And after that the dissection of the cord structures and placement of mesh. I am not going to go into detail how the steps are there, but remember the mesh has to be an adequate size mesh. That is why the concept of critical view of myopathic orifice came into place. So it should be at least 15 into 12 centimeter ideally. So in large hernias, mesh fixation is advocated by current guidelines in large hernias and in direct hernias, especially more than 2 centimeter mesh fixation, otherwise in TEP at the Cooper's ligament in TEP. So I think time is up, but I have the still images that you can see here. The step is basically the curved or the S retractors are required for making the incision. In the TEP the incision is towards the at the level of umbilicus or just below the umbilicus at the site of hernia. In zone 3 dissection the separation of sac is being done from the cord structures, and after that separation it is going to get you see that this is a sign that we have use of electrosurgery here. Why? In sac why it is required? Because it again in the studies it has been found that the chances of post-operative seroma and hematoma has found to be decreased. If you cut it without use of any electrical surgical device, there will be a higher chance of scrotal seroma or hematoma, and it is ligated as well before division. Thank you. क्या बंद हो गया क्या? And one of the things is in special cases, if there is an irreducible or incarcerated hernia which is chronic in nature, in acute incarcerated hernia, the TEP is not advocated per se. In that cases, you may go for an open approach, but in chronically incarcerated hernias, TEP can be done. And the important point here is the concept of release incisions, which are done in incisions are placed at 10 o'clock. Usually it is incarcerated hernia is indirect in nature, and 10 o'clock is the side where there is least chance of injuring any vessels or nerves. You put in a small incision up to 5 millimeter and then try to reduce it. If not reduced, then it can be extended up to 1 centimeter. Could be there. The two variations that are important here is the variation in transversalis fascia, the variation in arcuate line. Arcuate line could be placed more proximally or more distally, so that may impede the visualization during the, but how we can deal it, we can cut the proximal aspect of arcuate line and enter into the peritoneum. But while cutting, remember, you cut only the fascia, not the peritoneum, because there are chances of going inside the peritoneal cavity. ETP is another extension of totally extraperitoneal repair. It is basically an enhanced view. The approach has been described many times, but only recently in the last 5 years. It is basically the placement of initial port that becomes important in ETP, which is at least 4 centimeter above the level of umbilicus, and in between the tip of 9 costal cartilage and umbilicus, you draw a line at this level. It is there at least 4 centimeter above. You put in an initial port so that you get an enhanced view and your dissection becomes better. Again, the space remains here. In the previous images, the extent of visualization of the chord structures and triangles was less as compared to an ETP. So credit to Professor Avnish sir, who has done a beautiful dissection in this video. So patient also had a direct hernia here. You can see that direct hernia is being, this is the medial hernia that it's being reduced, and you can see here the pseudosac. Pseudosac is the layer of basically the layer of fascia transversalis that has been weakened upon, and the peritoneum or the sac cord structures are basically lying lateral to it. It is medial to the inferior epigastric artery. So you will not be in direct hernia. Important thing is you will not be able to visualize the inferior epigastric artery in the initial time. If it is a direct hernia, you have to reduce it first. So this is the definition of anatomy, which is triangle of doom pain. And after that, the mesh are fixed only at the Cooper's ligament. If it is TEP, no need for lateral fixation. So in conclusion, the 3 M's, mastery of anatomy, modus operandi, how you do it, meticulous dissection are important, and it can be reproducible, safe and effective technique. These are my references. Thank you so much. Any questions?
Thank you so much, sir. May I invite Professor Avnish Kumar sir to kindly come and facilitate Dr. Ajay Pal sir. Avnish Kumar sir to kindly come and facilitate Dr. Ajay Pal sir.
So I think it was very interesting talks on hernia management. So I would like to know, so what is your basic understanding now? Like if you are going so I think it was very interesting talks on hernia management. So I would like to know, so what is your basic understanding now? Like if you are going to learn. So I am asking which procedure you are going to learn. The answer is Lichtenstein. People are saying Lichtenstein, which is most popular. If you are saying TAPP, any difference of opinion altogether out. So no, I am asking which procedure you are going to learn. The answer is now. Few people are saying with this, and few are saying TAP. Talk and discussion, you should be able to altogether out. Giving few comments. No. Like now, what is important now? Like if I am going with history, my teachers used to do herniorrhaphy only, and giving results were acceptable. Like now, then in our later on we started doing hernioplasty. My teachers used to do herniorrhaphy only, and became the results were acceptable. Then we evolved with later on we started doing hernioplasties. All procedures. Hernioplasty means Lichtenstein became the most common procedure. You don't have a choice. Then we evolved with TP. You should learn TAP. If you are supposed to do all hernia surgery, you are not supposed to learn. You don't have a choice. All these procedures. There is no choice with you. This is what I want. If you are supposed to do hernia surgery, you should learn a very good herniorrhaphy. All as well as hernioplasty. There is no choice with you. This is what I wanted to emphasize. Laparoendoscopy. You should learn a very good herniorrhaphy and TP as well as hernioplasty. Now earlier it used to be and laparoendoscopic procedure both was considered TP and TP, but definitely now earlier it used to be. We had this concept, but now as Dr. Ajay was told, considered slightly superior and everything. Now it is earlier. TAPP and we had this concept, but now as Dr. Ajay told, and with Cochrane, Avnish mentioned, so many now it is additional indications are TAPP equally good. So earlier we used to do more TAPs. Now we are shifting so many more additional indications with TAPP and TAPP are equally good. Earlier we used to do more TAPs. Now we are shifting. Learning curve is also more TAPs. So like results with TAPP and TAPP are equally good. One laparoscopic. So you can have learning curve is also. If you want to opt, so at least you can go for one laparoscopic, but and one procedure laparoscopic herniorrhaphy, that is TAPP. Otherwise, you can go up to TAP. And one procedure herniorrhaphy, at least one, so that is TAPP. Otherwise, you can go up to TAP. You don't have a choice. Why herniorrhaphy? You should learn herniorrhapy. Because if you are doing there are certain patients which are you don't have a choice. Like more surgical risk, elderly male 80 plus. Then there are certain patients which are cardiovascular status, more surgical risk, having symptomatic hernia plus, then compromise you're supposed to do cardiovascular status and having symptomatic hernia. If you are not learned, not well versed, you can't tackle that. Open, okay, Lichtenstein. And then definitely, so if you are not learned now, not well versed, you can't tackle that. 2018, if you are saying, then definitely it was as you are saying earlier it was like in 2018. If you are saying like it was doing this, as you are saying earlier it was. Your preference is like I am doing this preference open hernioplasty, whatever, and you can advise to patient. It was like preference, whatever you can prefer, you can advise to patient. Changed now even in unilateral latest recommendations hernia, uncomplicated hernia. Now even in unilateral our preferred procedure is uncomplicated hernia, not Lichtenstein. Preferred procedure is laparoscopic. Preferred procedure is so. What you are supposed to discuss with your patient, you should ask to patient. What you are supposed to discuss with your patient, you should ask to patient. This is you are having hernia. Herniorrhaphy indication is this is you are having hernia. If you are not indication is hernia, well versed with laparoscopic hernioplasty, then you are supposed to say well versed with laparoscopic hernioplasty. I am not, although I am not saying, but this is a procedure which I am not, although I am not doing. I am doing Lichtenstein. This with this information you will go. But I am doing Lichtenstein. This with this information you will go. There is no choice now. This is what you should learn. So all these there is no choice now. Procedures if you want to. You should learn all these 3-4 procedures if you want to do surgery. Okay. Thank you.
I now request Professor Neeraj Banova from Harani Lakshmi Medical College, Jhansi, to give his talk on incisional hernia repair.
Good afternoon. My topic is incisional hernia and their management. So, as we know the anatomy of the anterior abdominal wall, above the arcuate line and below the arcuate line. Difference is absence of posterior rectus sheath. Anatomy, as we know, there are 9 layers between the skin and peritoneum. No need of counting the names. The neurovascular bundle of the anterior abdominal wall is travels between the internal oblique and transfer abdominis muscle. So during the repair, we should keep in mind of that. actually ventral hernia of the anterior abdominal wall, inguinal and femoral are not included. However, lumbar hernia is included despite being dorsolateral. So incisional hernia are the secondary ventral hernias. This is the classification for the primary ventral hernia. I am not going to detail of the primary hernia classification. So what is the incisional hernia? A defect in the musculofacial layer of the abdominal wall at the site of the postoperative scar. So this is the definition, and the incidence 10 to 50% of the incisional hernia found in the laparotomy scar, and 1 to 5% occur in laparoscopic port side incision. 96% of port side hernias occur at 10 mm and larger port, and 86% at umbilical port, umbilical incision. This is the classification for the classification of the incision hernia. We can remember like that, the first hernia in midline is subgyphoid, which is 3 centimeter caudal to the gyphoid process, and second one is epigastric, and third is umbilical. Umbilical hernia is 3 centimeter cranial and caudal to the hernia, umbilical. So this is the umbilical hernia, and between the subgyphoid and umbilical hernia, the area is called epigastric hernia. So this is the, you can remember like that, and this is the suprapubic hernia. This is the suprapubic hernia. इसमें वो नहीं आ रहा मार्कर, इसमें चला रहा हूँ पॉइंट, है ना. So this is the suprapubic hernia. We can see that between the umbilical and suprapubic hernia is 3 centimeter cranial to the pubic bone. So between the umbilical and suprapubic hernia, the area called infraumbilical hernia, and in the lateral side, lateral to rectus sheath, this is the lateral hernia, lateral incisional hernia, which are चलो कोई बात ठीक है, ओके. ठीक है, मिल गया. किस तरफ हूँ, चलो ठीक है. तो फ्लैंक हर्निया, first we remember the flank hernia, which is 3 centimeter cranial and caudal to the umbilicus. नहीं इसमें वो आना चाहिए ना, अच्छा pointer, ठीक. So this is the flank hernia, which is 3 centimeter cranial and caudal to the umbilicus. Above this flank hernia is subcostal hernia, which is caudal to the subcostal margin, and below this flank hernia, area called iliac hernia. Dorsal lateral to the anterior axillary line, the incisional hernia called lumbar hernias. Clinical feature of hernia: reducible swelling in the at the vicinity of previous scar, more prominent on standing or cuffing, reduced spontaneously on the lying down, may present with the subcutaneous intestinal obstruction. Skin over the hernia in old cases are become thin and atrophic. What is the large incision hernia? What is the definition of large incision hernia and loss of domain? According to European Hernia Society, large incision hernia are defect centimeter, loss of domain more than 50%, and vessel content residing in the defect. And loss of domain is defined as when the vessel content chronically reside in the hernial sac. Causes of the loss of domain: bowel edema, abdominal packing during the procedure, peritonitis, and repeated laparotomy. Complication of the loss of domain, as we know, natural rigidity lost, abdominal musculature retained laterally, respiratory dysfunction due to the paradoxical movement of hernia, cause bowel edema, and after the repair, if it cause abdominal hypertension or abdominal compartment syndrome. Loss of domain calculated by Sabag method and Tanaka method. The incision hernia causes are factors: disease factors, surgeon factors and procedure related factors. What is the surgeon's factor are? Obesity, BMI more than 35, diabetes mellitus, smokers, advanced age, multiparity, anemia and hypoproteinemia, immunosuppression and steroid therapy during the procedure, chronic cough, multiple abdominal surgeries and genetic collagen disorders which cause collagen deficiency and cause incisional hernia. Disease factors are poor quality tissues like any collagen disease, wound tension and surgical site infection after the procedure. Surgeon factor, inappropriate suture material and poor closure techniques. Procedure related, vertical incision are more prone for incision hernia than horizontal, layered closure are more prone, continuous closure are more prone than interrupted closure, and emergency procedure are more prone than elective procedure. Prevention of the incision hernia, smaller and closer bite are used and 5 to mm back from the wound edge. So 1 centimeter apart or 1 centimeter back from the wound edge are optional. Incorporate fascia only suture bite, no muscle. Minimize excessive suture tension. The optimal ratio, as we know, 4:1 from suture to wound. Prophylactic mesh in high risk patient like obese patient or in bariatric surgeries, we can use prophylactic mesh. So the incidence of the hernia can be reduced. Principle of the surgical repair, cover the whole length of the previous scar with minimal tension and mesh should be used. This is the principle of incision hernia surgical repair. So treatment. So first the preventive treatment. As we know, obese patient can easily develop incision hernia. According to Love and Valley, 5 kg of body weight is said to create one extra in women. So obesity should be count as a major factor for the incision hernia. Cessation of smoking at least 4 weeks prior to procedure. Treat any respiratory disease like chronic bronchitis. All precaution to prevent immediately post-operative wound infection. Give proper antibiotic and proper wound cleaning. Surgical options are first is open repair. In open repair, suture repair and mesh repair. Types of mesh repair are onlay mesh repair, inlay mesh repair and sublay. Component, second technique is component separation, can be done by open lap or endoscopic. Two type of component separation are doing nowadays, anterior component separation and posterior component separation. In laparoscopy, IPOM, which is intraperitoneal only mesh repair, IPOM plus and robotic hernia repair. So open repair, primary hernia repair by or suture repair can be done less than 2 centimeter of hernia, and mesh repair can is used for the defect more than 2 centimeter. Onlay or inlay mesh repair, we can see in this figure. After the repair of hernia, mesh can be placed over the anterior rectus sheath. So advantage, no direct contact with the viscera, and but the chances of seroma is high in this type of repair, and superficial location of the mesh is most prone for the infection. Second is inlay. Mesh is placed between the facial edges. We can see that the chance of recurrence is very high because of there is no support of this mesh. Third is sublay or retromuscular technique, also called Rives Stopa retromuscular repair. Placement of the mesh under the rectus muscle and posterior rectus sheath. You can see that mesh is Rives Stopa technique. Advantage, intra-abdominal force hold the prosthesis against the muscle. According to Pascal law, force that create the hernia now used to prevent its recurrence. Third is underlay. Mesh is placed between the peritoneum and posterior rectus sheath. We can say that. Now is component separation. Two type of component separation. So series of facial incision are used to separate the components and mobilize musculofacial tissue from the closure about 10 or less than 10 centimeter of defect. First is ACS, anterior component separation. Type of the anterior component separation are anterior component separation itself, yeah, or simple anterior component separation. The second is perforator sparing ACS based on the Huger zones. Third is endoscopic ACS. Posterior component separation are two types: posterior component separation alone or posterior component separation with TAR, that is transversus abdominis release. So anterior component separation after the dissection, after doing dissection between the skin or superficial tissue and rectus sheath, a incision is 2 centimeter lateral to 2 centimeter lateral to rectus muscle or rectus sheath to external oblique aponeurosis. Is space created between the external oblique muscle and internal oblique muscle. After that, done bilaterally, and this rectus muscle, both sides of rectus muscle, stitched in midline. Second is perforated sparing ACS based on the Huger zones. In it, a tunnel is made, not dissecting like that. A tunnel is made based on the perforators, and this decreases the surgical site occurrence like surgical or recurrence. Example of the perforated sparing ACS is periumbilical perforated sparing, PUPS ACS. Third is endoscopic ACS, in which a trocar is placed between the external oblique and internal oblique aponeurosis. A balloon is inserted, and by balloon the dissection was done, and by laparoscopic instrument, in direct visualization, a incision is given on the anterior external oblique aponeurosis, and the ACS was done. There is no incision, long incision or incision of the abdominal wall. Then rectus muscle is closed. This done bilaterally, and rectus muscle is closed. So by ACS, anterior rectal separation, up to the 6 centimeter gain will be obtained. Posterior component separation with TAR. This figure shows both. This is the rectus muscle. A incision given just lateral to the medial border of the rectus muscle, and space is created between the rectus muscle and posterior rectus sheath. A and B showing the simple posterior component separation. After that, if we give a incision just lateral border of the rectus muscle and enter the space between the internal oblique and transfer abdominal muscle, then it is called transfer abdominal release, TAR. So by posterior posterior component separation with TAR, we can obtain 10 centimeter up to 10 centimeter of space. Laparoscopic hernia repair, types of IPOM, intraperitoneal only mesh, where defect is less than 2 centimeter, we can go for the IPOM. If the defect is between the 2 to 6 centimeter, we can go for IPOM plus, in which defect was closed primarily, mesh is put. If the defect is more than 6 centimeter, laparoscopic TAR or robotic TAR was done. Mesh is placed intra-abdominally or intraperitoneally. Advantage of laparoscopic: lower rate, shorter hospital stay, quicker return to work, better cosmosis. Disadvantages are expertise needed, seroma formation, higher operating cost, and bowel injury. Contraindication, as we know in all the laparoscopic surgeries: inability to create a working space prior multiple open surgeries, ascites with child C criteria. Reoperation to the abdominal wall technique are intracorporeal closure, extracorporeal closure, and mixed technique. Suture, mesh can be fixed by suture, tacks, and fibrin glue. This is the case of incisional hernia. In content was reduced and defect was closed, extracorporeal suturing. Extracorporeal sutures. This is the corporeal suture. Mesh is fixed by takers. Crowning was done. This is the interesting case of done by my colleague Dr. Sanjay Chaube. In it, the hernia, external view of hernia is like that. This is the laparoscopic view. Primary suturing by the proline number 1 suture is done. Defect was closed. Defect was closed, and a hybrid vipero-mesh was inserted. Omentum spread over the content for protection of bowel. Mesh fixed. By the takers. This is the post-operative view of the Dane side. This is the Dane side. Because we tried first by laparoscope, but the large bowel ascending colon is the content of the sac, so chances of the injury of the colon was more. Then we go for the open method, close the reduce the hernia and close the, and abdominoplasty was also done, because the drain was put for the hernia in the space, because peritoneal cavity is open. Then we put a drain in the peritoneal cavity also. This is the table from the sacral fold. We can see that incisional hernia, if that incision hernia is less than 6 cm, go for endoscopic ventral hernia repair. If it is between 6 to 15 cm, go for minimal invasive surgery like Stopa, TAR and open TAR. If more than 15 cm, go for the open TAR. Types of mesh, as we know, propylene, ETFF. Other procedures are preoperative tissue expansion, T-spender like balloon tissue expander or botulinum toxins, or progressive pneumotomy. These are done in large incisional hernia or when loss of domain is present. And flaps and tissue transfer, these are also used in LIH and LODs. Thank you.
Thank you, sir. May I now invite Dr. Ajaypal sir on the stage to felicitate.
If anyone can want to ask a question, please. House is open for the questions. One thing I want to discuss is one of my, I'm doing laparoscopic hernia repair of a young lady who was operated for the choledochal cyst, a long vertical incision, and during hernia repair, adhesion when I was removing the adhesion, 1 cm enterotomy was done. So, but there is no spillage of the content. So I repaired primarily of bowel, then put the mesh. Post-operative was uneventful. So I want to say that there is a paragraph of the enterotomy, for the enterotomy in the sacral fold, which say if the content are not spillage, so wound is clean contaminated, you can go for primary repair and put the mesh. If the content are spillage, this is the contaminated wound, you can only dissect the wound, and after 3 to 4 days you can put the mesh. But if contamination is very severe, then go for the laparotomy, do primary, do adenolysis, then after some time you can put mesh. So this is for the enterotomy. Anything, thank you.
May I request Dr. Ajaypal sir to kindly come on stage and felicitate Neej Bhanoria sir. Our next speaker is Dr. Manoj Sonkar, an associate professor from the Department of Surgery, Government Medical College, Kannauj. In addition to his surgical expertise, Dr. Sonkar is passionate about teaching undergraduate and postgraduate students. He will be speaking about ergonomics in MIS.
Hello. Good afternoon, students and respected faculties. I am Dr. Manoj Sonkar from Kanpur Medical College. Today I will be talking on ergonomics in laparoscopy, that is the key to keyhole surgery. This is very basic for every you should be aware about laparoscopy, ergonomics in laparoscopy when you are starting with laparoscopic surgery. So, what is the basic difference between an open surgery and a laparoscopic surgery? Open surgery, you can stand on the right side of the patient and operate on the left side of the patient. CBDs on the right upper abdomen can be operated by standing on the right side of the patient. But in a laparoscopy, if you are operating on the right side of the abdomen, you have to stand on the left side. So there are ergonomics that is very related with the laparoscopic surgery. So in open surgery, ergonomic is an option for it is mandatory. You cannot work proper ergonomics and do a successful surgery. So what are the basic problems of laparoscopy as against open surgery? The foremost problem is it offers you a 2D vision. Because of this 2D vision, you do not have a depth perception, or you have a minimum depth perception. And second thing is no tactile or a minimum tactile feedback you see in laparoscopic surgery. The second problem in laparoscopic surgery is something called as counterintuitive movement. What is counterintuitive movement? So as you are operating with a long instruments, laparoscopic instrument, your abdominal wall acts as a fulcrum. So in order to move your instrument inside the abdomen from left to right, you have to make a counter movement from your hand from right to left. So this is called as counterintuitive movement. This can be gained, the skill, this can be gained with regular practice on endotenous. And the third problem with laparoscopic surgery is it offers you very limited degree of freedom, or also called as movement. It offers you only 4 types of movement that is possible in laparoscopic surgery. One is in and out movement of the instrument, one is right and left of the movement of the instrument, up and down movement, and lastly is the rotational movement of the instrument. As against your human hand can offer you a 36 degree of freedom, so you can use 36 degree of freedom in an open surgery, but whereas in laparoscopy it is limited. But robotics offers you a little better, that is around 7 degree of movement as against the laparoscopic surgery. Why ergonomics is important? For ergonomics, it makes you more efficient and comfortable. As you must be aware, people who are going to gym, they say a common saying that no pain, no gain. But that is not applicable in laparoscopic surgery. On the contrary, in laparoscopic surgery, if you have less pain, you can gain more. You don't have neck stiffness, you don't have eye strains and tenosynovitis, etc. That is the problem with the laparoscopic surgery when you do a long laparoscopic surgeries. So what are the basic problems a young laparoscopic surgeon faces when he starts his career as a laparoscopic surgeon? First problem is, where should I put my ports so that I could perform a good surgery? And second problem is, how do I set up my OT or the environment? Where should I stand? Where should the nurse should stand? Where should we keep the cameras? So that helps to minimize the tiredness of the patient, of the surgeon, plus prevents occupational hazard, which I discussed. So the throughout the surgeries, and this struggle throughout the surgery will lead to a stressful surgery, and finally this stress of the surgery will lead to more of complication and conversion to open surgery. So what is the answer to this problem? The answer to this problem lies in the baseball field. This is a typical baseball field. As you can see, this is the home plate. At the base you can see, then there is something called as first base, second base, third base. So this first, second, third base are placed in a form of an arc, around the home plate, equidistant from the home. So it is something called as baseball diamond concept for basic port placement. When you apply this logic to the laparoscopic surgery, then you, as in you are doing a lap cholecystectomy, Calot's triangle is the target organ. The first base and the third base acts as your right and the left hand working instrument, and the second base acts as a camera port, that is diagonally opposite to the target organ. So baseball diamond concept is applied because it achieves three basic principles of laparoscopy. Half of your instrument is inside the abdomen, half of the instrument is outside. Second is it makes the camera in the center or the telescope in the center of the ports, and third is it achieves an ideal working angle that is needed for performing a good laparoscopic surgery. So baseball diamond concept is basically a amalgamation of two principles, that is something called as arc principle, that is for port placement, and second is triangulation principle, that is the camera with respect to the position of the working hands. So what is the arc principle? Arc principle states that you identify the target organ and arc approximately 15 to 18 centimeter away from the primary target organ in a form of an arc, and you can place all the working ports and the camera ports in this position. Why do you put this ports half instrument in and half instrument out? The first principle is half instrument it should be in and half instrument should be out. How do you do this? So what you do is you identify a target organ. For example, if you are doing a laparoscopic cholecystectomy, your target organ is your Calot's triangle. If you are doing an appendicectomy, your target organ is the base of the appendix. So first you identify the target organ which you are going to be handling. Next is you should know the length of the laparoscopic or the working instrument. In adult laparoscopic instrument is approximately 36 centimeters in length. Pediatric laparoscopic instrument, that is 36 centimeters. And third is you have to place the ports approximately 18 centimeter, that is half the length of your laparoscopic instrument, that is 18 centimeter. So a trick is you can use your palm is approximately 18 centimeter measure from the tip of a finger joint, it is approximately 18 centimeter. So you can have an idea, you can keep the hand over the target, your tip of the finger over the gallbladder area and direct it to you can make out 18 centimeter. Next is why you want this to be half in and half out, because when you place the instrument half in and half out, you achieve something called as level 1 lever, because your abdominal wall acts as a fulcrum. So type 1 lever, if you are able to make it as a type 1 lever, so the x amount of force or the movement you make outside the abdomen, same movement will be transmitted inside the abdomen. But if you have a type 2 or a type 3 lever which is not recommended, you can undershoot and overshoot your instrument inside, that is not favorable for doing a good laparoscopic surgery. Now coming to the second principle is camera should be in the center, that is called as target organ, and camera is placed diagonally opposite, and your right and the left hand working instrument are on the either side of your camera. This forms a triangulation to have view. So there are two types of port placement you can have. There is something called as coaxial port placement or a contralateral port placement. In this, your right and the left hand working instrument are lying on the either side of the telescope or the optical axis. And second type of port placement is your right and the left hand working instrument are on the same side of your optical or the camera port. So this is called a sectoral port placement or something called as ipsilateral port placement. For a beginners, sectoral port placement or ipsilateral port placement is not recommended because it needs some amount of good amount of expertise to master this trick. Why you want a camera to be in the center? Because of this parallax which you encounter when you are doing a laparoscopic surgery, linear parallax, motion parallax, contrast parallax. So you can see in the linear parallax, you can see if the camera is in the center, right half of the image and the left half of the image appears to be similar. But when a camera is eccentrically placed, as in the second page, you can appreciate the bricks in the picture appears bigger, that suggests your brain processes as an organ that is nearer, and you may overshoot or undershoot depending on this. So for a beginner, a linear, to minimize this parallax, you have to have a camera in the center of your vision. Example of this is, for appendix you can opt for this port positioning. You can keep your right hand instrument at the supraumbilical level, left hand instrument at the suprapubic level, and camera will come in between, that is in the left lumbar region. Second type of port position for same laparoscopic appendicectomy, can we have a sectoral port placement, that is your right hand instrument can be in the left iliac fossa, and your left hand instrument will be in the suprapubic region, and your camera will come from the region. So this is a example of sectoral port placement or a ipsilateral port placement. Now coming to the third principle of laparoscopic surgery is having an ideal working angle for operating this patient. We follow this ideal working angle concept in our day-to-day life while eating with a fork or with typing or writing anything, we follow this principle. So same principle is to be applied in the laparoscopic surgeries also. How do you achieve a standard ideal working angle while doing a surgery? As you know, the length of the instrument is around 36 centimeters. So you have to achieve a ideal target, working angle, that is 60 degrees at the target organ. So the yellow thing is the optical axis or the port placement. So you have to axis so that the two instruments on the either side form an angle of around 60 degree at your target organ. So this is a small trick, diamond with your tip of the index finger and your thumb, and the length of approximately is 18 centimeters, and your anatomical snuff box will correspond to the port placement, whereas your thumb will correspond to the optical axis or the camera port. So in this way every surgery you can practice laparoscopic cholecystectomy or appendicectomy. This is the basic vision. Or to measure, you can use your 4 fingers, they are approximately 8 centimeters distance. Now coming to angles in laparoscopy, there are 2 important angles in laparoscopy. One is something called as azimuth angle and another is called as manipulation angle. Then what is azimuth angle? Azimuth angle is an angle between one of the working instrument, one of your hand, and the camera or the optical axis. And manipulation is basically 2 azimuth angle combined, that is distance or the angle between the 2 working instrument. So ideal azimuth angle is 30 degrees and 2 azimuth angle makes us 60 degrees. So ideal manipulation angle is 60 degree, which you need to achieve, or angle between manipulation angle between 45 to 75 degree is good enough for doing a laparoscopic surgery. Now coming to the second question, how do I set up my OT or the environment in the OT to do a good laparoscopic surgery? There are few concepts you should know. First is the straight line principle, something called as elevation angle below waist level table height, then we have a gaze down view and an arm position. So what does the straight line principle states? Straight line principle says the monitor or the screen, the organ of pathology and the surgeon, all 3 should be in a straight line. Why you need a patient to be in all 3 things to be in a straight line? So that your visual axis and your motor axis ideally should be same. You cannot drive a car by looking back. You can drive for 5-10 seconds, that is but you cannot drive the entire car for by looking back. So in our day-to-day life, you follow this principle, your visual axis and motor axis are always or almost always on the same axis. So you follow the same principle, your visual axis plus your plus your motor axis, that is the movement of a hand, should be in the same direction. So, this is an example for doing a laparoscopic appendicectomy. All the three are in the same line, and this is an example for doing a laparoscopic cholecystectomy. Now, coming to elevation angle. What is elevation angle? It is the angle that is made by your body with your working instrument, that is called as elevation angle. Ideally, it should be same as the manipulation angle, and ideal manipulation angle is 60 degrees. So, elevation angle and manipulation angle should be ideally same. Next is the surgeon stance. How do a surgeon should stand? So, he should have a downward gaze of 15 to 25 degree, it will prevent his. Second thing is elbow angle should be more than 90 degree for performing a long surgery, because angle less than this will lead to much strains. Third is the height of the OT table should be below the waist of the surgeon for better comfort, and fourth is predominant below elbow movement, elbow, wrist and hand movement should be followed. You should not use your shoulders because it will lead to strain. Now, after this long lecture, I think you must be confused what to be followed. So, the take home message from this lecture is basically follow 3 A's when you are doing any surgery. First is alignment, that is straight line alignment. You align all the three, the monitor, the target organ and the surgeon in a straight line. Second A is the arc principle. You put the ports around 15 to away from the target organ in a form of an arc. And the third is angle, that is the triangulation. The position of the camera should be in the center around this arc with respect to your working instrument. Thank you everybody, and I am happy to take any questions. And one small notice, we have organized a false hernia course in GSV Middle College in 11th to 13th of April, May. You can come and join and you can learn the basics of, we will be including open hernia surgeries and laparoscopic also basically. So, you can come and join us with GSV Middle College. Thank you. Any questions? Any doubts?
May I invite Professor Kushwaha sir to kindly felicitate.
ये ले लो.
Now we have Professor Vikas Singh sir, a recipient of multiple awards and an organization and chairing various surgical conferences, to kindly give a talk on abdominal wall reconstruction. We welcome you, sir.
All. Thank you, Sonkar sir, for here, and I will try to do justice in the next 15 minutes because I am the only one standing in your lunch. So let's have something more. And the topic which we are going to discuss, it's not more of a presentation, it's more of a discussion to one and all, and something I might be able to clear a bit for having me. Remember, 15 minutes for something known as abdominal wall. Because I am the only one between you and so what lunch. I will go on for is, so let's have something more postgraduate, and what the topic which we are going to discuss supposed to look more of a presentation, it's more of a discussion for this. and something I might be able to, because we all have been taught regarding 15 minutes for something known as abdominal walls, so-called various aspects possible. Be it so what I will go on regular hernias is when I say regular, I mean graduate, the inguinal hernias or epigastric hernias once you are going in for this particular topic. Because we all have been taught regarding various kind of hernias occurring in various aspects. Be it fragile things and hernias, other things when I say regular, I mean, and that is what we are going to look for. Epigastric hernias, just going for a slight umbilical or parumbilical. And as we all know that being in surgery, consider is something known as incisional hernias, and they are the ones which nothing beyond anatomy. Once we know the anatomy in detail, we'll be able to take care of the altered physiology, and then we go in for something known as correction, anatomical disruptions which have been there, we go in for near normal corrections, and by far we are the altered physiology or the pathophysiology nearing normal. That is what our basic aim is. And if you notice, this is what we have been studying right from our first semester or the day we entered in the anatomy. I don't need to go into the detail, but this pyramid is there which says that the skin, subcutaneous tissue, the fascia, the muscle, and the peritoneum. And in between the muscle and the peritoneum, we have one more layer, and that is known as the fascia transversalis. Because once we are talking of hernia, that equally becomes very important. If you want to interact, that will be better off, because remember again, it will be going to be a more of a monotonous lectures, what we have been since in the morning. So some of you might be even sleepy because of hypoglycemia. But try to gather up, because this is what we are. So in every layer holds some important value, because remember, once we are trying to tackle hernias, it is not just anatomical closure what we are trying to do. We are trying to do or restore the functions which each one of them separately or synergistically they do for the abdominal structures. And synergistically what they are trying to avoid or trying to provide is not only the coverage, also the functional status, means stretchable part. In whatever activities we are doing, they also provide resistance against the stretching, be it exercising, be it eating, be it yelling, or be it running down the stairs up and down, or everything. They provide the protection apart from the resistance as well. So there might be some indications of abdominal wall reconstructions, and when we talk of indications, what we are looking for is, number one symptom that we come across is pain. That means we are trying to give in pain relief. And you know the symptomatology, the pain is mainly because the parietal peritoneum supplied by the somatic nerves, and that becomes painful whenever things get stuck over there. Or there might be stretching of the peritoneum resulting in dull, aching, dragging sensations of pain. Prevention of complications. We all know that in any case of a hernia, be it incisional or any other variety, there are bound to be complications if not tackled well in time. So even the long duration history can result in many complications. Commonest one to start with is irreducibility, resulting in incarceration, and that can further result or get complicated into something known as either obstruction or strangulation also. So that is what we are supposed to prevent. That's why timely intervention in such cases is mandatory. And then finally we are coming down to the repair of defects. And that's why they are written 1, 2, and 3, because the repair of the defect comes in the last part. Before that, you are supposed to tackle these patients. And that is why it is always said the size of the abdominal wall defect or longer the track is there, chances of having complications are going to be exponentially increasing with each thing's going in. But there are certain contraindications as well. Not every hernia can be a cup of tea for all of us. So there are supposed to be certain absolute as well as relative contraindications. And let's talk of absolute. We all know that unless and until our anesthetist good colleagues don't give in to yes, we cannot operate. So that is one of the absolute contraindications in most of the hernia cases, if at all they are getting cancelled. But there are other relative contraindications, means something known as optimizing the patient for better outcome or results. And that optimizing is something that we need to understand the role of smoking, the role of the comorbid conditions, and the role of any other uncontrolled comorbidities, especially like diabetes, because they will definitely adverse your outcomes, whatever you are planning, especially in a class 1 surgery like a hernia. And the key considerations is something known as surgical site infection risk, because this is something, the amount of the dissection which you are going to do, the anatomical delineation which you are going to do, that will expose or that will incite more amount of inflammatory mediators, and also the surgical site infections will be on a high rise. That's why these things are supposed to be tackled before you put in the blade onto a patient. So what are the goals? The goals, again, it can be either obligatory or it is supposed to be an elective. Obligatory, we all must be taking care. Like in emergencies, a patient comes in with obstructed or a strangulated hernia, no matter what, because at that time it is the life of the patient within a stipulated period of time. So you need to go in, see exactly what all you can salvage, and do the best job out there, preferably without a mesh. That is known as the obligatory or the emergency part. And the other one is you admit it through the OPD, evaluate, work up, do the case presentations, and then plan it, and then go in for an elective surgery. So there it is where it comes abdominal wall reconstruction parameters which must be kept in mind. And finally, because of hernia, not only the cosmetic, the quality of the life gets impaired, and we need to restore the quality of the life in terms of rehabilitation of the patient. So the principles, I would come into the 4 principles that we look forward is patient selection and risk factor optimization. And number 1 is we need to minimize the complications which are expected of that particular surgery. That is the first and the foremost things. And we know the complications which are bound to happen, starting right from the enterotomies. They may be missed or they may be iatrogenic, and then the surgical site infections, and then maybe the comorbidities. Because of the comorbidities, if the things are not getting and our expected outcome is getting impaired, that is what we are supposed to look for in minimizing the complications. And that's why it is associated with comorbidities are supposed to be addressed simultaneously. So apart from cessation of smoking, rigid control of blood sugars and the blood pressures, and ensure that the respiratory part of the patient is good enough. Means the respiratory capacity is good enough. Means incentive spirometry and the respiratory capacity is tried to be kept to a highest level possible, because once you do a large hernia, there is going to be a reduction or splinting of the diaphragm, resulting in many problems in the post-operative, which you did not think of. So that's where it comes in, because it has been seen that tobacco does affect a lot of collagen, and whenever we are talking of hernia as such, it is a collagen disease. So that's why cessation of smoking or any kind of tobacco products should be cautioned about. Smoking at least 4 weeks. If they cannot stop it totally, then at least it can be minimized to an extent, and that is something that you need to hammer them time and again so that they address it and they know exactly that the amount of money which they are going to put in, the output is supposed to be dependent a lot on this. Then the malnutrition, we all know that what we are going to do is only anatomical closure of it, but the healing process will be dependent on the body's nutrition basis. And that's why the protein levels, the albumin levels, and the overall nutrition of the patient will play a major role in the outcome or getting the strength of that scar which we are going to leave behind. That's why that becomes very important, and that's why we have to ensure that the patient is optimized, not in terms of only the investigations, but also nutritionally build up the patient for especially large hernias. Obesity, because most of the patients will be there with the obesity. So it is not something that is one of the increased intra-abdominal pressure. So if you just do the anatomical restoration, the fat is going to be there in the muscle fibers as well, resulting in loss or the lack of the strength. And that's why you need to work both the things simultaneously. So maybe it can be as an incentive parameter that if you reduce the weight, then maybe the chances of getting the results or the expected results are going to be much better. So that is supposed to be hammered along with. Why I am using this word hammered time and again? Because that is the job of the residents, because these patients, they come across in the OPDs time and again to you. So it is not something that's just getting a CT scan or ultrasound or a loss of domain or other things, the blood parameters. It is the counseling part which holds a true value in the outcome or the preparation of a patient. And then the hernia recurrence, because if the muscles are not having the strength, the collagens, the nutrition is not optimum, then you don't expect, no matter what kind of suture or a mesh you use, there is bound to be recurrence. Because if the wall is not strong enough, no matter if you place a steel almirah or a steel girdle also over there, that is going to fall along with the wall as well. So that's why you need to make the wall strong, and then maybe you can change the grill out there. What was of the glass, you can change it with a steel or a titanium, depending on, but the wall has to be properly taken care of. The diabetes mellitus, we all know that how does it affect, not only by glycation, but also chances of surgical site infections are going to rise exponentially if we do not take care. And especially if the duration of the surgery is going to be long enough, then the chances of surgical site infections with uncontrolled blood sugar, which is bound to happen in the post-operative period also, and the chances, and plus the seromas, which we is said to be as an expected, not a complication, more as a side effect, then the chances of infection in that seroma resulting in mesh infections will be high class. That's why it is supposed to be killed even before you put up a knife on the patient. That is just one of the theory parts that we are looking at, that there is something known as ventral hernia working group and Cantor's grade. And that simply says in either it is going to be only a class 1 surgery, or it might be converted into a class 2 surgery with comorbidities or without comorbidities. That is what this, because the approach for these cases is going to be different in the terms of repair what you are going to plan. And that is what is required. Number 2, once we have taken care, means optimization, then means the patient selection, then you customize your n number of procedures which we do not know the names even of. Every day a new name comes up. We need to see exactly what procedure is supposed to be custom tailored for that particular patient. And that is where means whether we are going to do a primary musculofacial closure or are we going to put in a mesh. If we are going to put in a mesh, what type of the mesh are we planning to put in that particular patient? Because it is always said that we do not control the muscles, we control the facial layers on top or underneath those muscles. Because fascia is something which is large in amount and it provides a better jacket all around the visceral organs rather than the muscles. So it is not the muscle coverage what is required, it is the facial coverage what is required, and that's why it is always said to be as good facial closure in a case of a hernia for a better outcome rather than taking bites through a muscle belly or muscle fibers. And then just to increase or decrease has come into the place. We will discuss a bit about a component separation as well. So that means if we are reinforcing it with a mesh, the effectiveness increases. Because remember I showed you the pyramid in which there were 5 layers and 1 fascia transversalis. We are increasing 1 more layer and that is going to be the mesh having lot many holes in it in which the fibroblasts are going to grow in, and that is what is giving it as 1 more layer or the reinforcement layer. To mesh placement and fixation, that we will talk about exactly where exactly, lot many layers, right from the onlay to sublay to inlay to underlay meshes. That is what we all know, we have been reading that about. Synthetic meshes, we all are well aware of, mainly the proline and the vicryl meshes. I will just talk one about the biological meshes. If we are expecting class 2 surgery or somewhere where there is an infection inside, we prefer biological meshes. because they are said to be as anterior, they can fight out, and that is where it counts to put in a biological mesh. They provide the same amount of integrity, but they are better handled by the body. Chances of infection in them is much less than a synthetic mesh. And the third one, the skin and the subcutaneous tissue management, because remember, that is one thing which is going to cover up, because that is what the patient is seeing after all. Whatever you are seeing underneath, we do not know about, that only the doctors know, but what is outside is whether you were able to give the coverage on top of it with the intact skin or not. So when I say intact skin, it is with the subcutaneous tissue as well. So we need to preserve it till the time, at least to an extent, that we can close it in the midline or wherever there is line of incision. So we need to obliterate the dead space because we do not want seromas to form. Seromas are bound to happen. The only thing is we can minimize seromas formation in such cases and ensure that all the comorbidities, they are taken care, then the chances are much less. And the final part which comes into the play is the post-operative management, because then it is a long-term follow-up of these patients. It is not a one-time job. Patients are supposed to be counseled about, not only because of thromboembolic and the respiratory problems which can arise after a large abdominal hernia repair. So for that, you need to counsel these patients before the surgery and continue them in the post-operative period as well. And finally, obviously, once we are going so much of dissection, we need a good and better pain management as well. Both multimodal, when I say, it is supposed to be both intraoperative as well as post-operative. The complications, we know that apart from missed enterotomy, the seromas, the infection, mesh infections and the surgical site infections which are bound to happen, the only way is that we can minimize them as far as possible with the stringent measures. Component separation, I will just take 5 more minutes, Dr. Akshay, just 5 more minutes, right? Component separation, I will just go in for. Remember again, when we talk of components, we are talking of the anterior abdominal wall, and we all know that anterior abdominal wall, we have various fascias and muscles in various planes. Midline has a different one. Lateral, we have 3 muscles aligned, and they all insert via tendinous insertions onto the lateral border of rectus. And this is what various surgeons have exploited in terms of component separations. So they take it to be as कि 3 component lateral होते हैं on both the sides, and midline there are again 3 components: anterior rectus sheath, the rectus abdominis, posterior rectus sheath, fascia and the peritoneum. So these multiple layers, once you start to play between them, that is what is said to be as component separation. And if you notice, anterior component separation means external oblique aponeurosis. Underneath is transverse, means internal oblique aponeurosis and transversus. If I try to take off external oblique aponeurosis away from it, from the lateral border of rectus sheath, then this is going to be free. So if this is free, then the chances of play of the underneath muscles is going to be more. So this is what is said to be as anterior component separation. Multiple arrows in multiple places, all the possible places, and various surgeons all across the world have anterior component separation. And this is where he went in, means right next to the rectus sheath, he went in and he splitted the tendinous insertion into the lateral border of rectus, and he went underneath the external oblique aponeurosis. That helped in rectus sheath medialization, and that is what is said to be as anterior component separation. So wherever everybody is going, that is all anterior component separation. It helps in minimal medialization of the rectus sheath, and small channels or the small defects can be closed better without tension by anterior component separation. Posterior component separation, we are talking of the retrorectal, means behind the muscle. If we are going and we are going at the level of the transversus abdominis muscle, means beneath the internal oblique and anterior to the transverse abdominis, that is said to be as posterior component separation. And that simply involves the viscera is going to be covered fully, and then we mesh in between the muscle, or something known as retrorectal placement of the mesh for better fibroblastic activity. That is what is said to be as posterior component separation. This is what we are talking of, the posterior component separation. If you notice, it is the posterior rectus sheath which we are going, we further increase, and laterally we are going anterior to the transversus abdominis muscle. And then we close it in the midline, and that gives a better coverage of the viscera, and then the fascia is, means the mesh is placed on top of it, having the muscles on both the sides for better integration. And that is what is said to be as, once you reach on to the transversus abdominis, that is what is said to be as tar release or TAM. One more entity, something known as chemical component separation by use of botulinum. The only thing is it is a bit more expensive, and that is why, and we need a good radiologist to place it in these particular sites, so that these muscles, they get a bit of paralysis, and once they are paralyzed, it is easier to stretch them as per the requirement of the body. So that is something, so it's a double-edged sword. Any amount more can cause more trouble and even infections in these particular planes. But that is one thing, that one more thing that you are supposed to know is chemical component separation. So finally, the second last slide, patient readiness is supposed to be monitored. Don't be greedy in operating such patients. You are supposed to understand the anatomy and the pathophysiology behind. Optimize a patient fully, and in the meantime, counsel the patients to an extent that they are ready, because this is going to be a costly business in terms of both the patient's finances and your experience, expertise, time, and the post-operative management. So that's why readiness must be tackled. And then the skin management, because finally it is the skin which is going to be seen by patient all over. So that's why you cannot say that we have placed a good mesh. It is not the mesh, it is what the patient is able to see. That is what is more important. So the final takeaways is that we need to have a comprehensive approach in terms of the complex abdominal wall reconstruction. So as to simply examine one thing, it is a multidisciplinary. We need to have a good terms with our radiologist friends, plan out things in a full team, understand the basic anatomy of it, plan out what if one fails, what is the other backup plan for that, and then finally one aim is to minimize the expected complications which are bound to happen in such patients. Thank you all. Anything please. I have shorted a lot of time. Anything please. I have shorted a lot of time. Yeah please. Yeah please. Yeah. Yeah. That's temporary. That's temporary. It is said to be as, in the meantime, what we do, try to stretch the muscles as well. It is not only that by giving it. It is paralysis for certain time, few weeks. In the meantime, we are working on these muscles so that respiratory exercises and all that can distend these muscles or stretch these fibers. Once the muscle is stretched, it is easier to close it down. What has been seen is that there is no fibrotic activity after these tonsils. So it is not something that heals by fibrosis. It is only, it relaxes these muscles. When I say the paralysis, it is only that these muscle fibers stop contracting. So it is all flabby. So once it is all flabby, it is easier to have control or cover them. That is one of the main indications for using this.
Sir, one more thing. There's a general question, for example. Would it be recommended to close the abdomen not with the greatest of pressure? Matlab ki once the patient is awake.
What's your good name?
Akash.
Akash will be having One session at 3:50 will be starting till 6. We will be having 2-hour session, and I will be talking of abdominal wound closure, abdominal wall closure practically, and I will be giving you some tips apart from the bowel anastomosis. So I will tell exactly that what are the pitfalls once we take care of those cases. It's not about how tightening. We are not strangulating. We are approximating. The term is approximation. It is not खींच के रखना है. It is घोड़े चलाने को खींच लोगे तो वो रुक जाएगा. So you need to have the reins in control, but still it is supposed to be good approximation. So it is not the suture what matters. It is the technique with suture what matters. We'll talk about that on that. Anything else, please? Agitation kills, you know that. I think they are up.
Thank you for your enlightening talk, sir. May I invite Dr. Akshay Anand, sir, to kindly felicitate Dr. Vikas Singh, sir. Let's break for lunch now, and we'll be back in 40 minutes. Welcome back. Starting off our post-lunch session, we have Professor Ashok Kumar from SGPGI. He's a prominent figure in the Department of Surgical Gastroenterology, serving as an additional professor and wielding his expertise for over a decade. He will be talking about surgeries in rectal cancer. We welcome you, sir.
For giving me this opportunity for presentation before the postgraduates. Though every surgeon should know, it's the colon cancer and rectal cancer, both are today a different entity. One time there was both were clubbed together, that is the colorectal cancer. Now the philosophy of surgical treatment, because of the location and also the various, the histological characteristic, tools and technology, has everything changed to the management of rectal cancer, and surgery remains the mainstay of the treatment. So before I go for the surgical treatment, we should first recapitulate the anatomy, and you see the left hand side, the first diagram, you will see the rectum has been divided into three parts. This is the upper rectum, middle rectum and lower rectum. By that the difference is varying from 0 to 5, but most of the literature says the lower from 0 to 6 centimeters from the anal wall, and then 6 to up to 12 centimeters is the middle rectum, and then the more than 12 to 16 is the upper rectum. The right hand side picture is the basal musculature. You see the one is the basically the muscular tube of the rectum, and then you see the internal sphincter is 3, and the 4 and 5 is the part of the external sphincter whose continuous with the levator ani, which also forms the upper part of the sphincter, has a significant contribution into the continence mechanism. Now coming to the what are the various facial layer, this is very important for the perception of the surgical management of rectal cancer. And you see the pelvic fascia has been divided into two parts, that is the parietal endopelvic fascia and the visceral endopelvic fascia. The parietal endopelvic fascia is basically, it covers, this is the green line which covers the bony ostia, various phenomena into the pelvis, and this is the visceral fascia which covers the rectum, and that is known as fascia propria of the rectum. And this and interior to that is the mesorectum, which I will come in the later slides. And you see this is the another concept is the mesorectum, and the mesorectum is nothing but is the fibrofatty tissue which surrounds the rectum. This is also known as the mesorectum, is also known as the mesentery of the rectum. This encompasses the fibrofatty tissue which contains all the majority of draining lymph into the mesorectum, lymphatics, the superior and inferior rectal arteries and veins, and this forms the core concept of the rectal cancer surgery. So, and the philosophy of surgery which I will discuss what to do into the management aspects. I will not discuss this slide about signs and symptoms, but the common symptom is the blood mixed with the stool, and some of the patient presents with the narrow caliber if the tumor is lying in the left side of the rectosigmoid junction, and at times there is a alternative or the change in the bowel habit, and others are loss of weight and appetites. So, now coming to the staging of the rectal cancer, I have not taken the metastatic cancer, it is only the part is covering the locally advanced rectal cancer, and the most common staging I will go, and that is the MRI, and in very select cases you can do a kind of this MRI is basically for the staging of the pelvic area, and chest and thorax, abdomen, CT and MRI is very well accepted, which is part of the imaging, and PET scan is routinely not required in these patients except there is a borderline changes, there is suspicion of metastasis or is a doubtful lesion in the chest or very high CEA level. In that situation, if you are suspecting metastasis, then you advise for the PET scan. Sometimes people advise this in the follow up and monitoring, but majority of the centers and recommendations say PET is routinely not advised. So, what is the advantage of MRI in the pelvis, and this is a core concept of the evaluation of the rectal cancer, and what it does, it tells you the distance of tumor from the mesorectal fascia, and you can see whether the mesorectal fascia is breached or intact and how far is the tumor, and you can plan the subsequent surgical excision, whether the patient require neoadjuvant treatment or not, and obviously the sphincter involvement. If you are planning the sphincter saving operation, this is very, very helpful. And not the least, you will can also see the lymphovascular and venous invasion into the mesorectum. So, MRI is the core concept of today evaluation in the management of rectal cancer. So, this diagram you can see the what are the various structure you can see on MRI. You see the anatomy on the left hand side, which tells you the M is the mucosa and SM is the submucosa, and then the musculus propria is the outer cover. Interiorly you can see the seminal vesicle is marked by the fascia abdominal, where interiorly and posterior it is merged with the fascia propria of the rectum, and the right hand side you see there is a tumor into the mid rectum, and which is you can see it's 9 o'clock to 1 o'clock position, and if you see interiorly there is a breach into the mesorectum here. So, interior breach in the mesorectum and extension is there. So, what is the goal? The goal of the rectal cancer surgery, how to minimize the local recurrence, and second is the important goal is the prolong the survival. This can be achieved. How you can achieve this goal? By removing the tumor along with the draining lymph node, which the tumor is here, draining lymph node lying in the meso, the draining lymph node along with the sigmoid vessels, or maybe at times the inferior mesenteric artery. And then if the adjacent organs involved, organs should be removed in toto, and if on MRI the compromise of any of the structure and recurrences is expected to be high, patient require neoadjuvant treatment. The other objective of the patient of rectal cancer surgery, the sphincter preservation if possible, and then prevention of the autonomic nervous system.
Akash will be having one session
urinary and sexual dysfunction. So, how will you select the patient for neoadjuvant treatment? So, obviously the broadly based on the MRI, the patient has been clubbed into A, B and C. The first group, the patient, you feel that the first group, if the only tumor is localized to the rectal wall, maybe early lymph node or no lymph node, and you see if the predicted CRM in circumferential rectal margin is not going to be involved in this patient, you can take this patient. But T3, T4 and nodal involvement are, even if the margin is not compromised, patient go for the neoadjuvant treatment, either conventional or you can take the total neoadjuvant treatment which is emerging today. And the almost all cases, if MRI, if you see the circumferential resection margin is involved, then you go for a neoadjuvant treatment in all patients. So, one slide I have taken just to neoadjuvant, total neoadjuvant treatment, and this is the emerging trend, and possibly in the coming years you will find it's replaced the conventional neoadjuvant, the textbook. Today it's not a textbook, it's a textbook which to stage as pre-operative neoadjuvant treatment examination. Maybe you can say radio chemotherapy, but if somebody asks, you can say yes, total neoadjuvant treatment is coming and possibly it will replace the conventional treatment. So what are the patient? How will you choose this patient? One T4 disease, and if you feel circumferential resection margin is likely to be involved, are in some select group patient of the middle and lower rectal cancer where the pelvic lateral lymph node is also involved. And obviously the higher pathological, it has a very good response, and some, the study has seen it has a definitely advantage in preventing the distant metastasis and also downsizing the tumor. So, what are the various surgical options? Now coming to the surgical option, one is the sphincter saving operation, second is the sphincter sacrificing operation, and then the extensive surgery in the form of pelvic exentration. So, what is the sphincter saving operation? One is the anterior resection, there is no doubt it is performed for the upper rectum, rectosigmoid and even the distal sigmoid. The low anterior resection, the treatment of choice for mid and lower rectum, and ultra low is another option in select group of patient with the lower rectal cancer. And the intersphincteric operation, local excision is by the chance where there is a possibility of saving the sphincter depending on the various indication in low rectum. You can choose this operation to save the sphincter, which I have a couple of slides coming ahead to discuss. And obviously for lower rectum means the sphincter is already taken away by the tumor, or if the patient sphincter is compromised, patient is frail, multiple lymph node, locally advanced disease, abdominal perineal resection is the treatment of choice, and this can be performed by the open method, laparoscopic method, robotics, or even the transanal minimally surgery. So, these are the few diagram I have taken for you see this is location of the tumor in the rectosigmoid upper rectum, where you can do an anterior resection either hand-sewn anastomosis, stappled anastomosis, either by laparoscope, open and robotic, and kind of colorectal anastomosis. APR, you see the permanent stoma in this patient after resection of the lower tumor, and in select group of patient with the lower rectal cancer, you can do a intersphincteric operation, and there are three types basically: partial, subtotal and total intersphincteric resection, which I will discuss later, and transanal endoscopic microsurgery of for the local excision for the localized tumor into the rectum, and they have a selective indication. It is not for all patients. So, what is the basic principle of the rectal cancer surgery? One is the ligation of the inferior mesenteric vessel. Then there are three margins along with the tumor: proximal margin, distal margin, circumferential margin, major extent of mesorectal resection, how to preserve the autonomic nerve, and adequate lymph node resection, and wherever possible try to save the sphincter or try to do a sphincter saving operation. So, where to ligate there is a debate several decades back whether high ligation versus high, you are ligating the tumor right up to its vessel right up to its origin from the aorta, which have a lots of lymph node around. But there was a various complications, but like lymphoria, sometimes injury to the vessel, prolonged ileus and hospitalization, and it was not found to be advantageous because of extended mobilization, and there was no survival advantage. The message now came that in select group of patient where it is a common origin of the colic artery with first branch, in about 25% of the patient you can ligate at the origin, otherwise ligate this inferior mesenteric once it has given the left colic artery, and that is the site of ligation in majority of patients. And now the most important is the margins, proximal margin, distal margin and circumferential. So this is the three-dimensional picture. This is proximal margin. There is never issue with proximal margin. Plenty of margin is available. The issue is lying into the distal margin and also the circumferential or tangential margin is from tumor site to the outer border of the fascia propria of the rectum, and this is the resected specimen collaborating are similar to that. This is the ulcerated lesion here, this is the external in sphincter EAS, this is the and this is the length of the tumor from the external, that is the lateral margin or circumferential margin, and this is the distal margin. So its concept should be very, very clear, and how much margin should be here. So what is the importance of distal margin and oncological outcome? In this study published from China, you see if you take about a centimeter of margin vis-a-vis 1 centimeter to 2 centimeters, they have found in sizable number of patients there is a significant control of the recurrence if the margin is about 1 to 2 centimeters. However, there is also advantage about the 5-year overall and disease free. For well differentiated or moderately distant tumor, 2 centimeter margin would be adequate, and for poorly differentiated tumor you need to have a more than 2 centimeters. But in a select group of patient where in sphincter saving procedure is planned even for the lower rectum, well differentiated tumor who had a well responding to the chemoradiation, then you even need about a centimeters or millimeters, more than 5 millimeters margin is sufficient. So now coming to the another important is the circumferential margin. What is its importance? Importance in the local recurrence. This slide says if you take a margin of more than 2 millimeter, local recurrence is about 3.3%. But if you take the margin less than a millimeter, then its high recurrence 13%. So significant difference in local recurrence, and now most of the people say the circumferential resection margin is an independent prognostic factor in addition to lymph node T static disease. So the best would be you should try to take a minimum margin of approximately more than centimeters, preferably 2 millimeters. So what should be the mesorectal extent of excision? So several studies have shown that the tumor does not spread in the form of lymphatic or lymph node more than 4 centimeters into the mesorectum. So if you take a 5 centimeters of mesorectum, that suffice the clearance of the lymphatic and lymph node, and for the upper rectal it's 4.5 centimeter, means it's kind of partial mesorectal excision. For mid and lower rectum, you take a distal 5 centimeter, then it's amount to be total mesorectal excision. So what is the advantage of a mesorectal excision? This prevent the local recurrence and also it's improve overall survival. So what is there, if you do a mesorectal procedure, at times you breach the mesorectum, mesorectal fascia, sometimes we enter into the mesorectum, sometimes the mesorectum is also breached and you go into the intramuscular plane of the dissected resection. So it has been divided in the complete fascial plane. In mesorectum, you see the mesorectum has been breached, here the surgeon has gone into the muscularis plane of the rectum. So the quality of survival is very these 3 patients, and also these has a high chances of local recurrence. So, you see if you see the green line, if there is a no breach into the mucosal plane, fascia is intact, survival is going to be very high in comparison to where the breach is the mesorectum or the muscular plane. And another study recently published in BJS also say this properia resection increases the risk of recurrences, but does not seem to affect the recurrence or distant metastasis or survival. So, now coming to this is a very important slide for postgraduate. What are the various types of surgery? Where do you do anastomosis is indication. So, the first I will go the a type of resection commonly performed the anterior resection, or some people say it is high anterior resection, then low anterior resection, and then ultra low resection. What are the indication? The anterior resection or indication for rectosigmoid and upper rectal cancer, the low anterior resection for upper and mid low rectal cancer, and in select group of the tumor with lower rectal where it is more than 2 centimeters from the anorectal junction. Ultra low is again it can be done, not in all, but select group of patient with low rectal cancer if the tumor is about 1 to 2 centimeter from anorectal junction, but not in sphincter. And the principle of surgery is the either partial TME for anterior resection or TME for the ultra and low anterior resection. Anastomosis can be done in the form of colorectal anastomosis in anterior section, and this anastomosis is lines above the peritoneal reflection. That is why most of the people and examiners ask you what is anterior section. Anterior section means once your anastomosis lies above the peritoneal reflection after resection, that is the anterior section. Low means after resection if your anastomosis lies below the peritoneal reflection, and ultra low means your anastomosis is lying right up to the dentate line or maybe at the pelvic floor. So, these are the various definition, and it can be done either by Heinz-Ewan anastomosis or by possible then definitely anterior and low anterior stappled anastomosis can be done. Abdominal perineal resection is a very limited indication today. If the carcinoma involve the in sphincters, and by all possible tools and technology, if you cannot achieve a sphincter negative margin, and where elderly and frail patient where the sphincter is already compromised, where you think that preserving the sphincter, the quality of life, especially the functional output, going to be worse. So, here it is better to do a permanent stoma. So, what are the basic steps? Obviously, the basic steps is the complete mobilization from the splenic flexure, ligation of the inferior mesenteric artery, level I have already discussed, and you can divide the colon depending on the site of the tumor, whether it is a rectosigmoid, mid of the rectum or at the anorectal junction, depending on the site of the pathology, and preserving the mesorectal facial plane while dissection, and that should be done either by the seizure or by cautery, but not by a blunt dissection which jeopardize the facial plane, and either the total mesorectal excision or partial depending on the site of lesion. Now, coming to the especially few slides for the what are the options for the low rectal cancer. The issues are mainly the distal margin, circumferential margin, sphincter involvement because it lies in correlation to the sphincter, and whether or not the surrounding organs are involved, especially the prostate and urethra in male patient, posterior wall of vagina in female patient. At time there is a lateral pelvic lobe involvement, or even advanced tumor, it is infiltration to presacral fascia or maybe bony involvement. The various options are the ultra low resection, in sphincteric resection, abdominoperineal resection, either conventional or extended abdominoperineal resection. So, what are the various routes to do a sphincter preservation? You can do a transanal endoscopic microsurgery, intersphincteric resection, ultra low is already discussed, and local excision is another option for a select group of patient, and after that you can do coloanal anastomosis, you can make a J pouch anastomosis, or you can do HR kind of T-plasty in select group of patient and do a anastomosis. So, intersphincteric operation, I have already discussed, it could be, suppose that the tumor is lying very up into the lower rectum, and this is the levator ani is not involved, and both the sphincter are not infiltrated, it is up above the junction of the levator ani with sphincter. Here there is no need for, in this situation you can do a ultra low resection. But suppose the tumor is further down, and if it is involving the part of the sphincter where after taking a 1 centimeter of margin, your anastomosis may involve the internal sphincter, and you can do a partial ISR. If the tumor is further down below the dentine and involve the internal sphincter, you can do a subtotal sphincter, that means part of the both side of internal complex, and if the tumor is very low infiltrating the external sphincter, that is the partial ISR with the part of the external sphincter excision, that is known as the total ISR. So, what are the indication of intersphincter resection? If the tumor is located between 3 centimeters from the anal wall, or about 1.5 centimeters from the dentate line, or it is located within 1 centimeters from the anorectal. These are various anatomical landmark for surgeon. One is the anal wall line, and then is the anorectal ring. For surgeon, anorectal ring is the most important landmark for sphincter preservation, and tumor should be localized to the internal sphincter both on clinical examination and or ultrasound or on MRI. External sphincter should not, without any lymph nodal metastasis. So, it has two parts. One, the first dissection start from abdominal side right up to the floor, and then the further dissection goes from below into the internal sphincter plane, excise the tumor and do a coloanal anastomosis from the perineal side, and it can be done both by laparoscope, by a robot, or even open surgery. Obviously conventionally started with the open. What is the outcome? Outcome seems to be not very satisfactory, but Japanese study, they have one of the largest experience, and they said 10% of the patient have a significant benefit in the form of sphincter preservation, but compromise functional outcome. So, what is the final literature say? Intersphincter resection should be offered to select group of patients with low rectal cancer who are otherwise candidate for APR and unwilling for abdominal perineal resection, but with acceptable oncological outcome and also the functional outcome. I will skip this slide. So, what are the other option? Local resection. What are the indication? The tumor is located within 10 centimeters from the anal verge. The tumor size should be approximately 40%, a third of the literature said about 1/3 of circumference involvement. It should be mild or well differentiated carcinoma. On ultrasound, it should be T1 or T2 lesion, with or without radiotherapy before surgery, and there should not. And what is the technique? You should do a full thickness excision with 2 centimeters margin and with the use of electrocautery. After excision, you will find the raw area, whether you should close or not. Some people say if you close it, there is a further chance of implantation of the tumor, but many people feel that it is not required and it is not high, but these local excision are all at the high cost of local recurrence. Now, this is the another tools, transanal endoscopic microsurgery. It is similar to the local excision because the instrument kind of have a limited space and it can go larger distance with a good magnification, good sourcing, and indication almost remains the same. Now, it is the concluding slide. So, what one should do? If the carcinoma of the rectum comes to you, if the tumor is lying into the upper rectum, then anterior resection is the surgical option. or ultra low resection, and for the lower rectum there are several options. If the more than 1 centimeters tumor space is there from the anorectal junction, you can go for ultra low anterior resection. But if the margin is less than a centimeter from the anorectal junction and the tumor is mobile, preserved in sphincter function, involvement is up to the intersphincteric plane, you go and do either partial or subtotal intersphincteric resection. Then if the less than 1 centimeter from the anorectal ring, what are the other option? If it is tumor is fixed, not mobile, preserved function, external sphincter is free, you can go for a total intersphincteric resection. In cases if the tumor is fixed, lacks in sphincter function, external sphincter is infiltrated, patient has a poor function, you should go for a abdominoperineal resection. Now at the end I can conclude that basic principle of rectal surgery, cancer surgery is a total mesorectal excision and nerve sparing surgery. Removal of the rectum in block improve both the recurrence and also the disease free and overall survival. Preservation of the nerve improves the quality of life. In sphincter preservation should be tried without compromising the oncological safety. Types of surgery depends on the location of the tumor, stage of the disease, tumor characteristics and also the available expertise locally. Thank you very much for your patient sharing. Any question?
Thank you so much, sir. Thank you so much, sir. May I now invite Professor Vikas Singh sir to kindly facilitate the speaker. Our next speaker is Dr. Amit Chaudhary from the Department of Vascular Surgery. He is an enthusiastic surgeon and teacher. Sir will be taking the topic of venous thrombosis. We welcome you, sir. He's running a little late. Hold on for 5 minutes for the lecture. You may take a tea break if required while sir arrives. We have a small interim lecture by Professor Vikas Singh on the science of tissue management, sponsored by Ethicon Johnson & Johnson.
अरे जो दाएं बाएं गए हैं उनको बुला लो भाई, थोड़ा आगे बैठ जाओगे तो सुनाई और दिखाई थोड़ा अच्छा देगा। भाई साहब पीछे, भाई साहब बहन जी जो पीछे बैठे हैं आगे आ जाए। हाँ कम से कम मेन लेक्चर्स को तो अच्छे से देख ही सकते हैं। Okay. So again, as I promised that I shall be telling about in something regard to we all do day in and day out, and day in day out when I say that once you thought of becoming surgeons, you do a lot of laparotomies, and once you get inside the abdomen, the bowels are something that you need to handle, and the way you handle that is what your seniors teach you, and that is what you try to learn, and do something known as palpation or handling the bowel. Fair enough. We'll be doing some practical sessions on the bowel anastomosis out there, but I'll be giving you certain tricks in regard to why do you have wound dehiscence, especially in regard to the burst abdomen, which happens even in the difficult cases, even in duodenal perforations, it does happen many times, and then everybody is after your life. Even in the difficult cases, even in duodenal perforations, it does happen. Surgical site infections, and then everybody is after your life. But as far as possible, let us not be a part of it. Let us be a part of it, prevention of the complications or minimizing the complications. I don't say that it never happened with us. It used to happen. As the understanding increases, we get to know the science behind, and then maybe we are more vigilant as far as techniques are concerned. So this is going to be a sponsored session by J&J. Because this exactly what we are looking for is there is going to be dehiscence if we are not careful enough. And once there is dehiscence, the whole of the abdomen which you have closed may be under tension. If not under tension, because of the previous infection, because of ongoing infection, handling of the bowel, there is going to be bowel edema, which is going to protrude outside. And with each breath, the surrounding visceral structures, they are missing the layers, it is going to protrude out, and then you will be placing lot many things, from something known as silo to the wound manager doing the strapping dressings, and it is going to be a till the time your patient is either pushed them off to somewhere else. But the trouble is, the place where you are, people are going to push everything out here. You will not be able to push any patients out of KG. That is one of the most disastrous problems. So we had talked about in regard to that it is the skin, the subcutaneous tissue, and then the facial layers, interspread in them is the muscle. And you know that the facial layers are something known as avascular structures, and they are the ones which is providing the most remarkable strength as far as the abdominal wound strength is concerned. And that's why, and the muscles are only causing something known as liability. It does not provide you the strength per se. It is, remember, vascular structures. So whatever vascular structures are there in the abdominal wall, that just gives the shape to it and gives vascularity, but it does not provide the strength. It does provide a strength till the time it is intact with its own vascular blood supply. Vascular and neurological. So let me say the neurovascular bundles are intact. Till that time, it will provide some strength, and that too in the long term. But as far as the strength, immediate strength is required with any kind of sutures that are using, it is the facial closures which is required. So what you see around here is that because if you don't do that, then the abdominal wall reconstruction and the complications you are supposed to handle. There are multiple risk factors, as we all have seen in multiple cases. It might be a bad case, malnourished case. It might be having a lot of comorbidities along with, and then your expertise in dealing with, which we keep it always at the end, but that is the first and the foremost, because the same closure being done by somebody who has been doing it over the years might be able to do much better in the same given patient as far as anybody else is concerned. So that is where your technique of handling your sutures and your instrumentation and the choice of the suture does matter a lot. So that's why we are out here, because see, it is written at number 8, but as far as me or I am concerned, I would just reverse it, because rest are something which are modifiable. Technique is something which you cannot modify. You need to learn only one method of the technique, and that is the correct method. No matter what sutures you are applying, if you are applying it in a wrong format, things are going to be disastrous at the end. So what he was trying to ask me was, is it something that once you ask somebody to follow the thread, it is just to keep out of the moving instruments rather than pulling it as a retractor. So threads are not to be used as a retractors, it is just to keep out of the moving instruments the person is using or the main operator who is using it. That's all. That is the job of following the thread and not to tighten it up. I would be going in, remember, I don't go into much of the research work. That is for more of theory, but yes, definitely we do take cues from them that what is their punchline. To understand that, you need to be a bit more vigilant as far as the techniques are concerned, because that is why you say that the chances of getting complications are much less in minimally invasive surgery because of n number of things, and one of the n number things, one of the most important is we do not traumatize the muscle or the any neurovascular structures once we are putting in a port, because we don't cut the muscles, we are splitting the muscles while putting in any type of ports that we know of. So, and that's why chances of complications are much reduced. It says use non-midline incisions, but we all know that in emergency we always go in for midline laparotomy incisions, because doing a paramedian incisions, not routinely, maybe some consultant is fond of, and in all the laparotomies or appendectomies, if at all, they will be going in for all the cases as left or right paramedian depending on the pathology. But most of the time we are instructed to go in for only midline incisions. But marking that midline incision is the key, that whether you are in a hurry in like in trauma, or can you really identify and then only try to go in. And while marking, because midline something which is inherent for abdominal wall anatomy, but while closure you can do minor modifications to restore the anatomy later on. Because most of the times what we see, the practical approach what we all see, if suppose 10 centimeters, let's say till umbilicus the incision is supposed to be made, we'll mark it on the skin, and then we'll start cutting the layers, and we cut right vertically down up to the peritoneum. That is what we always do, and at times it does happen that we always try to undermine. Skin incision should be small, undermine, thoda upar बढ़ा लो, thoda नीचे बढ़ा लो, and it will be easier, because retraction is not of the skin, retraction is always of the muscle. Whatever devers or morris that you are trying to place, that retracts the muscle bulk, and we always try to, and while pulling, that muscle even tends to tear off, the fascia tends to tear off at the corners. So what happens? It is a reverse form which has to be there logically, but when I say reverse form means skin is supposed to be opened max, then a couple of millimeters less fascia, and then the peritoneum. That is how the reverse pyramid should be there scientifically, but we always tend to go in a reverse fashion. Means skin is the least, facial goes like this, and peritoneum is torn off even underneath till the time that we are unable to track it down. That happens in most of the cases that we do. So what happens with that is, because once we are closing, it is not the skin closure what is important as the science of tissue management, it is the facial closure which is, and you will be able to close only what you are able to see and feel very properly. If you are unable to see and feel properly, it is going to be very difficult to close this meticulously. And that is why this diagram comes in, that if this is the skin that we open up, it should always be less. Try to do that. Once you are opening in the next laparotomy, try to do that the fascia should always be visible underneath the nook and corner of the skin at the ends of it. And then comes further more layer, so that all the layers can be seen in an inverted pyramid format. Because once you put in our retractors, and especially when I talk about is the Journey's retractor, the one with the two claws onto one side, other one the solid one, once you see that, this should always be visible. Because once you are seeing it this, remember the maximum strength that we have is the facial part, the flat facial part beyond the incision line which is there. And that is the strength which you are going to reinforce the corners. And we all know that initiation of any incisional hernias happen from the corners. And that's why we need to reinforce the corners, as we do even in the bowel also, so-called something known as the cornel stitch, which I have never been good at, but still we will try to do that. We will learn with you today कि आप लोग मुझे ज़्यादा अच्छे सिखाएंगे कि cornel suture क्या होता है. I do more of lab, so I don't know. Anyway, so this is exactly what we are talking of, to reinforce the corner sutures. So that's why it says always begin your first needle at the intact one, not at the corner. Do not leave even 5 millimeters beyond. Means you are not supposed to. मुझे pointer एक दूसरा दे दो यार. Pointer please. Can I have a pointer? See this. This is where you are supposed to go in for. अच्छा बहुत सुंदर. Thank you. Right? Remember, this is where they are trying to go for. Not usually what happens, we start from this place, but they are starting even 5 to 7 millimeters onto the intact facial layer, and that is all. And one more thing, always remember, I did say that the muscles are not the ones which are providing the strength. Muscles require a lot of oxygen demand supply, or the nutrition supplied by a lot of perforators and by capillaries. So if you take your bite unknowingly deeper one, saying it that it is number 1 needle, and that to a loop nylon, so called, and the loop nylon, if you see the needle and if punctures your glove, it will not only just puncture the glove, it is going to take the whole pulp in it. That is the size of the loop nylon. So that's why, and there are 2 threads which are going from it, so that itself is highly traumatizing to any of the tissues that you try to put in. So it is not the thickness of the suture, it is where you put that suture, that is what is more important. So number one, you are supposed to take the suture in the intact fascia. You are supposed to ensure, because if it is visible and with a tooth forceps or with any thumb forceps, if you are lifting up, it is away from the muscles. So you are taking care to ensure that do not take any muscle fibers in your any of the needled sutures. That is the most important line. If you take even 5 millimeters of muscle, so remember you are taking at least 5 to 10 muscle fibers, and on either of the sides 5 to 10 muscle fibers, and then once you pull it, there is a strangulating effect on those muscle fibers, resulting into micro bleed, major trauma, causing seroma or small multiple hematomas rich in or enriched medium for any kind of bacterial growth per se. And that is where your disaster begins to happen. So never ever try to take. So better is, it's not something to leave behind, it is don't focus on the muscle, focus only on the fascia part. That is number one. Number two, you always talk of that what suture are we supposed to utilize. What are the common sutures that we use for the abdominal wall closure? Sorry? PDS, okay, wonderful. Proline, nylon, anything else? Vicryl? Vicryl भी इस्तेमाल हो जाता है. What is, तो दोनों में if I say कि proline और nylon को रखें और PDS and vicryl को रखें, तो what is the similarity in these two groups? Very good. So why do we take absorbable one? If at all we are going in for absorbable, what should be kept in mind? If we are using non-absorbable vis-a-vis absorbable, what thing must be kept in mind before we pick a suture? Sorry? Delayed absorbable. Why do we need a delayed absorbable suture? Four to 6 weeks to heal, okay? 4 to 6 weeks will be only anatomical healing. What we need at the end of it? Strength. And that strength is going to be provided for at least for 3 to 6 months. Right? 3 to 6 months that the strength is going to be there. And that's why we always go in for a delayed absorbable suture if you are not using absorbable one. And somehow it has also been seen that the delayed absorbable suture are better coated also with some antibacterial compounds, as we find in something known as plus sutures, Vicryl plus or PDS plus sutures, in which there is inhibitory substances are there. Bacterial growth can be inhibitory for a couple of weeks, maybe 20-21 days, and that is more than sufficient time for any of the exogenous sources for infection to settle in. So that is one thing that you must ensure. It is not the size of the suture, it is the variety of suture what matters. Regarding the knots, we all know about the surgeon's knot, but is this a good one? We always go in for the ones, the first suture is applied, it says something out here that the tensile strength loss is more than 40%. Can somebody explain me what is this? What does this mean exactly? आप सब लोग लगाते हैं. पहला सूचर जो होता है उसमें अगर कहते हैं जितने भी जीरो का सूचर है, 30 मीन्स एटलीस्ट 5 नॉट्स, 40 है तो कम से कम उससे 2 ज्यादा. तो जितने जीरो का सूचर है उसमें नॉट्स, number of throws or the number of knots which will leave it at least 2 more than the size of the suture. So why does it decrease the tensile strength? What happens? Sorry? Suture fractures. Why does it fracture at all? Rough handling, but you are using, that is the instrument that you are supposed to use. Sorry? Not pay memory loss. That means तो हम absorbable और non-absorbable दोनों में ही memory loss is going to be the same. Something else. Bacteria, not bacteria, something else. What you are using? Needle holder. Needle holder has crisscross serrations, and every time you are going in, you are stretching it all together. So there is going to be micro damage to the structure of the suture itself. So if you magnify it, you will see that it does break. There is micro breakage and it does break, and that is why the tensile strength is lost. Because you are using, and the tactile feedback of those instruments, aim is that we have to just tighten it. But tightening it causes micro damage to the suture lining, and that causes decrease in this. Every time that we are tightening a knot, it does cause trouble. Why this is a self-locking knot, and what is the commonest variety of self-locking knot that you know of? भाई साहब, self-locking knot कौन सी होती है? हाँ भाई साहब को थोड़ा जगह लीजिए. Self-locking knot कौन सी commonly that we use? Aberdeen's. Very good. Aberdeen's is something which you all have been using. And remember, Aberdeen's we are not putting it in with the knots, and it is only at one point our aim is कि नीचे वाला suture should just approximate, and then we use. And finally, so out there, it is more of a slip kind of a knot, which if we are stretching the suture, it is furthermore going to tighten up on a avascular fascia. And that is what our basic aim is. So this particular knots in most means the first knot that you are putting in should always be a self-locking knot, and the end of it as a self-locking knot. So what you are achieving it, one single suture in the whole of this facial closure, and that is mildly stretchable. And if at all there is going to be stretch, it's going to be uniformly distributed all through the distance. And that is why it is never at one point, it is throughout the suture and throughout the wound length that the force is being distributed. And that is why it is always good to use a one single suture with less knots. And that is why it is all research oriented, that 5 to 10% is the decrease in the tensile strength. This will be going in on our side also, one who can practice is. And if you notice, this is what they are trying to do in the first one. This is self-locking the anchoring knot, because the first one cannot be the Aberdeen's, so you close it. Aberdeen's is always the closure knot, but the initiation, the self-locking knot that you are doing. So these are the two sutures. One of them is the continuity, other one is the smaller one. Between the two fingers, we give in 3 rotations, and then we try to hold the loose end of it and pull it. It looks to be more tedious, but once you start practicing it, it does pay you off. Because what has been seen is, with this, the amount of stretchability in the wound is much better at the end of it. Because this is a single one, and that is what goes on to the intact. This is what is left out, and pulling it on to one thread, and it slips onto the intact fascia. And once it does, then again you can go in only in the facial closures. I am reiterating the fact, only use the fascia. Do not try to move the muscle fibers away with your opposite hand. And this is what we do. Usually the end mass closure hota hai, this is what we try to do. And if you notice, the suture is passing through couple of muscle fibers. But this couple of my muscle fibers is more than sufficient to give in multiple sites of breeding sites for all the bacteria. Plus, it is something which is causing more amount of damage to your suture line, not only causing loosening of the sutures, it is also causing infection as well. That is why never ever take, it will take a bit more of time in picking up anterior and posterior rectus sheath separately, moving your wrist to maneuver your needle to take it out, again maybe in 2 places onto one side, but at least it is going to be more beneficial for the patient and for your outcomes as well. ये आम तौर पर when we do it at least 1 centimeter की बड़े बड़े bite ले लो, सब ठीक हो जाएगा. But it is not बड़े बड़े bite, it is meticulous closure. If you notice, plastic surgeons, once they suture it, there is almost no scar. But the same thing once we do, there is lot of scarring. for the simple reasons they are doing it very close. If we have a scar out here, means a wound out here, we will take only 4. They will take maybe 16. And that 16 will be having less amount of scarring, but our force will definitely give lot of scarring. Anyway, fair enough. So that is always remember, it is not how big bites you are doing, how meticulously you are placing your bites, that is what is more important. And you will see in the next one. This is what we are trying to do. Only 5:5 ka ratio. Right? What we say, 1 centimeter deep, 1 centimeter far off, shun that, have 5:5, 5 millimeters far off. Maybe it is saying it is double the amount of suturing, but definitely it is going to be much better. And the reason being, you must have seen वो मेलों में वो कील के ऊपर लोग लेटते थे, कील का एक बेड बनाते थे और उसके ऊपर लेट जाते थे, and they used to say हमें कुछ नहीं होता. वहीं पे सिर्फ 2 कील लगाओ तो वो नहीं लेटेंगे, बट जब कील का अच्छा सा बेड बना होगा तो they can lie down. The reason being, the whole of everything is being distributed, and that distribution of the force, the dynamic force which the patient is bound to happen in the post-operative period while cuffing, while being mobilized, is going to strengthen that single suture what you are placing. And that's why it becomes very important to go only 5 millimeters away from your incision line, and every suture, every needle prick is just 5 millimeters from the previous one. If you try to follow that, it is going to give you much, much, much better results. ठीक है ना सर? एक बार लेट के देखेंगे. भीष्म पितामह शायद इसीलिए इतने साल तक रहे, तब तक महाभारत ही हुई थी ना. हाँ, जब तक वो होती रही तब तक he was alive, maybe because he was lying comfortably. Had he been only on one, he would have gone, but because there were many, so he was more comfortable lying down. Answer this might look more tedious, but it is more effective as far as strength is concerned. As far as scarring is concerned, the second one is going to be more effective. So it is not the number of sutures. When I say number, means the caliber of the sutures. It is the suture and also the technique with which you are trying to apply in your particular case. Because this has already been proven that if you are going in for smaller stretches at regular intervals, it is going to provide you much better strength. This is what we are looking at. The first one is something which we all do, jaldi closure karna hai. But jaldi mein practice karni hai, to meticulous wali practice karenge, to that is going to bear much better fruits than the first one. More amount of force will be required with this, and less amount of distribution will be this in the larger one. But if you utilize the smaller one, that is going to be better flexible, and flexible means your patient compliant in the post-op is going to be better. And this is, we are ending it with an Aberdeen's knot. So now the whole suture is one continuous suture, and that is going to be more dynamic than ever. And once we do that, you always try to bury this with one more continuous suture. मुझे लगा मैं अपने ऊपर चिल्ला रहा हूं. In regard to this, we did talk about in regard to the plus sutures, that if we are utilizing, then usually what happens in emergencies, we always get what is cheaper for the patient. But maybe time has come in all the institutes that we should always go in for what is better for the patients, because less skilled individuals, if I use that term, don't take it derogatory, less skilled individuals, more training is being done in emergency setups. So we need better equipments, better sutures for at that point of time rather than only in the elective surgeries. That is what I always bat for. And that is why if we have better sutures while doing emergency cases in which chances of SSIs are much higher than electives, maybe we are able to salvage SSIs or minimize these complications. And that is why all the plus sutures, it's not just about J&J, yes it is J&J because I am being sponsored by them. So that's why let's come to the recapitulating that you are supposed to understand the anatomy part of the abdominal wall. Very important. Learn to identify the fascia, both anterior as well as the posterior. Ensure that it is not mandatory to take a big needle with a big suture. A normal needle with a normal suture is also as good as till the time you are poking it at the right place. That is what is the most important. Follow the thread. Do not cause something known as strangulating effect on the tissues. It is more of good approximation only as far as abdomen is concerned. 5 to 7, the rule of 5:5 is the best one rather than 1:1, which we used to follow in our times. And preferably a delayed or a non-absorbable but with a lower caliber, that is going to be better off. We will be talking of the barbed suture because we all have been doing it in our minimal access surgeries, but follow a particular suture, the one which is there that you always need one assistant. Maybe if you use a barbed suture, that follow a suture, it is going to be much less. Because this is what is meant by the barbed suture. And if you notice, the major difference in this particular diagram is this is the suture strand and this is the barbed which has been created out of this. This is the usual thing, but what J&J says that it is cut out from one of this as a complete one. Means the tensile strength of the whole suture is better than the other one with the same caliber. The reason being, this is the caliber, but this has been cut out from it. So finally the caliber is going to remain this one. And that is why the tensile strength decreases. While in J&J sutures, this is outside one only. So this, the whole caliber remains the same, and so the tensile strength is better than others. So you have to understand the mechanism of the barbed sutures, how do they function, what do they look like, and where should not be utilized. Where to utilize is n number, where not to be utilized, that is important. Because this is, if you see this, this is the strand is looking good, and on the sides the barbed as if they have been placed separately. So it has been cut out from one particular place. That is why it looks like this, and it definitely eliminates the knots, because at the end of it you all must have seen, at least if not used, you must have seen what the barbed sutures look like. Either they can have a small hole or a loop or a pledget sort of a thing which maintains the last part of it. And it has been seen that because of this, because we are putting in less number of knots, the chances of infection, the bacterial colonization within those knots is going to be much minimized, and that's why it is better one as far as decreasing SSI is concerned. And this is the one in which last one we have a round thing or a loop in which the needle can be passed and it remains over there. The only thing is it does have a mild dragging effect. So you are supposed to ensure that that is supposed to be taken care in what structures you are passing it through. And that is the pledget which comes in over there. And that this second part is being utilized to secure further, so that with further more stress it should not go in, especially in a lean and thin or a frail patient in which the fascia might be overshadowed, and if you pull it hard it might go in. So that is securing that pledget, and then we can go in with our good speed. So even while going at a good speed, if you notice, he is just taking bites only through whites. He is not taking the bites through the reds, and red means the muscle. So meticulous closure is supposed to be practiced at all the times. At the end, you can simply, rather than putting an Aberdeen's knot, you can go a centimeter beyond the incision line and simply bury. So that is the best part. So decreasing the number of knots means decreasing the colonized bacteria out there. Thank you all. If there are any queries, I'm more than welcome, please. Yeah, please. if possible, it is always, because even if you try it, if I get a sample inside, I might even try it. The whole one, we are keeping it, and suppose it is a single suture. So remember, once we have placed, and we have placed one sliding knot out here, one sliding knot out here. Once we put in a sliding knot, means let's say the amount of the pressure generated in the mid of that suture line is going to be max. So what will happen? The mid part is going to be pulled. Once it is going to be pulled, it will tighten up onto this side, it will tighten up onto this side, so it is going to provide us more of a hinging mechanism. But once you are using multiple interrupted sutures, all the knots, all through, everything integrity is equally important, and you might miss out on. And suppose you have not been able to do that, so one, the number of knots are going to be n number of knots. Every knot's integrity becomes highly important, and that's why suppose one knot is missing, then the chances of having the burden on to the next knots increases. So that is the difference between a continuous versus your interrupted knots. So that is one of the things, plus everything, every knot is supposed to be buried. If the subcutaneous fat is less and you leave multiple knots out there, even then the chances of infection or poking into the skin will be more. So I would prefer that it should always be a continuous rather than interrupted. You can go in for something known as a delayed primary skin closure, but the facial closure, this provides us a better strength. And the reason is because we are having hinges on both the sides, and that too in a continuous fashion.
Sir, so for example, in the emergent setting, we use loop PDS or Proline.
Loop PDS, I would say no, for the simple reason that needle is too big to pierce. That is the main thing. Remember, it is not the size of the suture which holds the integrity. The same thing can be done with even one number or 1 0 also, rather than loop nylon which comes as a 0 1, because it is not the suture, the needle itself having two sutures swaged together, the needle is really big one. So I would say that the loop nylon does not added offer unless and until you really want to play with your strength and do a tug of war with the muscles. Otherwise it doesn't serve extra purpose as far as the integrity is concerned in the long run.
Sir, you spoke about barbed suture. So is it preferable to use the Proline suture?
The only thing is, remember, if possible, it is the PDS is one of the best ones, because PDS does resist and it does serve the purpose. Remember, if the patient's abdominal wall is thin, especially the subcutaneous part, and if you use a non-absorbable suture, we have seen that the end part of which we cut, that at times pokes out. And who is going to remove? Suppose we have put in a continuous suture and it reaches to somebody else, he will simply take it, pull it upwards and cut. So you never know what is the place where the person is going to cut, and if it cuts onto the knot, the whole of the suture is going to be compromised. So that's why we should always bury the knots inside. So if barbs are, the only thing is, usually the barbed sutures are not available in emergency settings. It is not the cost is something like this. The only thing is, still what used to be practiced 20 years back, that is still being practiced in spite of having these kind of advents or these kind of things. So we just need to push around with the system and things will be available.
So sir, for us, what would you recommend in our emergency setting? What can we use as
I am trying to push for PDS.
A single loop PDS.
Single loop PDS. And preferably a barbed one, that is going to be better. So that number of knots can be reduced. Simple one is, number of knots are supposed to be reduced. That's all.
Sir, and with regards to SSI, suppose we are closing the rectus layers, and a lot of the times, sir, we witness that the inner rectus sheath that is not visible, we can only find the outer sheath. So, sir, so should we just suture the outer sheath? As you said, don't take any muscle, which is
definitely
the dictum.
not take any muscle, definitely.
So, sir, is the anti-rectus sheath enough to hold the abdominal wall?
Remember again one thing. What happens then? The meticulous closure of anti-rectus sheath becomes of the prime importance. The reason being, if you go 1-1, So usually what happens in most of the laparotomies, at least if it is not a previously badly infected or a redo surgery, you do find posterior rectus sheath with the peritoneum over there. The only thing is good visualization and good lighting and your calmness rather than spending time कि अगला केस लगाना है. That is the main thing. थक चुके हैं, अरे बस निपटाओ, तू क्लोजर कर ले, कल पार्टी दे देना, तू क्लोजर कर ले. तू क्लोजर तो कर ले, बट वो क्लोजर बाद में हमारा हो जाएगा. So my bottom line is, whatever teach, it's not something that they are not supposed to be given surgeries. They are supposed to be given, but teach them meticulously. If you teach them meticulously, your outcome being one of the main surgeons is going to be better. So even if you give time, it has be bound to be found. उसमें मेहनत 2 बार करनी पड़ेगी. You will be taking out one, trying to find, push the muscle behind with the back of the needle, and then take a bite. So it is going to be double suturing onto one side. That is what it costs time.
Yes, sir. And one final question,
Yeah.
sir. In our textbooks, it's written that on a case-by-case basis, we can decide whether the primary closure of the skin has to be done or not.
Actually, we are running a little
On a case-by-case basis.
That has to be as per the case. If it is a badly infected wound, it is always better to close the rectus, put in a betadine gauge and do a delayed primary closure rather than at the same time.
Yes, sir.
Thank you for overshooting.
Thank you so much,
Thank
sir.
you.
I would now like to request Dr. Amit Chaudhary from the Department of Vascular Surgery, KGMU, to take the stage and deliver an enlightening talk on deep venous thrombosis. We welcome you, sir.
Welcome.
ये green next one. Okay. I will be teaching deep vein thrombosis. So basically, DVT is a part of broader term known as venous thromboembolism. So what is VTE? VTE consists of deep vein thrombosis and pulmonary embolism. So it is a short lecture. So I will finish it off in 10-15 minutes. So these its guidelines are from ESVS, European Society of Vascular Surgery. So you all have heard the Varicose triad. So for triad, there should be stasis or trauma or endothelial damage or hypercoagulability. So that what can lead to the formation of thrombus. So what Rudolf Virchow said, the detachment of larger or smaller fragments from the end of the softening thrombus, which are carried along by the current of blood and driven into remote vessels. This gives rise to the very frequent process on which I have bestowed the name of embolia. Okay. So basically the disease burden, actually this data is from mostly from European countries, but it is same worldwide actually. It is more in India actually. So estimated incidence of first episode is around 50 to 100 per lakh population, and approximately 2/3 of the cases of VTE are DVT. VT means venous thromboembolism. Okay. So 85 to 90% occurring in the lower extremities, and out of that 1/3 are pulmonary embolism. About 1/3 of all cases of PE means pulmonary embolism are fatal, and cancer is one of the many disease state associated with the increased risk of thromboembolic diseases. So how it is relevant for surgery? So DVT can be considered for the first cause of avoidable in hospital mortality or morbidity. So because it is always overlooked, किसी के पैरों में सूजन हुआ कुछ हुआ तो पहला चीज DVT नहीं आता है, लोग सोचते हैं कुछ सेलुलाइटिस हो गया, कोई दिक्कत हो गई, परेशानी हो गया, and we ignore, patient भी ignore कर देता है basically. So it can also lead to post thrombotic PTS as a chronic complication which has and important socio-economic impact. So classification, अगर आपके पास कोई short notes या long note आता है तो आप पहले क्या लिखोगे? DVT is classified as proximal and distal. Proximal means involves the femoral या उसके ऊपर की vessels, femoral and popliteal and above that, okay. And distal is when it involves the deep infrapatellar veins. Actually, proximal DVT has the greatest potential for embolism. And etiologically, DVT can be etiologically के हिसाब से DVT can be classified as provoked or unprovoked. Provoked means कोई cause रहा है, trauma हुआ, accident हुआ, कोई surgery हुई, that is provoked. Unprovoked means अपने आप से हो गया, कोई cause नहीं मिला, अगर आपने सर्च किया कोई cause नहीं मिला, then it is called as unprovoked. So these are etiology, all are important, but जो red से mark किया वो है like immobilization longer than 3 days, major surgery in previous 4 weeks, cancer. कैंसर की बात इसलिए कर रहे हैं कि पहले लोगों को पता नहीं था, बट इट इज़ वन ऑफ द मेजर कॉजेज दीज डेज, स्पेशली इन एल्डरली. कैंसर, प्रीवियस डीवीटी की हिस्ट्री हो, स्ट्रोक, मल्टीपल ट्रॉमा और स्पाइनल कॉर्ड इंजुरी, लोअर एक्सट्रीमिटी फ्रैक्चर्स एंड अदर थिंग्स. प्रेजेंटेशन, एज मैनी एज 46% पेशेंट प्रेजेंट विथ नेगेटिव वेनोग्राम्स. अगर आप पेशेंट आता है, आप इससे वेनोग्राम्स कराते हैं, केस डीवीटी का, स्टिल वेनोग्राम में क्या है उसका प्रेजेंटेशन नहीं आ रहा है, ओके. एंड आउट ऑफ दैट, एंड एज मैनी एज 20 to 50% ऑफ दोज इमेज डॉक्यूमेंटेड वेनस थ्रोम्बोसिस लैक स्पेसिफिक सिम्टम्स. पता लगा आप जो है अल्ट्रासाउंड कर रहे हैं, बट उसमें जो है डीवीटी आ रहा है, बट पेशेंट को कोई पेन नहीं है, कोई सिम्टम्स नहीं आ रहे हैं उसको. सो दीज आर होमन साइंस, अदर साइंस आर देयर. नाउ दीज डेज दे आर वेरी लेस रिलेवेंट, ओके. सो हिस्ट्री इज वेरी इंपॉर्टेंट. लुक फॉर द प्री डिस्पोजिंग फैक्टर्स, पास्ट और प्रेजेंट. Any asymmetric swelling in the lower extremity should be considered as DVT until the diagnostic evaluation is completed. So this should be the rectum. So presentation. So clinical signs of pulmonary embolism are non-specific. I am talking about embolism. So already that clot has gone to the lungs, okay. Such as dyspnea, chest pain, hemoptysis, and syncope or pre-syncopal attack. Maybe or patient may be asymptomatic and discovered incidentally. Syncope appears to be present in approximately 17% of cases and is associated with a high prevalence of hemodynamic instability and right ventricular failure. P with hemodynamic instability is infrequent, but it may be suggestive of massive impairment of the pulmonary circulation. Risk. If a DVT is provoked means some cause was there, okay, by a major transient risk factor. Transient means some trauma is there, so it is trauma is for a short duration, so it is known as transient risk factor, such as trauma or surgery like pregnancy, puparium, estrogen therapy. So there is a very low risk of recurrence when anticoagulation is stopped, provided the risk factor is no longer present, okay. Conversely, when DVT is known to be provoked by a persistent progressive risk factor like malignancy. So patient को मान लो किसी को CA cervix है, उसकी सिकाई हो रही, सिकाई मीन्स रेडिएशन हो रहा है, तो ऑलरेडी उसको डैमेज हो चुका है पेल्विस में, रिकरेंट रहेगा या परसिस्टेंट उसका डीवीटी मेंटेन बना रहेगा बेसिकली. सो दैट इज व्हाट आई एम सेइंग. द रिस्क ऑफ रिकरेंस इज सिग्निफिकेंटली हायर इन द सेम कंडीशंस. Little bit I will tell you about classes of the classes I will tell you. So for patient with unprovoked deep vein thrombosis, clinical examination and sex specific cancer screening as opposed to routine extensive screening for occult malignancy is recommended. So that is a class 1 indication. Various scores are there like Wells score, Caprini score, okay. Like Wells score, the Wells DVT score, so which categorizes the pre-test probability scores, all that is there. So other thing is D-dimer. So in your clinical settings, patients come with the they have reports of D-dimer, everything is there. But as a surgery resident, we should not go for the D-dimer first. First thing is our ultrasound examination. Duplex examination is there. That is the first and foremost thing. That is the gold standard. Okay. So what is D-dimer? The quantitative D-dimer assay based on rapid ELISA test has a high diagnostic sensitivity. तो sensitivity इसकी close to 95% है, but इसकी specificity कितनी है? 40% है. So that is not a good test. Okay. So duplex scan. So सोनोग्राफी में हमें जो है acute, अगर acute कब कहते हैं? If हिस्ट्री या उसका जो है क्लॉट लेस देन 2 वीक्स ड्यूरेशन का है, सब एक्यूट 2 weeks to 6 months को बोलते हैं, एंड क्रोनिक इज मोर देन 6 months ओल्ड. So classes or recommendation, this is very important, so you should. So class 1 recommendation is evidence and or general agreement that a given treatment or procedure is beneficial, useful and effective. So that is what we say, it is a class 1. Class 2 is conflicting evidence and or divergence of opinion about the usefulness or efficacy of given treatment or procedure. 2A 2B इसका होता है, 2A मतलब in favor of usefulness होता है, 2B होता है कि less well established, और class 3 मतलब not useful या some case may be harmful also. So approach. So I will talk about class 1 only. When deep vein thrombosis is suspected, a clinical assessment of the pre-test probability is recommended as a part of diagnostic process. So that what is known as class 1 indication. And for patient with suspected deep vein thrombosis requiring imaging, ultrasound is recommended as the first modality. So this is also a class 1 recommendation. Then for most patient with deep vein thrombosis, outpatient management is recommended. So that is also a class 1. So no need to admit unless until there is some complication is there. थेरेपेटिक एंटीकोगुलेशन. सो 3 फेजेस की बात करते हैं हम लोग. शुरू में पेशेंट आया, अगर आपने डायग्नोज किया, सो दैट इज द इनिशियल, दैट इज नोन एज अप टू 10 days. दूसरा होता है प्रिंसिपल, इट इज अप टू फर्स्ट 3 months एंड द एक्सटेंडेड इज बियॉन्ड 3 months. सो फर्स्ट में क्या होता है, हमारा एम क्या है, एम ऑफ रैपिडली इंस्टिगेटिंग एंटीकोगुलेशन थेरेपी टू द प्रिवेंट प्रोपोगेशन ऑफ डीवीटी एंड पल्मोनरी एम्बोलिज्म. सो ये हमारा इनिशियल फेज में आएगा. दूसरा होता है प्रिंसिपल फेज, जो फर्स्ट 3 months का होता है, टू मेंटेन therapeutic levels of anticoagulation to prevent propagation of DVT and reduce the risk of early recurrent VTE. फिर extended में क्या होता है, an extended treatment phase beyond 3 months with no scheduled stop date with a specific aim of reducing the long term risk of recurrent VTE. So anticoagulants में क्या क्या हम लोग यूज करते हैं बेसिकली. सो पहला होता है indirect anticoagulants like heparins, okay, or fondaparinux require the presence of antithrombin for inhibiting factor 2A and factor 10A, while direct anticoagulants act without the requirement of any cofactors. Vitamin K antagonists such as warfarin are administered orally and inhibit the gamma carboxylation of coagulation factors factor 2, 7, 9 and 10, a modification that is necessary for their functional activity. एक और पॉइंट है, हम लोग जो है कोई भी ट्रीटमेंट शुरू करते हैं तो पहले हेपरिन भी स्टार्ट करते हैं, प्लस स्टार्ट करते हैं क्या चीज़, एस्ट्रॉम स्टार्ट करते हैं. तो इसका कारण क्या है, कारण ये है कि एज द हाफ लाइफ ऑफ प्रोटीन सी इज रिलेटिवली शॉर्ट कंपेयर्ड विद द क्लॉटिंग फैक्टर्स, देयर इज ए ट्रांजिएंट हाइपर कोगुलेबल शिफ्ट ड्यूरिंग द इनिशिएशन ऑफ विटामिन के एंटागोनिस्ट. दैट्स वाई अगर आप एस्ट्रॉम शुरू करते हैं तो शुरुआत में हो सकता है थ्रोम्बोसिस का चांस बढ़ जाता है. दैट्स वाई साथ में हम जो हेपरिन को स्टार्ट करते हैं साथ में. Consequently, it is essential that effective overlapping anticoagulation is ensured with heparins or fondaparinux during the initiation of vitamin K antagonists. Parenteral anticoagulation should only be discontinued when it has been given for a minimum of 5 days and a therapeutic international normalized ratio of INR of more than 2 is achieved. Okay. दूसरा आता है unfractionated heparin की बात आती है. Is currently only used in special clinical situations such as severe renal insufficiency, patient hemodialysis पे है या pending interventions है. यहाँ पे हमें मेंटेन कितना करना है, EBTT अराउंड 1.5 to 2.5 हमारा टारगेट है हमारा. फिर आते हैं लो मॉलिक्यूलर वेट हेपरिन जो हम कॉमनली यूज करते हैं. सो इनके फायदे क्या हैं, दे आर गिवन सबक्यूटेनियसली, डोज एडजस्टेड फॉर पेशेंट बॉडी वेट एंड वंस और ट्वाइस डेली इसका होता है. दूसरा आता है fondaparinux, ये वंस डेली देते हैं. fondaparinux इज गिवन सबक्यूटेनियसली एट ए स्टैंडर्ड ट्रीटमेंट डोज ऑफ 7.5 mg OD, while patients weighing less than 50 kg receive 5 mg and those weighing more than 100 kg receive 10 mg. Okay. These are directly acting oral anticoagulant, DOAC है, NOAC, NOAC बोलते हैं इसको. So one of it is dabigatran. So oral dose का BD 150 mg BD होता है and started after at least 5 days of initial parenteral anticoagulation. दूसरा होता है एडॉक्सामैन, इंडिया में नहीं अवेलेबल है. तीसरा एपिक्सामैन, मोस्ट कॉमनली हम लोग वेस्कुलर सर्जरी में एपिक्सामैन ही यूज़ करते हैं. सो स्टार्टेड तो 2 चीज़ कर सकते हैं, या तो आप शुरुआत में एक्टिव फेज में यू कैन स्टार्ट विद हेपरिन or you can start with the apixaban itself only. अगर आपको apixaban only treatment करना है तो आपको क्या करना है 10 mg BD 7 days देना पहले acute phase में, followed by standard treatment dose of 5 mg BD देना है इसको. इसमें फायदा क्या है आपका, द नो डोज एडजस्टमेंट इज परफॉर्म्ड इन DVT ट्रीटमेंट इन द प्रेजेंस ऑफ रीनल इंसफिशियंसी एंड वेरी सीवियर रीनल फेलियर में अगर क्रिएटिनिन क्लियरेंस लेस देन 15 ml पर मिनट है तभी इसका जो है डोज जो है एडजस्टमेंट करते हैं इसका. दूसरा है रिवॉक्साबेन. So second common is rivaroxaban. It is started without initial parenteral therapy but requires a higher dose of 15 mg BD for 3 weeks followed by standard dose of 20 mg OD. इसका भी adjustment is required for patient with creatinine clearance of 15 to 49 ml per minute के लिए. So मतलब अगर moderate renal failure में तो नहीं देंगे इसको. Therapeutic approach में so introduction of DOAC or NOAC and NOAC are recommended first line treatment for DVT as further facilitated outpatient treatment. So पहले था कि आप इंजेक्शन देना पड़ रहा है पेशेंट को, IV देना पड़ रहा है या सबक्यूटेनियस देना पड़ रहा है तो आपको पेशेंट को एडमिट करना पड़ रहा है. बट अभी क्या है, अगर आप डायरेक्टली ओरल पे करते हैं सो पेशेंट अपना घर से आएगा OPD बेसिस पे ट्रीट होके जा सकता है आराम से. तो कंडीशंस लेकिन इसका कॉन्ट्राइंडिकेशन क्या है इसके होम ट्रीटमेंट के. Conditions excluded on home treatment include when to admit is massive or recurrent DVT, pulmonary embolism or a high probability of developing PE, पेशेंट प्रेग्नेंट है या कॉन्ट्राइंडिकेशन है एंटीकोगुलेशन के लिए या अदर कोमॉर्बिडिटीज़ हैं रिक्वायरिंग द हॉस्पिटलाइजेशन या पेशेंट बहुत दूर रहता हो तो. थेरेपेटिक कंसिडरेशन में और आता है कि फॉर पेशेंट विद काफ डीप वेन थ्रोम्बोसिस रिक्वायरिंग एंटीकोगुलेशन डायरेक्ट ओरल एंटीकोगुलेंट्स आर रिकमेंडेड ओवर low molecular weight heparin followed by vitamin K antagonist. So this is also a class 1 recommendation. For patient with symptomatic cough deep thrombosis requiring anticoagulant treatment, 3 months of therapy is recommended over shorter duration. So this is also a class 1 indication. Class 1 इसलिए बता रहा हूँ क्योंकि बेसिकली आपसे बाद में यही पूछा जाएगा. Being a specialist, being a doctor, आपसे उम्मीद की जाती है कि आप recommendation you should know. So that's what I am telling. For patient with symptomatic cough deep thrombosis not receiving anticoagulation, clinical reassessment and repeat whole leg ultrasound after 1 week is recommended. So this is also a class 1 indication. इसमें बात आती है कैंसर की. For patient with cancer associated with deep vein thrombosis, a low molecular weight heparin is recommended for initial and principal phase. That is also a class 1. For patient with active cancer associated with deep vein thrombosis, switching from a low molecular weight heparin to an oral anticoagulant is recommended after 3 to 6 months only of treatment of extended treatment. This is also class 1. For patients with deep vein thrombosis and high risk thrombophilia, example patient of antiphospholipid antibody syndrome, full dose extended anticoagulation therapy is recommended with periodic re-evaluation. That is a class 1. Duration is for patient with provoked proximal deep vein thrombosis with a major transient risk factor, 3 months of anticoagulation treatment is recommended. That is also class 1. Patient with provoked proximal deep thrombosis treatment with direct oral anticoagulant is recommended over a vitamin K for the principal treatment phase. That is also class 1 recommendation. For patient with unprovoked proximal deep vein thrombosis, treatment with a direct oral anticoagulant is recommended over treatment with low molecular weight heparin followed by vitamin K. So, for patient with unprovoked deep vein thrombosis, reassessment of bleeding risk is recommended before continuing the anticoagulation beyond 3 months. It is also class 1. And for patient with unprovoked proximal deep vein thrombosis who are at low or moderate bleeding risk, extended anticoagulation beyond 3 months with periodic re-evaluation is recommended. That is also a class 1. For patient with a second or subsequent unprovoked deep vein thrombosis, extended anticoagulation therapy beyond 3 months is recommended. For patient with proximal deep vein thrombosis who have contraindication to anticoagulation during the initial or principal treatment phase, temporary inferior vena cava filter insertion is recommended. That is class 1. So for IVC insertion, I will say now IVC insertion is not the first mode of treatment. IVC insertion is only done where there is imminent bleeding is there because of anticoagulation. Anticoagulation is 100% contraindication and not much life is left for the patient. and that also after 100 days you are going to remove the IVC filter, then only you have to insert the IVC filter. Thrombus extraction strategies. So one is surgical thrombectomy, it's not done. Main is catheter directed thrombolysis, that is CDT, and from pharmacological catheter directed thrombolysis. For patient with deep vein thrombosis treated by early thrombus removal with or without stenting, it is recommended that the duration of anticoagulation should be at least as long as if patients were treated by anticoagulation alone. So इसका मतलब ये हुआ कि अगर आप ये सर्जिकली निकाल भी रहे हैं तो भी आपको एंटीकोगुलेशन चलाना ही पड़ेगा. So same चीज, IVC filter insertion, very limited indication are there. Generally accepted consensus recommendation for IVC filter is major bleeding on full dose anticoagulation, major contraindication to full dose anticoagulation, or new onset of acute pulmonary embolism despite well documented full dose anticoagulation. Okay, thank you. Yeah. Any questions? Yeah, ask.
For DVT is 0.1 mg per kg low molecular weight heparin we can give. But coming to VT versus DVT, venous thromboembolism, the treatment for that becomes a double of that, I think, that is 0.1 mg per kg BD. So sir,
see nowadays if it is oral anticoagulation, so there is a fixed dose is there. If you are using the Apixa, for example Apixaban, so it is a fixed thing. Either you can start with the 2.5 mg or 5 mg. 5 is for the treatment, the BD dose is there, and 2.5 mg is BD you can for the prophylaxis.
sir, you said parenteral treatment.
Parenteral is for the treatment, it is not for the prophylaxis.
Yes,
okay.
Sir.
If you are thinking the post op surgery, after surgery you are thinking there is chances, then you can give for 3 days, 5 days you can give. Unless the patient is not mobilized, you can keep giving.
Clexane, no, sir?
Yes, yes, Clexane. Yes.
Thank you, sir.
Any more questions?
Thank you, sir.
Okay.
May I request Professor J.K. Kushwaha, sir, to kindly step on stage and felicitate Dr. Amit Chaudhary, sir.
Thank you, sir.
That was the last lecture for the day. Now we have a bowel anastomosis workshop in the skills lab. So kindly head on there for an enlightening experience. Thank you.